Oh, Nurbayak, you're one of the speakers.
Hello. Hello.
Hi, Nurbayak. How you doing?
Yeah, nice. I am speaker. How I can share my PPT? Can you hear me?
Yes, I can hear you. Can you hear me?
Yes, yes. And how I can share my PPT?
Okay. How can you share your screen? Nobody taught you.
Okay.
Okay. I can't see your picture. Where's your picture? You're not. Nurbayak, do you have your picture, Nurbayak?
Okay. I will send now.
Yeah, it's not on. Greetings, Vladimir. Okay, Nurbayak, you want to know how to screen share, right?
Yes, yes. I'm going to do, but please wait some.
Yeah. Okay. Okay.
Okay. Okay.
Let me know when you're ready. Okay. Hi, everybody. I'm Dr. John Bennett from Miami Beach. I'm the guy in the background in this webcast. And hopefully it'll work technically okay. Good afternoon, Adam. You know, I sent the information to Selfie about this webcast. Did you get it from her, Adam? From Selfie?
Good afternoon, sir.
Oh, yeah. Oh, good. You got the news from Selfie?
Check, sir.
You're Adam from Indonesia, Adam.
Yes, sir. I'm from Indonesia, sir.
Welcome, welcome.
Thank you so much.
Okay, we've got to get Nurbayak. You want to learn how to screen share, right? Man, we're going to have a lot of people at this conference. I'm not used to. Hey, holy Julian, how you doing?
Hello, Dr. John. Good evening.
Man,
good
you
morning.
like these webcasts.
Okay. Yeah. Okay,
It's
thank
great.
you.
Yeah, welcome.
Right. Okay, thank you. Thank you.
A lot of names and faces I don't know, but you're all welcome. Welcome, Vladimir. Lagos, wow. Sunday salami. Lagos, Nigeria, that's great. Let's see, how many speakers we got here now? We've got okay, Nurbeck, okay. How you doing, Nurbeck? Okay, let me try to show you. You got to unmute, okay. You can hear me okay? Hello, Nurbeck? I can't hear you. You need to unmute Nurbeck. I don't know what's going on, but I can't hear you. Maybe your microphone's not on. Your camera's on, but I can't hear you, Nurbeck. I see your microphone on. Can you speak, Nurbeck? Speak now. It looks like your microphone's not on at all. Put music on, like put YouTube, put a video, audio sound, a song on. I doubt if you're hearing anything. Hello, can you hear me, Nurbeck Baban? Right, you can hear me, right? Okay, you need to turn your audio on. It's not on. I heard you before, but apparently I think you turned your volume down. I don't see any sound coming to your microphone. So either you're not connected or your volume's off on your microphone. I'm guessing. Everyone else can hear me, right?
Can hear you. Hello.
Yes.
Yeah,
Good
okay.
morning.
Thank you. Thank you,
Morning,
Mohammed.
Jordan time. Hi, how are you?
Good. How you doing?
I'm good. I'm good, thanks.
Good. Yeah, trying to get someone's mic to work. Can you hear me, Nurbeck?
I think he's still muted.
Yeah, no, he's not, he's unmuted, but there's a microphone on my
Yeah,
console that
you may need
shows
to
that he's
check his
not
headset.
getting any audio at all to his, let me try texting him.
It's not moving either, so I'm not sure whether it's internet con. Oh, it's moving. Okay, fine.
Hey, hi, I can hear you.
Yeah, hi.
Hi, I'm Dr.
Nice to
Ben. Are
see
you
you.
one of the speakers?
Yes, I'm one of the speaker.
Okay, welcome. I'm not sure of the order. I guess Sam will determine that. He should be coming shortly. Hello, Dr. Boban. Are you working on your mic? I can't hear you. And your microphone's not working. I think your audio's off completely because I don't see any input at all onto your microphone. Look, I can tell when sound is going in to a microphone, but when I don't see any sound at all coming from your mic, which I think means that your mic is off on your computer or the volume button's off. Could try those two. And I bet if you play music, you don't hear it on your laptop or whatever you got. Yeah, you're on mute now. I see you're on mute now. So unmute and connect your microphone, turn the volume button on. Yeah, I know. I can see your audio works fine and your video works fine. Your video is fine, but the audio is not on. You may need to reboot. You probably have some other programs open. Reboot your computer and come back.
Excuse me, Dr. Bennett, just ask him to unplug his phone, just use his, his speakers. Sometimes it
No,
probably in the
unplug his
headset.
what?
His headset, or his microphone.
Oh,
And
okay,
just
he
use the
has a
speakers.
headset. Okay, Nurbeck, can you unplug your headphones? Okay, try that. I know, I see you muted. Take your headphones off. Hello, Doc. How you
Good morning.
doing,
Absolutely fine, buddy.
Dr. Bennett?
Yes, sir.
Okay, and I guess you know the panel, the order of the speakers, correct?
Yes. Very much so.
Who's the first speaker? Because I think, okay. Who do you have there?
Just 1 second, sir.
Right.
I think we should wait for our chairman to give his welcome address.
Yeah, we got 8 minutes, so.
Yeah.
Sam better move his tail. Okay, Nurbek Baban, is he one of the first speakers?
Just 1 second.
I think I'm the first because my
First is, I
time
think,
is
Mohammed
8:35.
Assaus.
Mohammed Asous, yes,
Yes,
8:35
Dr.
Jordan
Mohammed is-
time, and yeah.
Dr. Mohammed is our first speaker.
Morning,
He is-
sir.
Good
Okay,
morning.
Nurbek, you got your sound working?
Not working.
Can you hear me?
Dr. Fadel.
Yes, who's this, Nurbek?
Yes.
Yes, this is Novak.
Oh, finally, we got your sound going.
Okay, thank you.
Okay, now listen, to screen share, you've got to go to the, are you listening there? Hello? Nurbek?
Yes. Yes. Can you hear me?
Yes, we can hear you. Okay, now put your face in the camera. Your face is off the camera there. Okay, now to screen share. Okay, you gotta, okay, put your PowerPoint on the screen. Like, get off this screen, put your PowerPoint up. Okay? There you go, perfect. You know, yeah, there you go, keep going. Beautiful. That's it. And you gotta make it bigger. Just figure it out. I'm sure you'll be
Bennett,
able
our
to
first
figure it out.
talk starts with Mohammed.
Yeah, it's not big enough there.
So can you see my PPT?
Yeah, we can see it, but you gotta make it bigger. You gotta make your main slide bigger. Do you see what I mean? It's pretty small.
Okay.
Unless you're used to presenting like that, I don't know. Are you used to presenting like that?
No.
No, okay, just play with it, play a little bit. Now you'll figure it out.
Yeah, our first talk will start with Dr. Mohammed Assaus. So, Mohammed,
Okay.
sir, I hope you're ready.
I'm ready, yes.
Yep.
Okay, I'll just introduce you, Doc, Malcolm, okay, and then you just take it over. Or I guess Sam's gonna speak first, right?
Sam's going to be the inaugural speaker.
Okay, then he just determine who goes next. He'll just, and then you guys kind of run it yourself.
I just send you the list again on your WhatsApp. So you
May I just share my screen for a second to make sure it works?
Yeah,
That's
sure,
okay,
go
yeah?
ahead.
do that.
Go ahead.
Please do that.
Can you see my screen?
So you want to try it again? Yeah, okay, yeah, I see your video works, okay. Now, you want to try the screen share again?
Okay.
I think you were going to try it too. Mohammed, only one person can try it at a time.
I think somebody has to stop sharing the screen for me to do it.
Hey, please go ahead and share your screen.
Okay, I'll do it again. No, I can't do it.
You can't do it?
Yeah, I'm clicking on the green button, share screen, but it's not letting me do it.
At the bottom will be a share screen button, green
I'm
button.
doing that. I'm doing that. I think somebody's sharing their screen. I think we can't share two screens at the same time.
No, nobody's out
All
so
right.
far.
Okay.
Go ahead, go for it.
Yep,
Okay,
you're
you
on.
can see.
Okay, good. Excellent. So I'll stop share.
Yeah, we're just waiting for
Yeah.
our
Yeah, sure.
host, our principal host.
So then I will try my share then, since everybody is having a go.
Yes, Dr. Paul. Yeah, you also try it out.
You see?
Yeah, you started your screen sharing, but we see nothing. Yeah,
Oh, I
now
see.
it's come on.
You can see now?
Yes, but you can make it bigger. At the bottom, there's a couple of options at the very
Sure,
bottom.
sure. I haven't clicked that. Now I'm full. So you can see full now?
Yes, perfect. That's exactly how it should be. Exactly.
Okay, great. So I will stop sharing now.
Yeah, that's exactly it.
Okay.
I think Dr. V. Zhang is the only person who is not on the board with us right now.
Sir, can I start testing my sharing?
Yeah, please test Dr. Caudal.
Thank you, sir.
Good morning to you.
Good morning, sir. Yeah, can you say?
Yes,
Yes, we
perfect.
can.
Perfect.
Wonderful.
Okay, thank you. I'm stopping now.
Okay.
We have 2 minutes to go.
We're definitely waiting for Sam, right?
Yep,
Okay, we'll just wait for him. Okay.
I'm waiting for the big boss to come on.
Okay, when he starts, when he comes, we'll start.
Yep. Nice to see all of you guys, yeah, and connect with all of you all. I've just pinged Dr. Morse, so I think he should be accessing right now. Dr. Bennett,
Yes. Yeah, I don't know why he says he can't get in. He registered and everything else. And he's,
he wants the link. Sam,
Link
send
is-
the link.
the link is all over the internet. Okay, let me get him. Let me get him another link.
Please, please, please.
Okay.
सार्थक करके patient admit.
Okay, I sent him the link.
Let us go some done imaging.
Oh, here's Sam. Here's Sam.
Good. Is he online?
Yes, he's coming in.
Hi,
Hey, Sam.
Good
how are
morning.
you? Good morning.
Okay, ready to start?
Yes,
Waiting
can
for
I
you.
share my
Straight-
screen?
Straighten your
Good morning,
picture
Mike.
up first, Sam. You're sideways.
I have logged in 10 minutes ago, but they didn't give me access.
Okay,
Okay.
you need to fix your screen.
Okay.
You're sideways there.
Okay,
Good morning, Dr. Hyun Sung Kim. Welcome. We
Nice
are
to meet
honored.
you. Good morning.
Good morning, Dr. Kim.
Nice to meet you all, Dr. Marcon and all, Dr. Bennett and all friends.
Yeah, I haven't seen you for a while, Dr. Kim.
And
Yes.
Dr. Marcy, your screen is still sideways.
Yeah, come on,
Okay.
Sam. Come, there you go. There you
Yeah,
go.
he did it, he did it.
Okay.
All right.
Good morning.
Okay.
Okay, are you ready to start, Sam?
Okay, can I share my screen?
Yeah, no, hold on, Sam. Let me introduce you first so people can see
Okay.
your face and then go to your screen, okay?
Okay,
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach, home of Neurosurgical TV. Today, we are honored with the presence of Samuel L. Morsi, a neurosurgeon who heads a group that's going to run a conference tonight on endoscopic spine surgery, and we'll let Sam take over. Welcome, Sam.
thank you, dear John. I will start sharing my screen now. Can you see my screen?
Yes, perfect, perfect.
Okay, I will start now. Greetings from Egypt. Dear colleagues, professors, and partners, thank you for accepting our invitation to share your experience with us about endoscopic spine surgery. In this Congress, in this Congress, which is a unique event that is never experienced before in the world, as we believe in the future of spine endoscopic surgery in the world, and also our speakers will change your concepts about this kind of intervention. This event introduced to you under patronage of Owens Academy and our partners, Endoscopic Spine Foundation India and Neurosurgical TV. Owens Academy is a pioneer in online neurological and spine education. Started our activities 4.5 years ago. 33 groups with most recent innovative content with total number of members more than 17,000 members. We made 2 previous physical meetings. First one was in Greece, 2018. The second one was in Amsterdam, Netherlands, 2019. We were planned to make our third meeting this year in Ireland, and it was prepared. I was prepared these 2 lectures for this event. Unfortunately, we have canceled this meeting because of COVID. So we started our online webinars. Till now, we made 3 webinars of different topics to start every one different webinars series. And we will continue this series continuously. I'd like to convey my deepest gratitude to these persons who made great efforts for last 2 months to prepare to you this magnificent and extraordinary program. Dr. Malcolm Bistonji, Dr. Anand, Dr. Anand Kevi, and Dr. John Bennett. Owens Academy, Endoscopic Spine Foundation India, and Neurosurgical TV hope that you will enjoy this Congress to the max. Thank you. Dear Dr. Malcolm, you can start, dear friend. Thank you. Dr. Malcolm.
Thank you. That was a wonderful talk. It was a wonderful talk by you, sir. I declare this World Congress open now. And I think without wasting much time and much ado, I request Dr. Mohammed Assaus to come online, start his screen sharing, and let us start with our first lecture on transforaminal endoscopic lumbar discectomy by Dr. Mohammed Assaus. Welcome, sir. Please start.
Thank you so much, Dr. Kistonji. Dr. Sami, thank you so much for the invitation. And I welcome you all. And I thank you so much for giving me the opportunity to share some knowledge in endoscopic surgery. I'm privileged to be part of this brilliant symposium, looking at the names who are taking part. I'm definitely humbled and privileged. Thank you so much. My passion for minimal invasive surgery started 11, 12 years ago, but I moved to full endoscopic surgery in the past 4 years. I'm sure the audience is probably part juniors and part more senior, so hopefully I have something for everybody in the course of the coming 15 minutes. This is my disclosure. Hopefully we're going to talk about indications and limitations. Note that I didn't say contraindication because I think the transforaminal approach is extremely robust. It certainly has limitations as any other approach. We're going to talk about the procedural steps for transforaminal endoscopic lumbar discectomy, focusing on the craniocaudal approach, which I think is safe and versatile, and in the way talk about some complications and how to manage them. We know from previous couple of years, 3 or 4 meta-analyses came out and all showed that actually endoscopic surgery, endoscopic discectomy does work. And when compared, like this paper from Albert Elfin group, when compared to tubular microdiscectomy and open microdiscectomy, the complication rates were actually less, in particular durotomy were less. in endoscopic surgery. And never mind actually the length of stay and return to work, because it doesn't matter if your patient goes home within 6 hours or 12 hours, but look at the VASO score in the leg and the back at 2 and 3 years follow-up, and in particular the ODI scores, and they were significantly better in the endoscopic group. So the indications for the transforaminal approach, I think most disc herniations can be taken out transforaminally. The issue is always focusing on L5-S1. In particular, if you have a cranially migrating disc at L5-S1, you may struggle with that. But in experienced hand, I think most disc herniation can be taken out. Certainly, bilateral herniations are prime indication for the endoscopic transforaminal approach. Recurrent disc herniations after posterior interlaminar surgery, again, I think is an excellent indication. And then you extend your indication of the transforaminal approach from discectomy to the all too common foraminal stenosis and the lateral recess stenosis. Limitations, again, high iliac crest. Most men L5-S1, the iliac crest might very well be in your way, especially if the fragment is cranially migrating. Very short foramen, again, makes an issue with reaming and the introduction of the cannula. And if the foramen is collapsed because of severe disc degeneration, you have to do foraminotomy, which again is very feasible with the endoscopic transforaminal approach. Low-lying exiting nerve root is an issue. And of course, if the fragment are dorsally embedded, you may have a problem getting those from the side with the transforaminal approach. But these are limitations. But again, as I said, in experienced hands, most of them can be done safely and effectively with the transforaminal approach. The advantages of the transforaminal approach, apart from the first few points that I mentioned, that is actually quite possible to do it under sedation with the awake anesthesia. This will have an impact in patients who suffer with significant comorbidities, elderly people, and morbidly obese patients. And again, it makes all this makes the transforaminal approach very feasible for ambulatory service as a day case when your patient goes home within a few hours after the surgery. So I'm moving to the cranial-caudal approach. It's a safe approach. It's an all-out technique. The idea is simply to dock your working cannula in the lateral recess. You stay out of the foramen, out of the disc all the time, and then you address the pathology where it is. So the concept is straightforward. You don't focus on the disc fragment. You rather focus on the compressed nerve root. So if this is a traversing nerve, nerve root problem, as indeed in this example, you just need to push your cannula medially into the canal, but you are still all out in the canal to take the herniated fragment, which is pressing on that S1 traversing nerve root. It gives you a safe bony landmark, which you can get very easily by going, at an oblique to the disc space rather than straight into the disc space. And the advantage with that is you are furthest away from the exiting nerve root, which is commonly compressed during the access. So in the example before that, even L5-S1, you can see, how far you are when you come in obliquely at the disc space, how far you are from the exiting nerve root. So the summary of the steps, for the juniors in the audience, are fairly straightforward. Decide your entry point of the needle, decide the landing point, and then you slightly ream the ventral part of the SAP to dock your cannula in the lateral recess. And I do that in every single case, regardless of the position and the location of the disc. So neither entry point, neither landing point, reaming of the SAP. And then you have to decide, is this a traversing nerve root problem? In which case, you just push in your cannula into the canal slightly, identify the traversing nerve root, and remove the sequestrum from the canal, whether it is at the disc level, central, cranially, or caudally migrating, or is this an exiting nerve root problem? And then you just basically rotate your cannula 90 degrees up and take it, pull it out a little bit, and then you'll be looking at the exiting nerve root. So the first three steps are common for all disc herniation, the same entry point, same landing point, same reaming process, and then you decide exiting root problem, is this a far lateral disc herniation, or foraminal stenosis for that matter, or if this is an intracanal problem, and then you identify the traversing nerve root in the recess, and that's exactly where you landed anyway. So this is what you need to do first. Decide the level, and if you're doing upper lumbar, usually 7-8 centimeters. L3-4, you are 10 centimeters from the midline, and L4-5, L5 is when you're between 12 and 13 centimeters. If your patient is obese, you probably get another centimeter. If he or she are very thin, you are probably short 1 centimeter. But I put this in a question mark. It doesn't really matter the target dislocation, because the approach to most disc herniation is exactly the same. So if I'm doing L4, L5, I decide this is a 12 centimeter. So I mark the midline and I put a line 12 centimeters. This is the first thing you need to do in every single case. And then you need to draw 2 lines, and they're very simple, to be honest. The first one is the AP line. This is just a 15-20 degrees line touching tangentially the upper border of the ipsilateral pedicle and the inferior border of the contralateral pedicle here. So upper border to the inferior border, this is your AP line, which is here. Patient head is here, the feet are here. And then you need the lateral line, which is the more important of the 2 lines here, as you can see. And this is just a 45 degrees line. You just need to touch the back border, the back upper border of the caudal vertebra. So this is L4-5 disc herniation. So I'm transecting the upper border of the L5. So this is my lateral line. And the 2 lines will intersect somewhere around your 12 centimeter line for L4, L5. So AP line and the lateral line, and they will meet at L4-5 at 12 centimeters. If this was an L3-4, I promise you, they will meet around 10 centimeters. And if you are upper lumbar level, they will meet somewhere here. And I do the same for every single case. So this is what you need to see. This is the landing point. So if you are actually in that position, a little bit taken off the SAP on the lateral, which again is the more important of the 2 lines, you will be around the medial border of the pedicle on the AP. So this is an L3, L4. So in that particular example, I took a 10 centimeter and both lines met at 10 centimeter, and this is my landing point. So this is the step-by-step. I'll go very briefly through this video. So you put the needle and then you exchange the wire basically. And then it's a matter of sequential dilators. And then you start reaming, and reaming with sharp end reamers. And it's very straightforward and very, very safe. All what you need is to take a little bit of that ventral aspect of the SAP. And for L4, L5, I'm going to play the video for the reaming here. So you ream until you reach or just past the medial pedicle wall for L4, L5. This is all what it is to reaming. The reaming is the idea of the reaming is to allow you to dock your cannula in the lateral recess to facilitate exposure of the traversing nerve root, because the traversing nerve root is easily identified in the lateral recess. So this is reaming, and you stop here at the medial pedicle wall or just past. Just a millimeter or 2 past it, nothing more than that. And this is what you see. So you've decided your entry point, you've decided your landing point, you docked your cannula in the lateral recess, and this is what you see. Every single case is the same. And if you are systematic, you know for a fact that you will be successful in most cases. And this is what you see. You need to identify the SAP. So this is L4, this is L5. This is exactly the view on this video here. So this is cranial, this is caudal, patient in a prone position. In this particular example, you need to identify the SAP and the pedicle, and very importantly, the posterior vertebral wall of the caudal vertebra, because that wall is really the difference or the mark between the canal, just dorsal to it, and the annulus and disc space ventral to it. So this is the video now. It's absolutely copy-paste of what you see on the left. So this is the SAP, and you will see this is the pedicle, and you can see the pedural fat pulsating here. So I'm identifying the posterior vertebral wall, having stained the disc with contrast and methylene blue. So this is disc space at 6 o'clock. And once you see the posterior vertebral wall, anything behind it is the disc herniation. There's no more to transforaminal discectomy than these 3 points. So entry point, landing point, identify SAP, pedicle, posterior vertebral wall, and you are looking at the disc herniation here. And anything that you push into the canal parallel to the posterior vertebral wall is safe. The root is not actually lying on the posterior vertebral wall. You can see where the root is here. It's starting actually to peak on us. So this is the traversing L5 nerve root, and this is the disc herniation. And you take the disc, and this is the day case under sedation if I do it under lateral position. So this is the end of the surgery, free and mobilized traversing nerve root. So I'm going to finish with a couple of examples to show you how robust the transforaminal approach. This is a high caudally migrating recurrent disc herniation in a young man who tried everything for the last 4 months with pain in the leg, but nothing worked. And you can see this is reaching all the way down to the level of the pedicle on the right side. So L4, L5, caudally migrating, and this is the video. Nothing has changed, same approach, but you know for a fact you can either go through the pedicle, which I don't do. I just basically drill 3-4 millimeters of the caudal pedicle to give me more access to go caudally with the flexible forceps. So drilling the pedicle, as you can see here. I'm going to speed this up. So, and once you do that, remember this is a revision case, so adhesions. And when I say revision after open surgery, I really mean open surgery. This guy had 10, 15 centimeters, incision for his first surgery in another country. And this obviously have a huge impact on the amount of adhesions that this patient will have in any further surgery. So again, that's the facet here. The pedicle is here. This is where the nerve root and the adhesions, and this is part of the disc herniation. And you work your arm, you drill down, and radio frequency, again, is your friend because it allows you to dissect, probe, feel, and again. And then once you've done the drilling, this is the fragment, obviously all stuck posteriorly, but then eventually comes out, huge 6 or 7 centimeter fragment. And that's a nerve root. Very small fragments attached to it. Doesn't really bother me because the root is free, pulsatile, and that's what you want to see. So this is what I meant by his previous surgery. This is the transforaminal approach. That's the total amount of the fragment. This is the huge 5 centimeter fragment that came out, as you can see here. And this is the pre-op MRI on the right, and this is what we have on the MRI post-op. The last case is a high compromise. All common if you've done enough fusions, you will see quite a few adjacent level disease. This was done somewhere else 6 or 7 years ago. Lovely lady, 74, and she has fusion from L2 to S1. And surprise, surprise, she had a T12, L1, L2 disc herniation and severe disc degeneration, as you can see, and sagittal imbalance as well. But she didn't want any major surgery. So the main problem with the lady was weakness in the right leg, and it was all lower motor neuron, nothing actually upper motor neuron, which indicated to me that probably it's L1, L2 the problem, not T12, L1. And indeed, looking at the MRI, this is L1, L2, high compromise of the canal, as you can see, with a huge central disc. And looking at T12, L1, the canal is not actually too bad. So, but given the fact that the symptoms and the signs were all actually lower motor neuron, I still did T12, L1, but I didn't think it was the problem. So again, same approach. The only advice for the ladies and gentlemen started in the upper lumbar and the lower thoracic, do not ream past the mid-pedicle wall, because the dura will be looking at you because the thick fatty dura there. So I'm going to finish with this video. So again, the foramen was absolutely included. So this is foraminotomy for the huge SAP, and then you start to make your way. So this is caudal, this is cranial. Identify the flavum and open the space. I'm going to speed this up a little bit. So it is a matter of identifying the nerve root. If you take one thing from this presentation, it is a discectomy surgery, but it's a nerve compression surgery. If you want to find the disc and make sure that you take it completely out, find the most important structure, which is not the disc, it's actually the nerve root. So you can already see, so this is the dura, everything is stuck here. This is a big disc herniation looking at us here. So once I see the most important structure that I can hurt, I know it is safe because I can see it, I can dissect it, and then it's a matter of removing disc herniation. And that's what was done in this case. So, and you can go all the way in. So you work laterally, but then you work ventrally, you know, all the way central and even to the contralateral side if you want.
Thank you so much, Dr. Mamadasos. Wonderful presentation.
So this is, I'll just show you the report, the MRI. So this is a pre-op, this is post-op. I did actually visit T12L1. I took some part of the herniation centrally, and this is the L1, L2, the most important. And see, she has a canal and she improved post-operatively. Complications, I'm happy to take that in the discussion. But the most important thing in this approach is find the nerve root, as I said, to find the disc herniation and effectively remove it. Thank you so much.
Thank you so much. Excellent presentation. I think we'll move on to our next speaker. So if you all are ready.
Yes, I'm ready. I'm going to share my screen.
Please do.
Can you all see the screen? Let me know.
Yes.
Yes, you all can see the screen? Great.
Yes,
Not yet, not yet.
welcome.
Hi, I'm Dr. Pang Hong Wu. I'm from Singapore. Today, my topic is a narrative review and clinical applications of lumbar endoscopic spine surgery. Some of the talk has been covered by Dr. Mohammed. In my practice, I do 40% open spine and 60% endoscopic spine. My fellowship training is with Nori Ganam, so I do an endo Ganam style. I'm fortunate to have both uniportal mentor of Dr. Hyu Sung Kim and biportal mentor of Dr. Ho Dong Hua. I have very good exchanges with several mentors as shown in the middle of the screen. I thank them for that. You can see some of the expansion of the talk in this article that we have written together. Is published in the Neurospine in June 2020. The aim of endoscopic spine surgery is to provide safe and targeted access to the compressive pathology with minimal soft tissue trauma, while performing what we want to do, decompression or fusion. Three key components help to achieve this objective: a magnified visualization from an endoscope, a working channel that's allowed customized endoscopic instruments to bypass soft tissue trauma and directly to the operative field that are causing compressive pathology, and a constant inflow and outflow of irrigation system that allow clearance of debris and clarity of vision. So in the recently, there is some renaming of several ways of performing endoscopy. Essentially, we have renamed them into the discectomy group, the lateral recess decompression, and the transcambine lumbar interbody fusion, as well as the interlaminar approach, where we have also labeled as discectomy, lateral recess decompression, bilateral decompression, and contralateral approach, as well as biportal surgery. The common current indications, part of it are covered by Dr. Mohammed just now, is that for herniation of disc. And the most common indication for transforaminal approach is for contained and low-grade migration. There is advantage of local anesthesia and perform under local anesthesia and moderate sedation, particularly in the L1 to 5 region, for central, paracentral, and foraminal region. There are three ways of doing it: inside out, which I felt that is like dock, and then we float out to find the fragment. Outside in is a foraminoplasty, creating space and find the docking point, and finally a mobile outside in technique. From an inside out approach, if we dock well with onto the target is calm and serene, there's not much epidural bleeding, you can straight away get on to do the discectomy. However, when we have wrong docking, we can actually get into trouble and really fraught with surrounding danger. While on the other side, with a targeted docking, after initial discectomy, then we can withdraw back and look at the epidural space and perform the fragmentectomy. I think the main disadvantage is that there is existing nerve roots is close by. Without foraminoplasty, there is limited real estate and hence might lead to existing nerve root dysesthesia. Outside-in technique is more of using a foraminoplasty to create space for docking. And after a sufficient space for docking, we can have a better access and better opportunity to prevent existing nerve root injury. The classic outside-in technique popularized by Dr. Thomas Hoagland is to basically do a foraminoplasty, increasing the foraminal ventral SAP, getting rid of the ventral SAP and also a small amount of pedicle to create space for the docking. This reduces existing nerve root injury. And there is some further modification. One of them described by Professor Chu Li is the foraminoplastic superior vertebral notch approach, which I recently used in my institution because of hypertrophic SAP. We use this SVN approach technique to increase the foramen size and take out the superior rim of the pedicle. We have a very good view of the disc and the epidural space. Other similar endoscopic foraminoplasty also described by my mentor, Professor Kim, as a suprapedicular circumferential opening technique. Mobile outside-in is like floating a boat to the dock. And for beginners, sometimes it can be disorienting and it can be fraught with danger. And it is an endoscopic assisted foraminoplasty essentially. With visualized reamer and drill, there is an added advantage of being safe when we perform our foraminoplasty. The advantage of that is that we can actually plan intervertebral routes, a foraminal route or a suprapedicular route, looking out for the disc along the way and minimize other soft tissue, unnecessary soft tissue trauma. Subsequently, we do what is quite similar to inside-out technique. We do docking in the cabin triangle, remove the disc, decompress the disc, and then look for the fragment. This is an example that I've done using a mobile outside-in technique, a patient with bilateral sciatica and neurological deficits with a right L3-4 prolapsed disc with quite a significant canal compromise. It's done under local anesthesia with indigo karma injection. We use under endoscopic technique, foraminoplasty performed, and then we can find the disc fragment by the herniatomy site. Perform some internal decompression first to create space for our working cannula. Subsequently, we remove the main big fragment, which I will move forward a little bit and show. And more importantly, like what Dr. Muhammad say, we will have to look at the epidural space and ensure that it's free pulsating nerve root. And using this technique, the patient can go home on the same day with a local anesthesia approach, and we can check that the patient has a good recovery from a discectomy. This patient also subsequently have a teleconsultation and doesn't really need to physically see me because of COVID period. He was locked down in the dorm. So there are some expanded indications for transforaminal approaches, such as high migration disc. We can use, as we mentioned, mobile outside-in technique. Sometimes we can drill the pedicle and directly access to the disc, or we can do the foraminoplastic technique and partial resection of pedicle and facet complex as described. We have seen a case by Dr. Muhammad about the revision discectomy and agree that this is a good approach for revision discectomy, and we can avoid fusion, which is a plus for many patients. Spinal stenosis, we have to take it with a caution. I felt that it's good for unilateral asymmetrical lateral recess stenosis. It is technically challenging, especially if you do it under LA. It can be quite time consuming, especially if a patient have a very tight foraminal stenosis. There might have a chance of exit nerve root palsy, but if done well, many of the papers have shown that they have very good results. Transcambien fusion over the talk or over the next 2 days, you will see there are a few ways of performing endoscopic fusion now. The main advantage is done under LA and is facet sparing, but there's some disadvantage of subsidence and exiting nerve root injury with expandable cage and cage glider usually necessary for the fusion. For interlaminar approaches, we know that it's good for L5S1 with a high iliac crest, especially in male, narrow foramen. Especially in an L5S1, we have a wide interlaminar window, and many of us are familiar with this approach through our microscopic learning during residency. This is a case that I've done recently. The patient, a 24-year-old man with a listing and a painful antalgic gait. So the patient have a caudally migrated L5S1 prolapse disc. So I perform interlaminar approach. I drew a little bit of the caudal lamina, sparing the facet, creating space, and at the same time able to access to the caudal migrated disc. With a nerve root retraction and advancement and rotation of the working cannula, we can protect the nerve root and retrieve the disc effectively. We first do the fragmentectomy, and then subsequently we work on to the interfragmental.
We have an internet slowdown.
Thank you. I think we have lost Dr. Huang.
Yeah, okay.
No,
I
looks
believe
like
we
he's
have.
Yeah, whatever. I
Dr. Huang,
think,
your sound is muted.
yes.
Your sound is muted, Dr. Huang. Dr. Wu.
Dr. Wu, your sound is muted.
Yeah, I'm back.
Yes, please. 2636.
Can you hear me and can you see me?
Yeah,
Yes.
Dr. Wu, please hurry up.
can
You're
see
in the
my
last
slides?
minute now. Yeah, please hurry up. Please hurry
Okay,
up.
sorry. Okay, I just get started. Okay, so now I go on to the interlaminar bilateral decompression. So basically, this is a technique that Prof. Kim and I wrote up on proctorship. And this is a recent case. 2-level decompression can be done using bilateral decompression. We like to use the outside-in technique. The advantage is that we keep the flavum on most of the time, preventing epidural bleeding. And we can actually have a good, using endoscopic drill and energy, we can assess the flavum clearly to the edges, and then we can retrieve it as a piece. So this is L4-5, and I will skip to the L3-4 part so that we can see that as a, because it's quite repetitive. My mentor used a 1 incision technique. I use 2 incision. I think for beginner, it's good to use 2 incision to get to the V point more clearly. So we can retrieve it as the entire piece. I think that's a good advantage. And then we can have a clear visualization as we retrieve that. I think give maximum protection of the dura when we can do bilateral decompression this way. We can use 1 incision for 2 levels actually, with a slight cranial, caudal to cranial.
John, if you could look into the link, but I think we are running out of time with Dr. Wu.
Okay, I'm sorry. I don't know why I keep putting out. I think I will finishing up soon, just a couple of minutes. You all can hear me?
Please.
Yes.
Yeah, so I just finishing it up. Sorry about that. A contralateral approach, you can read our papers on it. And then this is the final one. I just wanted to highlight with biportal. I think essentially the difference is it is a floating technique. We have a decoupling of visualization and instrumentation. We have a similar irrigation pressure, good visualization, and we can perform most of the interlaminar surgery with spine equipment that we can use in open surgery such as osteotome and high-speed drill. So this is a good way of doing another technique if we have resources limitation, or we are more familiar with the biportal approach. It's another way I do my interlaminar decompression. Sorry that I take up a bit of more time, and I will finish up soon. The advantage of biportal surgery is clear, similar to uniportal in many ways. I think both have its advantage and disadvantages. Most of them show better result than open microscopic surgery. And we have also published our data on uniportal endoscopic fusion. Can be done in spondylolisthesis, severe collapsed disc space, or adult degenerative scoliosis. You can read them online. And this is a recent paper we published on systematic review of complication. I think the initial learning curve is tough. However, with good perspiration and a little bit of inspiration, sometimes I have a mentor from Prof. Kim and Prof. Hao Dong Hua, we can overcome this. And I think this is the way to move forward in the future. I hope all of you are in good health, and I welcome you to Singapore one day to meet physically once COVID situation improves. Thank you very much. Sorry for the interruptions for a couple of times.
It'll be a pleasure to meet you, Dr. Wu. I think we will start with the next speaker because we are in a race against time eventually. Dr. Podal, please start your screen sharing.
Okay, sir.
It's an excellent presentation, Dr. Pang.
Thank you.
Can you see my slide?
Yeah,
Yes, we can.
start.
Thank you very much for giving this an opportunity. I'm Bapak Podal from Nepal. Today I'm going to talk on this disc pen generator and percutaneous endoscopic management. You know that there are different endoscopic spinal techniques, from the endoscopic assisted to the uniportal to the biportal, depending upon the instrument we use and the portals we use. And to be a true endoscopic spine surgery should be done percutaneously with stab incision with foot endoscopic system, utilizing the soft tissue dilation rather than cutting technique, and should be done under constant saline irrigation. So the tubular endoscopic system is the true endoscopic surgery. And recently, EO spine consensus paper has been published on the nomenclature of the endoscopic procedures. It has defined the full endoscopic decompression and endoscopic assisted. It has put the uniportal discectomy and the stenotic decompression as a full endoscopic decompression, whereas this Destandu technique and UBE technique are put in the endoscopic assisted surgery. And there are certain advantages of endoscopic spine surgery because as we master, we can operate the patient in the shortest period of time, and there will be a less blood loss, and there will be less pain, and the rehabilitation will be faster, and hospital stay will be shorter, and the patient can return to work early. And pain generators can arise from any change in the neural and chemical structures, and from the posterior column is from the deep somatic derangement. But my today topic is mainly the discs, the pain generator. So I will mainly focus on the middle column. So disc is the important structure. When it is pathological, it can come about this anatomy. And there is a constant homeostasis of the disc physiology with the balance of the mastocytic production and of the stimulator and inhibitor and the breakdown of the matrix. And the disc, as we know, that disc is innervated posteriorly by the sinovertebral nerve, and through the gray ramus communicans, it has connection with the sympathetic trunk, and is the connecting this the sinovertebral nerve is connected to the sympathetic nerve, and both the ventral rami and the dorsal rami poke together with this synovial knob to assist in the segmental function, because segmental function is very, very important. What is this function, that will be a problem will start. And we all know that these end plates are innervated by the basivertebral nerve. These are the pain generators. And this is the picture that shows that discs and end plates are highly densely innervated for the segmental dysfunction, because these are the pain. That's why somewhere we have to do discectomy, somewhere we have to do the fusion surgery, depending upon the pathology, what it has done. And when this symptomatic discs from the degeneration has been studied, it has been found that there is a growth of the vascular tissue inside the nucleus pulposus. Actually, nucleus pulposus in a native form, asymptomatic form, is avascular or neural. But when it gets symptomatic, there is a growth of vascular cavernous tissue inside the nucleus pulposus. Not only the vessels, there is found that the growth of neural tissues inside the nucleus pulposus, that is the pain generators in the spine. And extensively, there are the pain markers has been found in the symptomatic disc than in the control discs. And there are some massive expression of the growth factor like basic fibroblast growth factor beta, transparent growth factor beta 1, and connective tissue growth factor in the symptomatic degenerative discs. Whereas in all symptomatic degenerative discs, there is no knob growth, no formation of vascular granulation, and the expression of only a few growth factors. So we have to differentiate between the symptomatic and asymptomatic degeneration, because we are operating upon the patient, not on the MRI. MRI may show the degeneration. Well, if there is no symptoms, asymptomatic, we should not tackle that one. We have to really find out whether it is pain generating or not. And how the pain is produced in the discogenic back pain. Initially, there will be internal disc derangement that leads to the internal disc tear, and that leads to the ingrowth of the vessel that I talk about, the stimulation of the sinovertebral and the basivertebral nerve, and there will be the activation of the pain substances, so that you will have a back pain. That is the cause of the discogenic back pain. What about the lumbar disc herniation? The first initial insult is same, the internal disc derangement that leads to the internal disc tear, and that leads to the herniation, and there will again the growth of the nerve and vessels with the stimulation of sinovertebral and basivertebral nerve, and there will be activation of the pain substances. On top of that, there is a mechanical pressure over the root or the cord, or depending upon the pathology, it gives rise to the back pain and also the radiating pain, and sometimes the neuropathic pain when it is the central type of disc herniation. We don't find the radiating type of pain inside. And what about the stenotic pain? How it is pain is generated in stenosis? The same initial internal disc derangement that leads to the internal disc tear, that leads to the segmental dysfunction, that all column that I described, either in the anterior, middle, or the posterior. In the posterior part, we have medial branch of the sinovertebral nerve, and this is a fascitopathy. So because of dysfunction, there is a spinal stenosis because of the hypertrophy of the bone around it, the spinal canal, and the hypertrophy of the ligamentum flavum. So because of that, there is the ingrowth of nerve and vessels with the stimulation of sinovertebral, basivertebral nerve. There is activation of pain substances, and there will be a mechanical pressure over the root and cord. So again, we'll have a low back pain, claudication, and with or without radiation, depending upon the pathology where the location is. So how the discogenic back pain is managed? There are two types of the discogenic back pain. One is arises from the annular disruption, that we call annular disruption induced low back pain. Other is derived from end plate disruption. Because end plate are innervated by basivertebral nerve, annular end plate disruption is associated with the sinovertebral nerve. So how we tackle this? It can be done by the laser ablation. So the landmark paper on this is published now, and we call this transforaminal laser ablation of the sinovertebral nerve. If we ablate the sinovertebral nerve, we'll call Tesla. And if you ablate the basivertebral, we call Tebla. This is the promising percutaneous endoscopy technique so far. And prior treatment like I did, thermal procedures, discogenic back pain has less favorable outcome and has problem. However, this technique, which we have published together with my mentor Henson Kim, it has shown that it has 96% good to excellent result for Tesla, and it's about 93% for the basivertebral nerve ablation. How we manage the PIVD? Now it can also be managed by percutaneous full endoscopic technique. Initially, the disc herniation with the caudal equinox syndrome is disc herniation with spinal stenosis. Recurrent disc herniation is disc herniation with stable spondylolisthesis, or the calcified discs are once considered contraindicated, but now is no more contraindication of endoscopic surgery. We can do all type disc herniation with the endoscopic technique with a 96% success rate according to the McNubb criteria and 98% success for endoscopic success grading. This is the endoscopic success rate we have described, and the difficulty for the surgeon and the grade and the score of the doing the endoscopic discectomy depending upon the nature of the discs. You can go through the literature, you can find in the detail now. And endoscopic surgery, the discectomy can be done through the transforaminal approach, interlaminar or transpericular and other approaches. And there is a difference between inside and outside. Dr. Hu has also explained about this. There is a difference because inside, in and out approach, we go directly into the discs, but out and in approach, we remain outside the discs and we target the pathology only. So the difference is in and out approach, there will be a big range. So the recurrence after the discectomy will be high in and out approach than in the out and in approach. And there is a now shift in the transforaminal endoscopy discectomy from the inside out to the outside in approach. And this transforaminal endoscopy has 3 routes. We can do through the 3 routes depending upon the location of the disc. Exiting root approach, interverted root approach, suprapedicular approach. So the for bilateral, foraminal, and superior migrate discs, we use the exiting root approach. And interpreted root approach is the paracentral and central discs, mild inferior migrated discs, high canal compromised disc herniation, and for high-grade inferior migrated discs, we have suprapedicular approach. And likewise, in interlaminar discectomy, we have 2 approaches, shoulder approaches and axillary approach, depending on the location of the disc where it is located. So there are the problem with the discectomy, like high iliac crest, narrow foramen, migration, recurrence are the problems. But there is a solution for this problem too right now, because we can approach the high iliac crest by the transiliac approach or by interlaminar approach. We can do this problem of the narrow foramen can be solved with the foraminoplasty either by the reamer, bore, or sealer by dissection of superior facet, superior vertebral knot approach, or S-cut as suprapedicular circumferential opening technique, because this S-cut technique is usually used for discectomy high-grade inferior migrated lumbar disc herniation. And migration is also a problem, which is migrated discs wasn't unable to treatment in the past, but is now enabled to treatment because we have C-cut technique, suprapedicular techniques, transpericular technique, interlaminar technique with the use of semi-rigid flexible curve, probe, foraminoplastic, ventrally approach, down level interlaminar approach, and contralateral foraminal approach. So depending with the instrument and approaches and techniques, we can manage this migrated discs as well. So there are a lot of literature that supports that. That I've already said S-cut is used for high-grade inferior migrated. It's recently published. And recurrence is also a big problem. The solution is found that for annular sealing, in interlaminar approach, annular sealing is one of the method, and in the transforaminal approach, targeted discectomy, that means outside in technique, is one of the solution for that. And through the interlaminar approach, rather than resecting the ligamentum flavum, if you do with the ligamentum flavum splitting, it is an advantage for the recurrence, because then when the study is done, there is a found that there is a without the sealing, this annular sealing, the recurrence rate is 13.5%, with sealing is 5.5, and when it is augmented with ligamentum flavum splitting, it is found that recurrence had decreased from 5.5 to 2.5%. So these are the solutions. So how we manage the spinal stenosis? This can also now be managed with percutaneous endoscopy technique. We call this percutaneous endoscopy sternocleidomastoid lumbar decompression, PESLD, but recent consensus has changed the name that we call now that ULBD, LEUVLD. And
we are in your last minute, please, sir. Hurry up.
Okay, sir. The result is more 90% good. Okay, sir. And this now been extended indication are there for fusion, discitis, Bartholdi syndrome, spinal tumor graded population, and obese population, and it can be used for the fusion, which is evolving technique by transcamin approach or endothelip or interlaminar approaches. There are a lot of literature evidences for that. So it's a review, systematic review. It has shown that there is a good surgical option for degenerative disc disease instability, spondylolisthesis. So a lot of evidence is also available for the infection also. So recently, this meta-analysis has cleared that it has early intervention in spinal infection is encouraging, and there is a high rate of causative pathogen identification, and it provides satisfactory clinical outcome. But it quotes that large number of control trial is necessary. So we can also use in the Bartholdi syndrome. As we know that Bartholdi is the enlargement of the hypertrophy of the lymph transfer process, and sometimes we have pseudoarticulation with the pelvic thing. So there is a compression of we can decompress with endoscopic technique. And UB is the emerging technique where you use the by two portals, and there is remote future indication for the endoscopic surgery is to use for the disc regeneration as a visualization and delivery tool of biological materials. So if the more of the information can be achieved, can be achieved from this book, Endoscopic Procedure in Spine. We also have one chapter here. So the my presentation I'm finishing now. The treatment of discogenic back pain, discectomy, and stenosis, decompression, is fusion will all be percutaneous in the near future. In due course of time, all spinal problem can be solved by percutaneous endoscopic technique. So I would like to acknowledge my professor, mentor, Professor Hyun Kim, for mentoring me in the spinal endoscopy. And I would like to welcome you to the Nepal, this mystic place with the mountains and Himalayas. All tallest mountain, highest mountain is in Nepal, and we have God and Goddess, and we have very natural resources.
Thank you so much. I think we will move on to our next speaker, Dr. Baban from Mongolia. He's been waiting patiently. Please share your screen, sir. Thank you so much, Dr. Caudal. It was a wonderful all-round presentation. Thank you so much. Dr. Baban, welcome. Please start.
Can you see my PPT?
Can you please move your
Can you see my PPT?
Yes, we can see your PPT, sir. Please start.
Thank you for. Okay, thank you for giving me opportunity for these presentations. So my topic is clinical experience of endoscopic decompression. So I think endoscopic surgery is made some paradigm shift. So good example of paradigm shift is was Nicholas Copernicus. He made before Nicholas Copernicus, people thought sun turned world, but Nicholas Copernicus made world turn sun. So this is good paradigm shift example. So I think endoscopic spine surgery are also one of the paradigm shifts good example. So I did almost 500 cases from January 2000. Between 3 years, I did almost 500 cases. So 257 cases for discectomy and stenosis cases 229. So foraminal stenosis, I did 17 cases and 212 cases for central and lateral recess stenosis. So what we understand after 500 cases, we understand three things. One is operation time is important. Second is MRI reading is more important. Third thing is find to pain source is important. So why operation time is important? So we studied some case. You can see in pre-op MRI and post-op MRI, there is no muscle change. But sometimes you can make some muscle change like this. So why it is happens? Sometimes you can make three-level stenosis, and we did L3, 4, L3, 5, 5, but there's two level has muscle change, one level don't have. So we studied like that. We collected 100 cases and divided to two groups, operation time less than 1 hour operation time more than 1 hour. So also we divided with muscle edema, non-muscle edema, and muscle edema, non-muscle edema for group, and we calculated G-super distribution and adjacent logistic regulation. And there was 12 times more possible if operation continue more than 1 hour. There's chance to 12 times more muscle edema. So operation time is most important. We understand that. So second is BMI. BMI not related in these our studies, not related to. So I will focus PSLD UBL, PSLD discectomy, and the paraspinal. So we can do paracentral herniation and central herniation like that case. You can see in this video paracentral and sorry, this is don't work. Okay. So we all know that permanent stenosis grading by radiologist doctors, and they divided 4 type of systems, permanent stenosis grading system. One is conogo-Hassiv system. They divided per direction of stenosis, and the Wildermuth system without directions, Lee system, and again Lee system, entry zone, middle zone, exit zone, like that. So in my opinion, we have to know pain source well, more than good than radiology doctors. So for example, in this case, SIP made some pain source. You can see here, SIP made source. And for example, in this case, also have SIP made pain source. And second is sometimes we can, when you, during operation, when you mobilize nerve root, you can feel some bone spurs like that. And sometimes disc herniation and collapsed disc and soft tissues here make permanent stenosis. And in this case, you can see combined lesions. There's SAP, soft tissue, and bone spurs, disc also. So to know well about pain source, we can save some times of operation, and we also know when we have to finish operations. And so para-PSLD is different than PLD. PLD is landmarking is cambium triangle. Para-PSLD is landmark is isthmus, like that. So peroneal stenosis, extraperoneal herniations, we can do para-PSLD. For example, in this case, endpoint of peroneal stenosis, we have to see exiting nerve root, traversing nerve root, and axilla. We have to see, and during extraperoneal herniation, we don't need to see endpoint. So finally, its conclusion. So after 500 cases, I load PSLD. So why I load PSLD? And PSLD can solve combined lesion. For example, in this case, herniation and stenosis combined. And the second is it can be full decompressions. For example, one nerve root can compress in 3 area, and 3 is after discectomy. Sometimes this height will loss, and that makes again stenosis. So this is prevent future compression nerve roots, and also can solve multi-level stenosis also. And we need no need to more decompression. And finally, modern medicines proposes aging population, increase of age, but PSLD and endoscopic surgery can make quality life is good. And thank you so much.
Hey, Dr. Malcolm, are you there?
Yes.
Sorry. Thank you so much, Dr. Baban. That was a very wonderful lecture. It was short, sweet, and right to the point. It went to the heart. Can I please request Dr. Wee Zhang to now come online and start his screen sharing? Dr. Wee Zhang, are you there with us? Dr. Wee Zhang, are you there with us, sir?
Yes, I'm here.
Yeah, welcome, sir. Welcome.
Okay, can you see my screen?
Yes. Thank
Okay.
you. Welcome.
Thank you very much for giving me the opportunity to share my experience in the UBE clinic applications in cervical cases. I'm Dr. Zhang Wei from China. Today's content include indication, basic anatomy, tools, and this is position, locations of portals, and surgical steps. Indication include the keyhole for the discectomy and decompression of the cervical nerve canal, and the cervical URBD for the cervical spondylotic myelopathy. The basic anatomy is similar to the UBE lumbar procedure. We often doctor in the midline and there is nearly no muscle, and then we move to the lateral side. We will see the laminar in the first scene. We can see the lateral muscle, and we work in the midline and then move to the lateral mass. UBE cervical case equipments is a simple and a relatively small number of devices required compared with the lumbar procedure. Include endoscopy, IF, plasma, special tools, small size kerosene punch, and high-speed drill. Endoscopy is includes 0 degree and 30 degree. 0 degree is similar to the open procedure, so is the first choice. How about 30 degree? We should rotate the endoscopy to see interesting area, and the distance between view portal and work portal is 2 centimeters. So at such short distance, the 30 degree endoscopy and the instruments are prone to conflict. But maybe the ventral structure of the spinal cord is easy to see. I often use the two types of the IF produced from the Bounce company. The big one is used to expose. A small one, I name is nerve friend, and to do the bleeding control around the nerve root. Special tools include the small size dissector, and there's a half tuber, and the small size UBE retractor for the autoflow fluently. And this protector sheath is used to remove the osteophyte near the nerve root. You can see we insert the protective sheath, and we protect the nerve root. Then we insert the drill bore through the protective sheath to remove the osteophyte. Kerosene punch includes 1 millimeter, 2 millimeter thin blade, 110 degree and 130. And 2 millimeter thin blade curved punch is used to the cervical URBD. We master the dural no touch technique. This is the angle kerosene punch. High-speed burr, I often use the short handle because short handle is stable, I think, and nearly no exposed drill root. There is no exposed drill root because it often can damage the endoscopy and the muscle. 2 millimeter and 3 millimeter diamond bore is often used. And this year, we need to control the low blood pressure and deep anesthesia and this jet plane position, and to keep the curve of the cervical spine in the level. Location of the two portals. I prefer to the midline of the lateral mass, and the I draw a line between the two pedicle, and the midline, the blue line, the cross point above this point, about 1 centimeter is the view portal, and below 1 centimeter is the work portal. The lateral X-ray show the endoscopy and the instrument meet together in the facet joint. This is the picture during the operation. The laminar and the base of the spinal process is a safe dock area, I think. The endoscopy and the instrument meet together the laminar, the surface of the laminar. A surgical step, V point is very important anatomy landmark. You can see the V point is the inferior margin and the upper margin and the medial margin of the facet joint. This is the bone work start point. I often use the size of the drill bore to measure the decompression area. We cannot go beyond the 50% of the lateral mass. You can this video shows the lateral mass joint, facet joint. You can see the joint. Start point is the V point. We start from here. The V point. We use the 3 millimeter diamond bone. The dividing line of the flavial ligament, the lateral margin of the flavial ligament, you can see here. I use dissector to separate the lateral margin of the flavial ligament and the membrane. We often find this membrane on the surface of the nerve root. This is not the dural membrane, so it's safe. This is the decompression area. I draw the picture. You can see the medial wall of pedicle, the two pedicle. And this is the nerve root, this is spine cord. How to make sure the decompression area? You can see the lateral wall of the pedicle and the medial wall of the pedicle. Yeah, you can make sure the decompression area. Because the lateral wall of pedicle is located in the 50% of the lateral mass, so we decompression here. Another method, I use the size of the drill bore to measure the decompression area. After discectomy, and we can do the further decompression of the spinal canal. The disc herniation is often located in the axillary area. At last, we see the medial wall of the two pedicles. We finish the keyhole decompression. This is a keyhole procedure. The case one is a giant osteophyte. You can see the huge osteophyte. I will do the contralateral approach to remove this osteophyte. The above is midline, the below is the right side. I expose the laminar. You can see the upper margin of cervical fold. cervical 5. This is the V point. You can see the inferior margin of osteophyte. I use a small IF. This is the upper margin of osteophyte. You can see the free bone fragment. I remove the free bone fragment. Separate the free bone from the spinal cord. So I think the small size plasma is very safe, especially for the cervical case. We can see the contralateral root and the contralateral facet joint. After further removing bone, the decompression finish. Yeah, this is a post-operation, the CT. The case 2 is cervical ULBD, the classic procedure. We start point is from the V point. Mixing the laminar. You can see the inner plate of the laminar. This is a flavor ligament, and this is a up margin of the flavor ligament. Then I make sure the start point of cervical 5. After removing the laminar, the decompression finished. Anatomy is very important, especially V point, and we must make the docking point in the midline, and we choose the right tools and right operation indication. The anesthesia position is also very important. Precise location, especially work portal, is very important. How to make sure the decompression is also important. We have 2 methods. Thank you very much.
Thank you so much, Dr. Wee Zhang. This was a wonderful and a very, very informative talk by you. Amazing, amazing work, especially with the osteophyte removal. Really impressed with your work, sir. I am a fan of yours. I can declare that publicly today. And I think we will now start with our panel discussion. Dr. Bennett, can I please request you to get all the speakers? And if the public have any question, I'd also like Dr. Anand Kavi to join us in this panel discussion. So,
yes, Malcolm, I'm here.
We have 10 minutes on with us. If anybody has any questions, please regarding. So I hope Dr. Mohammed Assaus is also there with us right now. I personally have one question for Dr. Mohammed Assaus. Dr. Assaus, are you there with us?
I hear you.
Yeah. Dr. Mohammed, one personal question that I have for you is, what has been your personal incidence of transient root paralysis and root dysesthesia following transforaminal endoscopic discectomy?
I probably, in 500 cases, I remember 1 or 2, and it was in my initial cases, basically, when I went too steep or too straight on the disc. So after that, I immediately adopted the cranial caudal approach. I think this is an access issue usually where the cannula sits on the exiting route during the access. And this is why I think you are much more safer and less likely to get this complication by going just that 10-15 degrees caudal and avoid the exiting route altogether.
Thank you so much. Thank you so much. Anybody else with any other questions, please, from the public also? Do we have any questions for our panelists? Dr. Wee Zhang, one question directed to you. Personally, whenever I do cervical endoscopy, I definitely follow what you have been speaking about. I identify the B. And I did appreciate your suggestion that we should not remove more than 50% of the lateral mass. So that is 2 things that I desperately follow. I believe in dividing my cervical work into 2 parts. One is when I wish to just trace a root or to decompress a root, then I prefer to go more laterally. Or if I prefer to go centrally, then I prefer to do more central decompression. I try not to mix both together. I try to be more specific in my approach. Regarding your case of tackling the cervical osteophyte, I found it very, very intriguing, very beautiful. We don't get to see such cases in our Indian subcontinent, unfortunately. So it was interesting to watch your work over there. Dr. Baban, it was wonderful to hear your concise talk and your experience about 500 cases of PSLD, which you have very beautifully divided into cases that required only discal work and cases that required stenotic work. I appreciate your approach and your ability to deal with posterior osteophytes that specially compress and elevate the root in its exiting part of the foramen. And the ability to do that in a uniportal approach is fantastic. It's really fantastic. So hats off to you there. And Dr. Podal, you are one of our beautiful panelists who spoke upon pain generator. This is a concept which has been really highlighted by one of my great mentors, Dr. Satish Chandra Gore also, who has been speaking about pain generators in the spine. So definitely the end goal of all surgical work in the spine is relief of pain. And that's what we all basically aim to achieve. So that's a very wonderful talk that you have delivered. Dr. Pang, Dr. Wu Pang, yours was a wonderful talk. You mixed all branches of endoscopy right in the initial program itself. It was like delivering a nuclear bomb in spine endoscopy, and I really, really appreciate what you spoke upon. The future of spine endoscopy is going to be a 360-degree approach. It's going to be a merging of all branches of endoscopy. There is going to be nothing like specialization in endoscopy, PELD, UB, uniportal. It is basically just going to be achieving proper decompression, achieving pain relief, and setting out the gold standards that we actually are today. I don't think that microscopic endoscopic discectomy with a microscope is any more the gold standard. I feel that with the fluid medium that we are using, better visualization, camera actually at the chip or the end of the scope is the future, and the world is well on its way over there. So I would like to conclude this first session. If any of you as speakers would like to raise a question, please do it now.
Yes, Malcolm, there is a question from the audience.
Yes, please.
There is a question that kindly describe the anatomy of V point. What do we mean by V point in case of posterior cervical endoscopy? So
I think I will ask Dr. Veer, our panelist himself, to speak on it. Dr. G, if you can speak on that, please. Hello. Our panelist is gone. Hello, Dr.
Yeah,
hello,
Dr. V. Zhang.
Yeah. I see the question. Javier explained the viewpoint. The viewpoint is a very important anatomy landmark in the cervical endoscopy procedure. Is formed the inferior margin of the laminar and the upper margin of the laminar to form a word V, and the V point is located in the medial margin of the lateral mass. We do the bone work from the V point and to the lateral side to expose the nerve root. And after remove the bone of the V point, we can see the lateral margin of the flav ligament and the membrane on the surface of the nerve root. We separated the flav ligament and the membrane, and we can see the nerve root. And we go to the below pedicle, mid wall, and above the mid wall of the pedicle to do the decompression of the nerve root and remove the disc herniation. So V point is a very important start point for the bone work. Thank you.
I think I have with me a sample, a specimen over here. And I would like to point out that the V point is where these two points meet, where the upper and the lower lamina meet to form the lateral mass. That is the V point. Now the V point, when you decompress about 30% or 50% of it, anteriorly you have decompressed and exposed the entire discal surface. You don't need to go more laterally. So that is exactly what Dr. Jai has been trying to explain to all of us. And I hope that this satisfies you. Thank you so much. I think we will now take a short break, and I will now request the joining of our next set of panelists. So if I can request Dr. Bennett to please come online and get our next set of panelists on so that we can, compress the time and we can restart our next session by 12:35. So thank you very much, all of you. Any other question from the audience? I hope not. Dr. Bennett, do we have you here with us?
Yes, we're here.
Yeah, Dr. John, if you can get the next set of panelists.
That's up to you. I can't do it.
Yes.
It's up to you.
Please do. So we can have our next set of panelists, Dr. Choi, Dr. Jinwan, Dr. Tunch, Dr. Hayati, Dr. Shidem, and Dr. Mankyu Park. All are dear friends. So it'll be nice seeing all of them live. And I once again thank all of you. Thank all of you for being with us. Please continue to enjoy being with us, and please continue being part of this program, giving your inputs. Let's not keep it very official, but let's keep it like a family. So John, if you can get the next set of panelists on.
I misunderstand you. How am I to do that?
Dr. Choi, has he joined?
Okay, they all are here on the panel, I believe.
Hey, I'm Dr. Choi.
Yes, Dr. Choi, welcome. Welcome.
Welcome.
Nice to see you, buddy.
Hey, nice to see you. How's it going?
All fine, Choi. I hope you're ready with your talk.
Yeah, sure.
Ready to rock the world. So can we start? As a matter of fact, we are a couple of minutes early, but I would love if we can start and then, have some more time at the end of the session. So Dr. Choi, if you could start sharing your screen, that would be a wonderful thing to do.
I'm okay. I started. Do you see my view?
No, we are only seeing you, Choi. A very handsome face, but we'd like to see your screen.
Okay, can you see?
Yes. Can you enlarge it, please?
Yeah, I'm started.
Can you please enlarge it?
Thank you, Chairman, and Dr. Malcolm Estonji. This is Sunyeon Choi from Harvard Hospital, Busan, South Korea. As you know, pedicle is the key anatomy of spinal surgery. What is the UB? For this question, I would like to answer this is the endoscopic solution for the spinal stenosis. UV can be performed under the general epidural anesthesia with the patient in prone position. For the equipment, 0-degree endoscope, RF device, irrigation system, and the surgical tool specific to the UV system should be prepared in the set. Caudal entries for the instrument and cranial entry for the endoscope. After serial dilation and working space is made. Scope is inserted. Lamina is exposed. This area is initial working space called the sonde space. I always emphasize on the continuous output. This video is a basic procedure of UV decompression for the central stenosis, ipsilateral and contralateral ligament flavum is removed. This is the ULBD state. Potential space name as sonde space is converted into initial working space for UV procedure. Paramedian approach has two subtypes, and the basic approach is paramedian approach and paraspinal approach. This slide shows migrative pattern in lumbar HIVD. I present how to lumbar HIVD according to approach type. The skin point is important. On the CM radiograph, you can check the skin point in lateral view. The indicator is middle portion of a spinous process, and two skin points are 3 centimeters apart from each other. In AP view, initial target point is spinolaminar junction. This case is a central huge HIVD case. In endoscopy view, this is root and the remnant ligament flavum, huge disc. Post-op MRI show complete removal disc. I try to spare to ligament flavum as soon as possible. This case is a central huge HIVD combined central stenosis. First, the ULBD done and then discectomy is done. Post-op MRI shows ULBD and the discectomy state. This is bilateral HIVD, bilateral inferior migrated case. I choose the paramedian approach. First, ULBD is done. After that, ipsilateral and contralateral discectomy is done. Post-op MRI shows complete disc removal. This case is a right huge HIVD combined central stenosis case. Left paramedian approach is chosen. First ULBD and next discectomy. This is post-op MRI. Contralateral approach has two types. The one is a sublaminar and the other is a translaminar. If the case is a superior migrated case, contralateral sublaminar approach is chosen. If the case is inferior migrated case, contralateral translaminar approach is chosen. This case is L45 left superior migrated case disc. Contralateral sublaminar approach chosen in right standing. First, I check the L4 pedicle and remove disc. Post-op MRI show removal of disc. This case is left L3 for inferior migrated disc. Contralateral translaminar approach is chosen in right standing. Left side ligament flavum of L4 lamina is detached naturally, and then pedicle is checked, and the ruptured disc is removed. Post-op MRI show removal of disc. This case MRI shows right inferior migrated disc and right L5S1 foraminal bulging disc. contralateral subraminal approach is chosen in left standing, and right side ligament flavum of S1 upper lamina is detached naturally, and then pedicle is checked. Rupture disc is removed, and right side L5S1 bulging disc is shrinked by RF device. Post-op MRI shows removal of disc and sparing of ligament flavum. Paraspinal approach. This is paraspinal approach. A lateral indicator located directly above foramen, and in AP view, indicator rotated 1 cm lateral to vertebral body. Initial target point is lateral end of isthmus and below, just below pedicle. After this area burning out and the ligament flavum is detached naturally in raw mode of transverse process. In foraminal stenosis, 3 pre-post ganglion part must be free. Ipsilateral paraspinal approach is able to be free 3 part, but if combined central stenosis is combined, I recommend the contralateral paramedian approach. This approach is able to be solve central stenosis with foraminal stenosis. MRI shows right foraminal and extraforaminal HIVD. Ipsilateral paraspinal approach can be solved after ligament flavum is removed and the ruptured disc is removed. We must check the ruptured disc in front of root because pathophysiology of foraminal HIVD is about the migration. And post-op MRI show removal of disc. This is left L3 posterior migrated HIVD case. Contralateral approach can be solved, but upper lumbar lamina is narrower than lower lumbar. Another option is ipsilateral paraspinal approach. This is endoscopic view. Ruptured disc is seen. MRI shows full decompression. Past history is previous open discectomy and recurred HIVD case. In revision case, first checkpoint is finding pedicle. First checkpoint is pedicle, and the root is already located in the medial side of pedicle, and both adjacent tissue and dura are retracted together, and then ruptured disc is removed. Post-op MRI show complete removal. Many degenerative disease has multi-level problem. This is L5 spondylolysis, spondylolisthesis with right L3 for foraminal HIVD case. After cage insertion using UV is inserted in L5S1, right paraspinal approach in L45 is done. Endoscopic view show foraminal hard disc. Post-op MRI and post-op X-ray. And next case, L45 spondylolisthesis with L5S1 right extraforaminal HIVD. Initial target point is junction of ALA and L5 transverse process. After blocking and removal of ligament flavum, hard disc and soft disc are removed using osteotome and RF device and pituitary process. Root is free. post-op X-ray, and post-op MRI. And last case is L45 spondylolisthesis, S1 spondylolisthesis with L2 for left inferior migrated disc. 2-level fusion using UV, and then this case is the contralateral transforaminal approach. First one shows the complete decompression of the seen. Conclusion: A-type migrated pattern, paraspinal approach, transfacetal contralateral approach is able to be solved, and inferior migrated pattern, paramedian, transfacetal, contralateral transforaminal approach, and extraforaminal disc, paraspinal approach can be solved. Foraminal HIVD, contralateral sublamina, or upper lumbar case is paraspinal approach is chosen. Superior migration disc, paraspinal approach, and contralateral sublaminal approach is chosen. Conclusion: UV is no restriction of surgical application from HIVD to spinal fusion. UV is maintained the benefit of minimal invasive and powerful surgical solution for multi-level spinal stenosis and HIVD. These are spine doctors in our hospital. Many domestic and foreign doctors come to run UV. Thank you, Dr. Malcolm Pestonji, and thank you, Dr. Anand Kavi, and UV India. Thank you.
Thank you so much. It's a pleasure to see you again. That was a wonderful time. Thank you. Thank you so much.
Thank you.
If we have our next speaker ready, can I invite Dr. Jinwoo An? Hello, Dr. Jinwoo An, are you there with us?
Hi, can you hear me?
Yeah, Dr. Jinwoo An.
Yes.
Welcome, sir. Welcome to our Congress. And if you're ready to start your screen sharing, we would love you to do that.
Okay, thank you.
Dr. Choi, you can stop your screen sharing now.
슬라이드 끝내야 된다. 현상이 문제 왔다.
Welcome, Dr. Jinwoo An. Please start your talk.
Okay. Can you see my slide?
Yes, we can see it very well.
Okay. Thank you, Chairman. I'm Dr. Jinwoo An, orthopedic spine surgeon, Namir Hospital in Dubai. I'm so honored to present this topic. Maybe previous represent, Dr. Choi explained very well about spinal stenosis by UV. Many surgery techniques will be talked about by other speakers. So I'm going to speak to you about UV history and basic concept. I hope this presentation will help for try to start UV. Spinal endoscopy has a long history over 50 years and is developed and well known with PLD, PSLD, and uniportal techniques. But today I want to introduce biportal endoscopy technique for spine surgery. Until 10 years ago, most of the surgery was performed as open surgery, but there were a few endoscopic surgery. In the last 10 years, endoscopic surgery has made great progress and has developed to a level that can handle many spine surgery field along to uniportal and biportal endoscopy. The merit of UV is more familiar to spine surgeon. Anatomy is the same as open microsurgery. Can use all instruments without limitations. More clean and safe than microscope. More benefit to patient, minimal incisions, less back pain, short admission days, and so on. I think UV and MLD are almost same approach instrument. anatomy, and surgical result, but accuracy and safety is different. That is my personal opinions. Compared to UV view and microscope view, UV view is much clean compared to microscope. This means clean view makes surgery easier and more safe. In 1996, first published paper by Dr. Anthony from Argentina in the Journal of Arthroscopic and Related Surgery about translaminar lumbar epidural endoscopy. 2001, Dr. Abdul Ghaffar from Bahrain shows poster presentation at AAOS about endoscopy lumbar discectomy. 2001, Dr. Jinhwa and Young Choi, they are South Korean. They were inspired from Dr. Abdul and started this technique in South Korea. They are real pioneer in South Korea for UV technique. 2003, Dr. Jinhwa from Jinhwa presented endoscopic lumbar discectomy using UV technique. 2013, it is the year that the area is extended from simple discectomy to treatment of stenosis and even fusion surgery. Dr. Son, he learned this UV technique from Dr. And he is the first surgeon to introduce ULBD using by UV technique. He established the basic concept of UV and make a UV as a name of this technique. Dr. And Dr. Son are still doing their best to spread to all over the world this UV technique. This is Dr. and Dr. Son's pictures. Okay, what is the UV? UV is based on arthroscopic with fluid environment as joint surgery, but difference is there is no space in spine, unlike joint. First is about water. UV is out of water flow. We must check water flow. During the UV surgery, we must meet epidural space and do in water environment as arthroscopic surgery. Water is inserted epidural space. If there is no appropriate outflow, the pressure inside epidural space will increase and make a dangerous condition. So management of inflow and outflow is very important. Keep the pressure 30 to 50 millimeter Hg per surgery. Second is triangulation. This means scope and instrument must be met under target point. Open and early triangle make surgery difficult. If you make good triangulations, you can see the instrument in the screen. This is good triangulation shape. Studies about control of water pressure. Controlled continuous outflow can make optimal hydrostatic pressure. We can check bleeding, and using hydrostatic pressure, some work is easier. This video shows block of outflow is useful for working. Next is about technique to remove ligament problem. Using blunt-ended instrument and split the ligament problem, and with calcium nodule, remove the ligament problem safely. Minimal touch the dura is very important. Scope can be moved to all directions and more deep close with clear view. At your surgeon's convenience, we can use variable degree lens. What can we do with UV? I think all kind of spine disease can be treated by UV, hernia disc, and spinal stenosis, fusion surgery, revision surgery, OPLL, fasciitis, and so on. Okay, now I will talk about some tips for the surgeon who want to start UV. First one is anesthesia. Anesthesia is very important for surgeon to do without stress for patient. General anesthesia is better for beginner and especially code level surgery. Patient must be prone position with neutral rolling pad. Irrigation fluid is at surgeon's head side. Wide skin window with fluid dam and back are needed. Wide skin window is better to prevent leakage of fluid. Radio frequency and drill with draining tube also. Serial dilation and triangulation on the C-arm. Scope and C-arm monitor is opposite side of surgeon. Assistant take a UV retractor with left hand that make more outflowing and keep good visual field. Assistant control water flow with closing or opening of drill draining tube. Next is orientation. Scope orientation check is very important also. Must check the direction of the scope. Next is skin marking. For interlaminar approach, target is upper part of disc and medial margin of upper pedicle. Find the disc level with C-arm and from the midline laterally 1 cm. The target is superior spinal laminar junctions. Distance of two portal is about 2 to 3 centimeters. Sometimes we use the spinal leader to reduce using the C-arm. For foraminal approach, in lateral view, target is just above the foramen. In AP view, isthmus is target. So two portals are made on 1 centimeter lateral side from vertebral lateral margin. For spine fusion, the reference point is pedicle. This picture shows pulse incision to compress and insert the cage and screw for fusion. Working space is very important. In joint arthroscopy, there is existing space, so we don't need to make a working space. But in spine, there is no space, so we have to make a real working space. First video shows serial step up to make a portal. Second video shows to make more space using two instruments. That is sleeve up technique by Dr. Son. We will meet the redness at first time, but with precise triangulation, we can find the instrument and the laminar bone. Check scope orientation is important also. We must check the all direction. For paraspinal approach to work bilateral disc herniation or foraminal stenosis, same manipulations. If we can reach an exact target point, we meet the isthmus portion of transverse process. Bone working is done with ball punch. Enough bone working is essential to success of this technique. Last one is flavectomy. Split and remove is basic concept. After this step, we can meet the nerve and disc region. Left video shows interlaminar approach and disc removal. Right video shows extraforaminal air containing cyst removal. Important point is carefully review the patient's information, decide approach, each up to surgeon's choice. Accurate targeting is two regions, minimal soft tissue injuries, bleeding control. That is basic concept of UV technique. Conclusion, UV is powerful surgical method for treatment of spine disease. It's more safe than open surgery, shows same anatomy as open, so it is familiar to spine surgeon. That means easy to learn. I think endoscopic surgery, including UV, will be standard treatment of spine surgery. Do it now. Sometimes later become never. We have two UV society. If you want to join, you can find it in Facebook website. Thank you for your attention.
Hey, Malcolm?
Mute myself, sorry. Dr. Jinwan,
Yes.
a wonderful talk, stuck to the basics, educated the world. I think that was a very fantastic and a noble thing to do. Most of the time when we talk on statistics and we talk on papers, but I think this talk came straight from the heart. I think both you as speakers, Dr. Choi and Dr. Ann, you are wonderful speakers. You have really spread the knowledge about UB as a technique. This was most of the people who will be watching this video, even on YouTube and repeatedly watching these videos, are going to learn a lot from you. And that is exactly what this World Congress is actually about. It's about teaching, it's about learning. And it was a very beautiful talk by both of you. I will now request Dr. Tunç, an old friend of mine from Turkey. Where is he? Can he come on live? So Dr. Tunç, can we start your screen sharing? And Dr. Ann, can you stop your screen sharing?
Okay.
Dr. Tunç, are you there? Or are we too early for you?
Hi.
Hello.
Hi.
Dr. Tunç, are you there?
I am here.
Yes, welcome, sir. Welcome. We are not able to see you. Please start your video. Dr. Bennett, yeah. Welcome.
Hi, how are you?
My brother who's 3 days younger. Welcome.
Thank you so much. Hi, everyone.
I'm fine, sir.
Today, my speech is especially for beginners because I know this fantastic meeting, fantastic congress is very interesting for beginners also. And from my own experience, I will try to make a simple simple presentation, especially for beginners. So,
wonderful.
Okay, we can start.
Please do.
So, when I start to my surgeries, my boss, they say me always that big surgeons make big incisions. You see my presentation?
No, we cannot.
Still not, sir.
You cannot see?
No, you need to share it.
It's too minimally invasive.
Let me. You see now?
Okay, you're on the track,
Yes.
right track.
You see my presentation?
Yes, we do. You need to make it bigger, please.
Malcolm, it's okay?
Perfect.
Yes, Dr. Tunç, we can see your presentation. Go ahead.
Okay, thank you. So, I was interested by endoscopic spine surgery, and the big question was how to learn this the spine endoscopic spine surgery. And it was like a new instrument, like a new woman who just married and she don't know how to cook. So I decided to learn how to cook with this new instruments. And it was like some chopsticks because I know many of our friends, they are very able to use these chopsticks, but for us it's very different. So it was like to learn to eat with chopsticks. And my big questions was how to learn faster this endoscopic spine surgery. And in many years, I understand that there is no way to learn faster it because there is many issues to learn: endoscopic anatomy, use of fluoroscope, OR settings, preoperative planning. And I think the first step of the surgery is the correct needle placement, correct instrument placement for success, because the optimal needle placement is the most crucial step of this procedure. This is a simple example of a transforaminal approach. And if we don't have a good instrument placement, if we don't have a good needle placement, who is crucial step of the procedure, we will not have a success. So the mastery of the technique is learning where along the spine to place correctly the instruments. By the same way, we can go anywhere in the spine. We can go inside the canal. We can go to the posterior part of the disc, to the nucleus, or the anterior part. And when we have a correct needle placement, we will be happy, and we will feel like Julius Caesar, who is a big commandant, who is a big victory, and a young surgeon who feel successful. Really, it's a good sentiment, but sometimes we are confused. We have some difficult patients with many arthrosis, scoliosis, or some other problems. So we lost our way. And when we lost our way, we don't know what to do. We don't have to forget that that we have a patient, and we must to have a strict target, strict procedural approach. If no, we will go outside of our target. So for the patient safety, learning where along the spine to place correctly the needle and our instrument is crucial and essential. So for the safety and success, we need the knowledge of the radiologic anatomy, cross-sectional anatomy, and we must be strict adherence to the procedural technique. For transforaminal approach, sure, we must know the anatomy of intervertebral foramen, who is the area of entry of endoscopic spinal access, and especially the anatomy of the upper part, not only the lower part, but the upper part, where we have some, the nerve root and some vascular tissue. So we need an action plan. We want to put the ball inside, and we have to make some simple calculations. These calculations are simple, like this picture, but sometimes these calculations are very difficult for difficult patients: scoliosis, arthrosis, malposition of the patient, and we need many calculations. We need a good preoperative planning. So, like Plato, he said, we need to know geometry and mathematics for the preoperative planning. So there is some steps, basic steps for every spinal procedure, including also endoscopic spine surgery for all kind of approach, transforaminal, UBA, or stenoscopic. The first is the preoperative planning. We must also analyze the placement of hernia fragment in the lateral and AP X-ray view, because we have all the MRI and CTs of the patients, but during the procedure, we have face to X-ray, to fluoroscopic view. So we must know where is exactly our pathology, our stenosis, or our disc herniation. And we must know that Cummins triangle can sometimes must not be very secure also. There is many articles inside. There is different types of Cummins triangle, and this door can be sometimes a small door. So preoperative radiological analysis is very important. So we must know where we want to go. We will select a transforaminal approach, a UBA approach, inside-out technique, or we target the SAP for outside-in technique. Step 2 is the position of the patient. The patient position is very important, and this is the tool that I use sometimes to be sure that my patient is in correct vertical position in the operating tab. And use of fluoroscopy, learn correctly to use of fluoroscopy is very essential for beginners, because if we don't use, if we don't center the view, the patient to the fluoroscope, we will have big difficulty. And I know that like the surgeon, the fluoroscopy technician also is very important. This is a teamwork, and the work of the fluoroscopy technician is very important for to have a good and easy procedure. A photograph and a fluoroscopic image are both two-dimensional picture. So a shadow, we have a shadow like an X-ray. This shadow must show us the correct ratio, the correct dimensions of our anatomy. A fluoroscopic image of a cylinder from the side is a rectangular image regardless the angle of the beam. But by reviewing a series of images, we are able to mentally construct a three-dimensional picture of this cylinder. Our so we must now use with all with different angle fluoroscopy. It's crucial, and AP and lateral and sometimes oblique view are different, give us different information. So different angles give us different points of view, like some artists or even some toys. So this is a shadow, fluoroscopic image is a shadow, and we must have a correct shadow for good needle placement, for good instrument placement. So like Mahatma Gandhi, he say, every fight is one between different angle of vision illuminating the same truth. So it's crucial, it's very important for beginners to learn how to use fluoroscope for a successful surgery. And I use also always a level specific AP and lateral view, because the spine has multiple curve, and an AP view of L5S1 is not the same view of L3, L4 by the same angle. Even for the end plate, the superior end plate of sacrum and inferior end plate of L5, they don't have the same angle. So CN position on AP, not only for to now our puncture point, also during the procedure, for to know where I am exactly, where is my instruments, where is my punch. It's very important. So we must have also a lateral view, a correct lateral view. So step 4 is the determination of the entry point for inside out technique or for outside in technique, we have different, as you know, targets. Before needle insertion and cannula insertion, we must, inside the annulus, we must have AP and lateral views. For outside in technique, we must sure it's a little bit more difficult and a little bit more different than inside out to be sure that we are on the tip of the SAP. L5S1 for transforaminal approach is sometimes difficult, as you know, and we have different solutions, SAP resection or transiliac approach. And sometimes, depending on the degree of lumbosacral lordosis, the needle skin entry point of L5S1 can be more cranial than for L5S1. Same issue for UBA also. So finally, we have to confirm with contrast solution and where we are. And when we start to our procedure, we must be sure that we are in our target. We don't have to be, for example, anteriorly, if we make a inside out technique. For outside in also, we must be sure that we are on the tip of the SAP, like here, and sometimes if we don't use AP and lateral views at the same time, as you see, we can make some mistakes and some wrong misposition. So I finish my presentation to my friends that essential here before to start to a surgery is the anatomy, correct patient position, and also use of fluoroscopy. Thank you so much.
Okay.
Wonderful talk, Dr. Tunj. Very beautifully and lucidly put across. It was a mix of knowledge, humor, and I think what you really stressed upon is how important it is to be in the correct position to achieve a correct result. And I think that applies to everything in life. So it was a wonderful talk. Really impressed with your talk today, Dr. Tunj. Very enlightening. I will now request Dr. Hayati. Dr. Hayati, if you are present, please do join us and start your screen sharing. Dr. Hayati, are you with us? Hello. Dr. Hayati.
I don't see him
Not joined. So
unmute, please, sir.
Okay.
Can't hear you. The microphone is not working, I don't think.
So weak.
Do you hear me?
Yes, now we can.
Okay. Nice to see you. Dr. Pessanji, how are you? Hi, everyone. Hi, Sung Kim.
Dr.
Kim and Selgun. Nice to see you again.
Yes, pleasure. Please
yes,
start
we
your
used to your excellent organization. I'm so happy to be part of your excellent organization again.
Thank you. Thank you so much.
Pandemic, you know, Otherwise, maybe we will be in Turkey for international UB meeting, but
It's okay.
yes,
It's a changed world. It's a changed world.
yeah.
Welcome, sir. Please start with your screen sharing, sir.
Okay.
We're all waiting to hear you.
Yes, I will talk about some basic issues about the discectomy, endoscopic discectomy. Now,
Just increase your screen sharing, please. Enlarge it. Yes, perfect, perfect. Perfect, sir. And be a little closer to the mic.
so my topic is the UB, actually UB discectomy. I'm doing most UB discectomy. So I saw some issues about the endoscopic discectomies, especially discectomies. So I want to share my opinion and my experience about this, and I want to take your attention on some topics. As you know, disc surgery is one of the main surgical procedures in spine surgery because almost all age group affecting disc diseases. Because of some difficulties about the open surgeries, in surgery, there are many techniques are available today, especially inflammatory responses against to the injury, and ischemia can cause severe adhesions and fibrotic healing. After this surgery, reherniation is the bigger challenge for spine surgery every time. To get good results because of this, to get good result is in a treatment is difficult because of unique biomechanical and anatomical properties of intervertebral disc. So we believe that the surgery should have less footprint on the surgical areas. So the question is which technique is have less footprint on the operating field, and how can we achieve this? As I said before, because of some problems on the open surgeries, the endoscopic surgery in the podium currently, and most of surgeons believe that the endoscopic surgery has less causes less fibrosis because of less footprint. So the question is it true? If is it true, which technique is achieve this? We know that naturally the transforaminal approaches has less fibrotic effect than posterior. As most of all you know, there are some the adhesions can be seen in different locations. Dura phleum and the surrounding tissues, dura phleum, etc. If we look at this according to the technique in tubular and the microsurgery, we will see the dura phleum and surround tissue adhesions and the fibrotic healing. And also we will see the dura bone, dura disc, nerve root bone, and nerve root phleum. In interlaminar endoscopy, phleum and surround tissue fibrosis can be seen, and also dura phleum, dura bone, dura disc, and nerve root bone and phleum. In transforaminal, naturally less fibrotic tissue formation can be seen. Why this fibrotic healing is important? Because of after surgery, we will see that about 28% to 2% reherniation. The literature showing us. And more than 50% of reherniated cases require surgery. Let's see these videos. You see here's the open surgery and the posterior interlaminar surgery and the transforaminal surgery. As you see here, in open surgery, onions to the outside and inside compartment of the operating field. But in posterior endoscopic approach, separated to the operating field inside the canal and outside the canal. And also similar to the transforaminal approach. If we look at this video, this is about after microsurgery revision case. We are doing UBE revision for this case. Please take your attention. Here is the flavum and the fibrotic tissue border. There is no space between flavum and surround soft tissue, severe adhesions between the flavum and dura, severe adhesions between the dura bone, nerve root bone, and nerve root flavum. Because of this, we are doing endoscopy. After endoscopy in interlaminar flavum, we are we should define the flavum removing technique and flavum preserving technique. In flavum, in interlaminar surgery, flavum playing a key role about the adhesions, but in transforaminal surgery, the epidural tissues play a key role. This is the, after UBE discectomy. This is my another revision case. I'm doing a revision case for reherniation. If you notice that there is no severe adhesions between the flavum to surround tissues. Yes, the endoscopy, posterior endoscopic approach is working very well. Here you see there is intact flavum and no severe adhesions in with the surround tissues, and the intact bone and flavum border we can see. We are using the flavum preserving technique for primary procedures. Now you see, even though flavum preserving technique, the epidural fibrosis and severe adhesions can be seen. We should be aware of them. You see the very severe adhesions between the dura and the flavum, even flavum preserving technique. Here. Because of this, I'm trying to make in a left side surgical approach, not right side surgical approach to the disc herniation. We are talking about the disc herniation, not the stenosis. Stenosis is wholly different procedure, but disc surgery should be careful because of the reherniation possibility. So I want to show you the flavum preserving technique. First, I'm removing the superficial layer of the flavum, and I'm trying to left intact of the deep layer of the flavum. And then we are using the limited laminotomy to make pinpoint approach. I will show you what's mean pinpoint approach. Here, just sparing to the flavum without touching the flavum epidural interface. It's not necessary to touch to the flavum dura interface. Also, dura disc interface, very important. After the wiping to the flavum, maybe in the future we can develop to the flavum repairing techniques, but it's not important actually. The important thing is to not touch to the, do not touch to the flavum epidural interface. So I do not separate the epidural flavum interface and want to just limited flavum window and do not touch to the epidural fat pad. And we use coagulator and radiofrequency probe as less as possible. And we should not manipulate to the nerve root if it's not necessary. And the exploring of the disc around is not necessary and is not good. And you do not touch to the dura disc interface. To make optimum surgical plan for using target-oriented approach, we need to make high quality and current radiological work. If your approach is not correct and if you trying to find the fragments into the canal, if you faced with reherniation, you should know that you are in trouble. And choosing the correct and appropriate technique is very crucial. For example, if you have intraforaminal or nearby foramen disc herniation, you can choose the transforaminal approach or interlaminar approach. So we are trying to preserve the epidural tissues. This is previous case, my case, and I showed you the revision case. The revision case video belongs to this previous surgery. After this surgery, we faced with the reherniation and we revised, and you saw the dura and the flavum adhesions after this surgery. In conclusion, of course, the less footprint is important factor for less fibrosis formation. Endoscopic surgery has big advantages to protect to the anatomic structures, which inside and outside of the spinal canal. But interlaminar endoscopic interventions can cause severe adhesions inside of the spinal canal. So the high quality radiological workups is crucial to establish proper surgical plan. And target-oriented approach should be done. Consider using the adhesion barrier in surgery, and in revisions, choosing the friendly tissue can provide safe surgery. Thank you for your attention.
Hayati,
yes,
that wonderful, wonderful talk.
Thank you.
I think you have opened our eyes to a very, very different concept overall. I mean, it's one of the first talks that I've ever heard about in endoscopic spine about tissue sparing, you know. We only have that concept that endoscopy itself is tissue sparing, and in endoscopy you're talking of tissue sparing, which is unbelievable. I mean, it's a wonderful concept. I'm sure. I mean, I'm going to take your concept to heart. I'm going to be more phlegm sparing, more epidural tissue sparing. Try and strip less. You know, our human nature is that we want to see the cord, we want to see the root very carefully, and in that we tend to do more and more of stripping. We feel that being endoscopic surgeons, we are doing less stripping, but maybe your talk is an eye opener for all of us. So I really appreciate your talk, and I will request the audience to be ready with their questions to bombard at you also at the end of this session so that the panelists can get together. In the meanwhile, I will now request Shidem, Dr. Shidem, if she's available, please come online. Please start your screen sharing, and Hayati, if you can just now please stop your screen sharing.
Okay.
Thank you so much. Dr. Shidem, are you there? We are waiting for you. But Hayati, your talk was amazing, amazing. And one of the best talks I've heard since morning. And I'm not ashamed to say that. Trust me, guys. This was mind-boggling. It was really eye-opening, you know.
Oh, good.
Tissue sparing has to be a concept, whether we are at the microsurgical level or we are even mini microsurgical level in the future. But tissue sparing is a theme that, I mean, it's a wonderful talk, believe me.
Thank you very much.
Very beautiful. Shidem, are you there? Dr. Mumsu. Dr. Mumsu, are you on? Can we hear you? I think otherwise we will have to go ahead with our next talk and reschedule with Dr. Shidem later. Dr. Shidem, can we hear you, please? I'm not able to get through to her. Dr. Hayati,
I'm calling. Yes, I'm calling. I'm calling here.
Please. I think this session has been all about a lot of revelations. Dr. Choi's first talk was wonderful because he concentrated on the contralateral approach to migrated upward and downward discs, which is a very fantastic way of, you know, putting things across. Dr. Jinwon.
Hadi hemen bekliyoruz, seni bekliyoruz.
Dr. Jinwon.
Hayır, çabuk hemen seni şu anda bekliyoruz. Hızlı. Tamam. Tamam, okay.
Dr. Ann's talk was amazing because
she's coming.
Yeah. It spoke to us wonderfully about the basics of UB, the history of UB, and
Dr. Pansonji?
Yes.
There are a question about the hypertrophic compressive annulus, debris or neglect. I want to answer this question. It depends on the location and the compression effect on this. If you can debride it, or you can remove the behind of the tissues to make the compressed neural tissues, not trying to debride all the scar tissues from the tooth.
Dr. DL, you are a master surgeon, and this is a master question from you. So with all due respect to you, and while we are waiting for Dr. Mumsu to join on, I would definitely like to answer this question. If there is a herniation and a hypertrophic compressive annulus, and if it's a broad-based annulus, I would prefer to neglect it after I do adequate decompression of the phlegm and make sure that both the exiting roots and traversing roots are free. Because I believe that saving the annulus under whatever circumstances possible is the best option. A bad annulus is better than no annulus. So destroying an annulus further to try and decompress it, especially if it's a broad-based annulus, I don't think is the key answer. I feel the key answer is adequate decompression, making sure that the roots are free, both the exiting and the traversing. So making sure that you visualize all the 4 roots is a better answer. I hope that satisfies the question. And Dr. Shidem, are you on? Has Dr. Shidem joined us? Can she start her screen sharing? We are waiting for her.
Hi.
Welcome, Dr. Shidem. Please start your screen sharing.
Yeah, okay. I'm sorry to.
Take your own time. Take your own time. No
Thank
hurry.
you. Thank you so much.
Be comfortable. Yeah, I can think we can see you and we can hear you. You're welcome to start, ma'am.
Okay. Sure.
It's okay now. We are seeing
Okay.
your presentation. You can start.
Okay. Yeah.
Presentation. Please start with your next slide.
Yeah. Thank you. Thank you very much. Şuradan. Yeah. Can you see my presentation now?
Yes, we. Yes, yes.
Okay. Good. I will present to you about patient safety in UBE, things to consider. UBE is an elegant and fantastic endoscopic technique in spine surgery field, but it is technically difficult, especially for neurosurgeons, as they are not familiar to arthroscopic equipment. So the neurosurgeons need to learn manual skills. There is no doubt about it, and every surgeon knows that there's a considerable learning curve. So the surgeons need to be trained spatially, and there is, of course, there is a long learning process. The team is very important. It's only the surgeon who must be trained the manual skills, but also your team, your nurses, your technical staff. Yeah. Sorry. Sorry, the team is very important. It's only the surgeon who must be trained the manual skills, but also your team, your nurses, your technical staff must be trained too. That means your nurses need to know how to set up the water pump of the irrigation system, or how to connect your video system. So there are a lot of details. So I recommend that not just you as a surgeon receive training, but also your team for patient safety. We know that there's a considerable learning curve in UBE. So when you start UBE, we recommend you to start with easy discectomy cases at the level which has interlaminar window that is much wider, so it gives you much maneuverability. Later on, start with discectomy on the level of L4-5. When you have more practicing, then you can do lateral recess decompression at the level of L4-5 and or L5-S1. And when you get more practicing with using PER, you can start over the top decompression. Then finally, you can start posterior foraminotomy in the cervical spine or far lateral discectomy. For patient safety, operative preparing is very important. We perform UBE under general anesthesia because general anesthesia is more comfortable for the patient and for the surgeon. The patient position is a prone position. We open up the operating table in order to widen the interlaminar window. This makes the surgery a little bit easier. Also, especially 5 or 10-degree head-up position is necessary to protect optimum ISP during the surgery. In my microscopic surgery, some surgeons use Wilson frame to make kyphotic posture to wide interlaminar space. Kyphotic posture may increase epidural pressure that may lead to more epidural bleeding. We recommend using neutral rolling pad. That is the important key. You can see operative steps. We know skin marking is basic for UBE. Two portals must form a triangle. That is very important. Also, it's important knowing how to use irrigation system for fluid control, clear view, and bleeding control. When you prepare interlaminar space, next step is similar to open microdiscectomy or microdecompression. You can see triangulation. If you lose anatomic orientation, the procedure becomes a little bit dangerous. We always need to know exactly where we are. We need to have full orientation. If you think you are getting lost at the beginning, you must convert to microsurgery. When you finish surgery, you should always put pneumatic drain for bleeding control for 1 day to all patients. When it is clear, we remove it. Post-operative first day, patient full mobilized and checked MRI, and patient discharged. Brace is necessary for 1 month, full unlimited return to all daily life after 1 month. I'd like to mention about my UBE cases. I've been doing UBE over 1 year. Till now, I've done 193 cases. I faced serious complications in the beginning, such as bilateral visual loss, paraspinal infection, incomplete decompression. I had to turn open surgery for 5 cases. Day by day, I learned how to avoid complications. Now I will share what I learned with you. What are the things to avoid for patient safety? More muscle damage, maybe muscle edema, so it may lead to infection, high hydrostatic pressure, RF damage, joint violation, and dural tear, also cord injury. What is the cause of critical damage? Surgical view must be clear to get good result. To have good vision, you must handle closer. The scopic hand is always movable, so you can go more deeper. That is the important key. If there is bleeding, move scope much deeper. You can use suction tip like a natural drain as inserted here. Then let fluid and blood exit, or you can use Bomax sometimes. High hydrostatic Pressure leads CNS problems, long level epidural hematoma, massive abdominal fluid collection, and sometimes hypothermia. What is the CNS problems? Posterior neck pain, a headache, if long time operating with dural tear, late awakening, hydrocephalus, pneumocephalus, seizure. The most serious complication is the visual loss due to retinal hemorrhage. What is the theory for retinal hemorrhage? If rapid epidural fluid injections cause a sudden increase in ISP, the increase in CSF pressure causes an increase of retinal venous pressure. The retinal vein ruptures, which result in retinal hemorrhages. I have one case like this. The patient is 28 years old, man, suffered from low back and right leg pain due to F5S1 discamnation. He underwent UB surgery. There was no dural injury or any complication during the surgery. Post-operative was bilaterally. He was immediately referred to the ophthalmology. He had bilateral retinal hemorrhage. He was applied YAG laser in the both eyes. 1 month later, his visual acuity increased and the hemorrhages were remarkably resolved. Optimal pressure must be 30 and 50 millimeter mercury in OP field. How to control optimal hydrostatic pressure? As I said before, first, patient must be in head-up position. Second, always we have to control output. For this, the nurse holds the UB retractor. So continuous output is to prevent how to control bleeding during UBE. Systolic blood pressure should be 100 millimeter mercury. If active bleeding, we use during coagulation with RF device. Sometimes we use bone marks. Usually epidural when bleeds, if you don't know where the focus of bleeding is, close the irrigation fluid and wait just 2 or 3 minutes. Clotting will happen spontaneously for bleeding control. Then you can restart. To prevent the infection, the operative window should be wide. All fluid must be drained outside of the body. If we use small operative window, fluid enter the abdominal surface. Also, long time surgery gets abdominal surface wet, which causes hypothermia. How to use RF devices? We must use RF probe with drainage tube, and we use RF short and repeatedly. Outer ligamentum flavum area coagulation should be 2. Ablation is 7. Epidural space coagulation is should be 1. Ablation should be 3. Just near dura, we don't use ablation. What is the RF damage? Low temperature burn. I have one case, skin multiple blisters around scar and direct neural injury, maybe caudal syndrome. How to prevent RF damage? Direct touch on dura of lumbar spine is relatively permitted, but on cervical it isn't. Don't touch directly on dura of cord level, short and repeated use. How to prevent infection? To be careful is gold standard. We should prevent contamination of instruments, irrigation fluid, drip sheet, serial dilators, and tube. This is my patient. She is 42 years old. She had left leg pain during 6 months. I did UBE. This is preoperative MRI. This MRI is postoperative second day. Later, the patient was discharged postoperative second day. About 5 days later, she came to my hospital. Her severe leg and back pain and contraction. You can see there is a hyperintensity zone, this paraspinal area. At that time, I did open surgery. When I cut fascia, all purulent infection material came out. She undertaken antibiotherapy for a long time. This MRI is 2 weeks after second surgery. Now she is doing fine. I want to show you a short video, which is one of my patients. As you can see, surgical view is clear and no bleeding. Mm-hmm. Yeah. Success in UBE with no patient complaints depends on being careful about these details. Many thanks to my great mentors, Dr. Hayati and Dr. San, and to you, Dr. Malcolm. Thank you so much for listening to me.
Thank you so much, Dr. Mumsu. It takes a lot of courage to speak about your complications honestly, openly, and to educate the world. I'm really grateful to you today for your talk, and I really congratulate you.
Thank you so much.
You deserve the highest of respect, because this level of transparency and sharing of information, especially our own problems, is vital in the learning curve of all those who follow in our paths. There is a saying that I saw beyond the shoulders of my mentor, because he allowed me to stand on his shoulder and see the world beyond. And ma'am, today you have shown us something so much that all new people who are going to learn endoscopy, join endoscopy, progress in endoscopy, this lecture is going to be saved, heard, remembered for a long time to come. I'm really proud to have you as a speaker today and to have you as a panelist today. It takes a lot of courage to stand up and speak. It takes a lot of courage to speak about our problems, to be honest about them. And I'm really appreciative of your talk today. Fantastic talk. Congratulations once again. Congratulations.
Thank you.
I will now request our last speaker, young master Man-Kyu Park from South Korea, dynamic, young, aggressive, and a fantastic UB surgeon. Welcome on board, Dr. Man-Kyu Park. We are waiting for you. And Shidem, I'll now request you to stop your screen share. Welcome, Man-Kyu Park.
Thank you for a great introduction. Hello, everyone. And I'm gonna start my topic.
صار توبك جديد.
Can you hear my voice?
Yes.
And okay, I'm gonna start.
Unilateral laminectomy,
A member of
and bilateral
Endoscopy
decompression.
working at the Bagonuk Hospital in Korea. I have been learning from Dr. Son, who is a UB innovator and master, and working with him at the same hospital. Today, it's an honor to address the great conference, and let me begin by expressing my gratitude to the gracious host, Dr. Malcolm Pestonji, and all distinguished doctors to be here to discuss UBE. Today, I would like to talk about lumbar ULBD by UBE, and especially I'm gonna focus on surgical step in detail. Effort to minimize invasiveness more and more, most surgery have been performed endoscopically. Various kinds of endoscopic surgery are attempted for lumbar spinal stenosis. UB is one of them. As you know, UB have many advantages, especially we could obtain highly magnified and blood-rich surgical view compared to microscopic surgery. Moreover, UB use two-portal and through semitubular retractor. For this reason, there are a little motion and vision limitation. That is a big pros. In this section, I'm gonna tell you about UB indication. UB central decompression have a wide indication. I will show you some cases. This is a case of lumbar multilevel stenosis that is operated by UBE. Even with the multilevel lumbar stenosis, there are a little muscle damages. Next, with a narrow width of lamina, even with upper lumbar level stenosis, UB can do it without facet violation. Furthermore, complicated cases such as revision surgery or ASD, UB can do it without difficulty. And now I'm gonna talk about surgical step in detail, and I will explain with a video clip and step by step. First, I think making portal is most important because improper location of a portal can make the surgery difficult throughout the operation. And we should keep in mind, first, under C-arm radiography, the exact target point is here, ipsilateral cranial lamina, and then through a line, pedicle medial margin. Above this line, two skin entries about 3 centimeters apart are made, centered on the target point. And then we recommend to use dominant hand for working portal, non-dominant hand for scope portal. And this is so important. Serial dilator and scope portal should make a triangulation above the target point, like this. Before I start to explain surgical step, I would like to emphasize the use of a semitubular retractor. As I mentioned earlier, UB uses a semitubular retractor, not instead of a tubular system. And then there is a little motion and vision limitation. In addition, it is a tool that keeps continuous fluid output like this, and act as an instrument guide and soft tissue retractor. For safe and effective UV surgery, we strongly recommend to use a UV semitubular retractor. Next, here is what I want you to know. This is so important. Many surgeons try to do UV, but without figure out this concept, that surgery makes difficult or fail. When making portal, we use this potential space that is between multifidus muscle. When making portal, after making portal, hydrostatic pressure and retraction of the multifidus muscle could make enlarge the initial working space, so-called zone space. Zone space refers to enlarge the initial working space. This concept provided a benefit, preserve the multifidus muscle, and start operation as soon as possible. I will show you how to make an initial working space. This is a start operation. Operation stand at the left side of the patient. The left is cranial, right side is caudal. Start operation. After retraction of the soft tissue, initial working space are made above the target lamina under endoscopic guidance. Radio frequency probe is used for coagulation of the tissue, and then confirmation interlaminar space. As you can see, in less than 30 seconds, we can make an initial working space without with minimal muscle damages. Next, we're gonna make a true working space after removing ipsilateral laminotomy and removing the base of the spinous process. As you know, generally the base of the spinous process obstructs the placement of the scope and instrument. That makes the surgery difficult. And then, firstly, we're gonna remove the base of the spinous process. Next, ipsilateral laminotomy. After that, we could obtain true working space for decompression. This video shows how to make a true working space. After confirmation, caudal lamina edge and the base of the spinous process. First, we're gonna drill the base of the spinous process because the base of the spinous process obstruct the scope and instrument. After enough of this area enough, we could obtain true working space for performing decompression with minimal limitation. Next, I'm gonna move on to ipsilateral laminotomy. Confirm ligament problem. Ipsilateral laminotomy performed with the caris longer, like this. And next, we use drill. And ipsilateral laminotomy is performed until the midline fissure of ligament problem is confirmed. As you know, the surgical view of UV is similar with the microscopic surgery, but the big difference is highly magnified surgical view, and then it is important to determine the anatomical landmark for orientation. And the midline fissure of ligament problem is anatomical landmark here. You can see that represents the midline of orientation. Based on that landmark, we're gonna perform ipsilateral laminotomy with caris longer, like this. And next, we use a drill. And you can see when drilling, we use a ligament problem as a protector. Next, let me begin to show contralateral decompression. For contralateral decompression, contralateral ligament problem is detached by free elevator from the contralateral sublamina. Contralateral sublamina area and caudal lamina is confirmed by a radio frequency probe. After that, here sublamina area is decompressed by sublamina drilling, like this. you can see the contralateral ligament problem should preserved until the completion of contralateral bone working, because it play a role as a protector for drilling. It look like safe. And that's all contralateral bone working. And then next we're gonna cranial bone working. How much bone working should be done superiorly? Here is anatomical landmark. And cranial bone working is removed up to the cranial attachment of the ligamentum flavum, which usually represent the uppermost aspect of the canal stenosis. More cranial drilling up to we can identify the attachment of the ligamentum flavum. We're gonna drill more cranially. We can identify if there are cranial attachment of the ligamentum flavum. That is anatomical landmark for cranial limitation of decompression. Next, to effectively remove ligamentum flavum, we should understand the anatomy of ligamentum flavum. I will skip that because you all knows about that. And next, how to remove ligamentum flavum's ambula. Here, we could detach the ligamentum flavum to superficial layer by sweeping over caudal lamina's posterior surface like this. And then superficial layers could be easily removed like this. After removing superficial layer, we could identify a junction between caudal lamina and lateral portion of SAP. Okay, next. This is how to remove ligamentum flavums. We could detach the ligamentum flavum to superficial layer by sweep over posterior surface of the caudal lamina. We can easily detach it like this. Further, lateral portion of the ligamentum flavum is removed by Fourier elevator. Serial removal, and then we can identify anatomical landmark junction, caudal lamina and SAP. Below this, we can find traversing root and the lateral margin of the Decker sac. This technique is so safe, and we could prevent the dural tear and serially detach the ligamentum flavum from the caudal lamina and SAP. You can see the ligamentum flavum can be naturally detached. And we proceed ligamentum flavum detached from the SAP. And contralateral side also, firstly, we're gonna remove the ligamentum flavum to superficial layer. And it's important to understand the anatomy of the ligamentum flavum. Firstly, remove ligamentum flavum to superficial layer. And Fourier elevator could be used by the plane between dural and ligamentum flavum, ensuring that it is free from adhesion. And next, calcium punch could be peel off the ligamentum flavum. Fourier elevator also is used to detach the ligamentum flavum from SAP. And using Kel's plunger, more detached the caudal portion of the ligamentum flavum. And eventually we could identify contralateral traversing route. And after release ligamentum flavum, the ligamentum flavum could be easily removed and block time. And this technique could prevent the dural tear and other complications. After removing ligamentum flavum, and next, remove more remnant lateral ligaments, ensuring that disc space and the lateral margin of the decal sac. Curved calyx plunger is helpful for decompression of lateral recess. And if you need it, after releasing the adhesion, the UV retractor could be used discectomy. Contralateral side also is confirmed by free mobilization of the contralateral nerve root. That's all I have to say. And thank you for your attention. And after COVID-19, I hope to see you again as soon as possible. Thank you.
Thank you, Mankyu Park. Thank you, Dr. Mankyu Park. Thank you so much. Wonderful presentation. Approach to UB, management of ligamentum flavum, its detachment, decompression at the spinous process, at the base of the spinous process, going to the opposite side before you open the flavum. Essential steps, whether it be in UB or whether it be even in monoportal or PSLD, whatever you call it, whatever endoscopic technique you call it, posterior midline. Your steps were wonderfully executed and presented. The separation of the flavum was beautifully elucidated by you. So congratulations on a wonderful talk. I will now request our host, Dr. Bennett, to call all the panelists online. We have a few questions that we need to be answered. I think Dr. Hayati has been answering a few questions on the side by himself, so I'm grateful to that. But should anybody have any questions, they are welcome to ask. Otherwise, I would like to go ahead with my concluding comments, and then we take a break and come back later. So anybody from the public would like to put up a question? We are waiting for it. Dr. Hayati has already answered you that the fluid bag should be around 170 centimeters from the ground and 100 centimeters from the tabletop. Usually should match your head height or maybe a few centimeters above that, depending on your comfort and your height. Mankyu Park is a tall fellow, so he needs the bag a little lower. But the rest of us, we need the bag a little higher because we are short. So that's a wonderful thing. Going back to Dr. DL's question, yes, there is always a balance about stripping of the flavum and decompression that is needed, especially when there is a hypertrophic compressive disc. So those are the exceptions that need to be answered and one needs to think of. But when there is an axillary disc herniation or when there is a small disc herniation which is paraxillary or in the axilla, definitely going to the superior margin, going to the tip of the SAP, stripping the flavum only in that corner, and accurately removing that disc with minimally invasive technique. That is the beautiful thing that was elucidated by our good friend, Dr. Hayati. I think this was a very, very informative session amongst all the sessions that we've had since the morning. I really appreciate Dr. Mumsu's honest approach to endoscopy. She has in a way put all of us to shame. She has made us realize how important it is to talk about the negative aspects of endoscopy, because what we learn and what we share is what prevents patients from getting affected at a later stage. So really appreciate, hats off to her for her talk. Dr. Tunj, your talk was excellent as usual, full of mirth, but with a deep underlying message that one needs to be on target, one needs to be perfect if one is going to achieve success. Success, whether it be in posterior endoscopy, whether it be in transforaminal endoscopy, everything starts with your docking, everything starts with your approach. And if you fail in your approach, you fail, I mean, the whole building collapses. So when we talk of pinpoint surgery, when we talk of targeted surgery, needle placement is of vital, or even your skin markings are vital. Correlation with anatomy, especially fluoroscopic anatomy, is vital. So Dr. Tunch, that was an excellent talk by you. Dr. Ann, once again, very grateful for your very basic and a very beautiful talk about UB's history. And you have led us through a very wonderful part of history also. And you have led us to understand UB in a very, very basic and a beautiful manner. Dr. Choi, yours talk, especially the part about stenosis and how you approach stenosis, how you approach migrated discs, how you use the contralateral approach. Wonderful talk. Amazing, amazing talk by all panelists in this particular session. And there is one question that if one has to return to full work after 1 month, how is it a minimally invasive procedure? Now, gentlemen, minimally invasive procedure is where we do minimal damage to a tissue. Return to work and getting back to life is partially dedicated and dictated by annular healing. Annular healing is not in the hands of any one single surgeon. Annular healing is a pathological process by itself. Depending upon the annular tear, the size of the annular tear, lies the incidence of reherniation. Reherniation is higher in patients who have large annular tears, especially tears which are more than 6 millimeters. So advise to be gentle, to be steady, and to get back to work gradually is not based upon the surgical technique. It is basically staged and set upon how bad is the annular tear, how bad is the herniation, what is the incidence or the likelihood of a reherniation. That is what determines how fast you get back to normal life. I feel so understanding annular healing is a very vital part of understanding the spine pathology and degenerative spine. There was one question regarding incidence of dural tear and CSF leak during endoscopic discectomy. Is it zero? Has it happened to someone? Let me assure you that with transforaminal endoscopic discectomy, if you follow the inside out or even the outside in technique, the incidence is very, very low. With posterior midline endoscopy, whether it be UB, monoportal, or PSLD, the incidence is a little high in your initial learning curve. When you learn to be stable, when you learn to gradually dissect your tissues, be liberal about using the hook or the dissector, then I feel gradually the incidence comes down to near zero. I think in my last few hundred cases, I don't think I had a single dural tear. And I pray to God in all his forms that the incidence remains very low. Sometimes we do have a tear, but the tear is very small. We are able to manage the tear by a stapler, by using a dural plug, or by even just, ignoring it, because the muscle base and everything falls back. And usually these small tears are not really of vital importance. But as my dear friend Hayati mentioned, if the tear is significant, if the tear is large, please proceed with microendoscopic discectomy, repair the tear properly. Let not the patient suffer. Let us not do any harm when we learn a new technique and we progress in a new technique. So I think that just about answers all questions that have been put across to us. I'm grateful to all of you. I think we will now take a break and we shall get back to our next session, which will be at 3 p.m. sharp. Thank you very much, all of you. Dr. Bennett, I request you all to please end this session. Thank you so much. Thank you, everybody. Bye-bye. Thank you, everyone. Mankyo Park, nice to see you, buddy. Been a long time. Huh? Bye. We get back at 3 o'clock. Till then, we exit. Thank you. Thank you. We are all leaving the meeting now. Lunch break. We are now waiting for Dr. Mohinder Kaushal and others to join our team and start our next session. Dr. Bennett, if you can help me check whether the others have joined in. Our actually first speaker is going to be, there's a slight change in program. So our first speaker is going to be Dr. Kaushal, maybe Yusuf, Paresh Chandra Dey. So I'm waiting for any of them to join in. Dr. Mohinder Kaushal, we are waiting for you, sir.
Hello. I can see you.
Yeah, John, Dr. Malcolm here. Dr. Rohidas is trying to join us, John. Dr. Bennett, can you hear me? Dr. Bennett, I can't hear you. Hello, you're muted. John?
Hello.
Hello?
Hello.
Rohidas, sir, 1 minute. Bennett, Dr. Bennett.
Yes, can you hear me?
Yeah, I can hear you. Dr. Rohidas is trying to join us. Can you please allow him in? He is not able, he is able to see me, but he's not able to see others.
Okay, what's the name again?
Dr. Rohidas.
R with an R?
Yeah, R with an R. Dr. Srinivas Rohidas. Dr. Mohinder Kaushal, they're all waiting, sir, to join in. Dr. Dey?
I can see Dr. Buhida and attendees. Can you please, John, upgrade him to panelist?
हेलो बोलिए आपने ज्वाइन कर लिया ओके देन आपका टॉक चालू कर देते आप you are ready now we'll start with your talk sir.
Okay. Dr. Shauhan?
Okay, John, can you please upgrade us to co-host?
Dr.
Okay,
कोई
special नहीं है.
Okay, what are the names?
Hold on. 1 minute, Dr. Dey. I am seeing you now. Will you please hold 1 minute, Dr. Dey, please?
Yeah. Okay.
1 minute, please.
Okay,
Hello,
what
John.
name needs to be admitted? Well, tell me the names, one by one.
Yeah, one by one is Dr. Abdul Halim Yusuf.
How do you spell that?
It's in the schedule, yeah, John. Abdul Halim Yusuf, Y-U-S-U-F.
John, please upgrade me to co-host and I will manage. I already see them in attendees.
Okay, let me put you as a co-host here. Okay.
Okay.
Then you can admit them.
They're all waiting.
I can't even find you, Sam.
Yeah, I don't know what's happening, John.
I
Well,
am
what's
in
happening? You
panelist.
took a long
I am in
break,
panelist.
so there's no hurry.
Yeah, there's no hurry. There's no hurry.
No hurry. You took a long break.
Okay.
Yeah.
So let's.
Dr. PC Day.
Okay.
Dr. Srinivas Rohidas.
Okay. I am in panelist, John. Just
Okay, I
upgrade
got
me
you. I got
and
you, Sam.
I will manage. Okay.
Hold on, Sam. I'm waiting. I'm getting you in.
Okay.
I am not able to see them.
They are in attendees, not in panelist.
Okay, Sam, I'm trying to get you. I'm trying to get you. It's not easy, especially when it's not prepared.
Yeah,
Okay.
in attendees, Dr. Srinivas Rohidas is there. Dr. Abdul Halim Yusuf is there.
Okay, just upgrade me to co-host and I will manage.
Okay.
Yeah, Dr. Paresh Day is also being seen in attendees.
Okay.
Can you please bring them as panelists?
Yeah.
Dr. Paresh Day, Dr. Srinivas Rohidas, and Dr. Abdul Halim Yusuf. I see all of them. They're all in the attendees list.
I'm trying to get Sam in here, but it's difficult.
Yeah, it's okay. You first bring Dr. Srinivas Rohidas and Dr. Abdul Halim Yusuf from the attendees list into the panelist. Can you do that?
Oh man, I'm trying to get Sam in here, but I'm having difficulty.
That's okay. I'm telling you, please get Dr.
Hold on.
Srinivas first. And Dr. Day.
Okay, Sam, you're co-host, Sam. So let the appropriate people in.
Yeah, Dr. Srinivas Rohidas.
You got that, Sam? Hello, Sam, you got that?
Yeah, I can't hear Sam's mic. His mic is muted.
Okay. I just upgrading them now.
Yes, please upgrade Dr. Srinivas Rohidas also.
Done.
And Dr. Day, D-E-Y. Paresh Day, Dr. Paresh Day.
Okay.
So now, Dr. Day, can you see? Hello, Dr. Day. You're on now. Are you?
I have muted them. You are muted.
Hello.
Dr. Malcolm.
Yes,
you
I'm
are
muted. I'm unmuted now.
I have upgraded them.
Yes, please, thank you. There is one more Dr. Mohinder Kaushal. We are waiting for him to join. When he joins, please update him also.
Malcolm.
Okay.
Yes, sir.
If PC Day is ready, start with his talk.
Yeah, Dr. Day, can you start with your talk? Can you start with your screen sharing, please?
Hello.
Yeah, welcome, Dr. Day. Welcome.
Yes.
Nice
Hello.
to see you once again after a long time.
Thank you. Thank you so much.
Welcome. We have a wonderful session today on the Dastandu technique, and you people are masters of it. Hats off to you for your work, for the work of Dr. Srinivas and Dr. Mohinder Kaushal and all of you. So we've had this one very special session for endoscopic spine. And welcome, sir, and please start your screen sharing. We're waiting to listen to you, sir. Welcome, sir. Please start.
So Rohidas is going to start?
No, sir, you
No,
are
no,
starting.
I'll talk at the last.
Okay, so I have to start.
You
Okay.
start with your presentation.
Correct. Okay. Are you able to see my screen?
Yes.
Are you able to see my screen? Malcolm?
Yeah, we are able to see your
Yes.
screen, sir. Please start, sir. Please start.
Okay. So hi to everybody. I'm going to speak on this Destendo technique because of this Rohidas was supposed to start. Two-level recurrent disc herniation is an endoscopic decompression. The recurrent disc herniation maximum, I think there's a 6 month is the limit period that is to the index surgery. And recurrence that occurs at a short time after the primary surgery, most of which are caused by the surgical omission. MRI with contrast is helpful to differentiate the recurrent disc herniation from the perinular fibrosis. The facts are, the majority of the surgeons prefer to use the standard open microdiscectomy to treat the recurrences. Wider exposure is assumed to provide for the more convenient recognition of the anatomical landmarks and tissue manipulation. Could be justified for less neural damage, which may lead to the decreased stability, so fusion surgery may be considered in some cases. This article shows, it is published from the Freiburg, Germany in 2016, shows the outcome were reported to be equal and sometimes favorable compared to the open and microdiscectomy for the recurrent lumbar disc herniation. Overall success rate is 90%. This is minimal invasive tubular microdiscectomy for the recurrent lumbar disc herniation. Operating time was 90 minutes, little higher and plus minus 30 minutes. Incidental durotomy, 5 patients out of 30 patients. 2 patients developed instability and requires fusion. This is the most comprehensive and detailed meta-analysis involved a total of 20,390 patients and 63 studies from 13 countries. PTD, that percutaneous endoscopy, transforaminal discectomy working channel is placed inside the nucleus pulposus with a very steep trajectory angle to recurrent central disc herniation. As a result, it is not easily accessible. Now come to the full endoscopic lumbar discectomy for the recurrent disc herniation after open discectomy. This article is published in South Korea in 2019. Shows higher risk of the complications which includes the persistent leg pain controlled by the epidural injections. Are you able to listen me?
Not able to listen to you. There's somebody here who's bombing our people.
Okay. So the role of the full endoscopic lumbar discectomy, another article is published in 2019, also shows the limitations are the upward migrated disc at the shoulder and the nerve root, and the central or the lateral canal stenosis. Now come thought of the my technique, that is endoscopic Destendo technique, provides the clear differentiation of the neural structure from the scar tissue. Adhesivolysis performed while preserving the stability of the remnant facet joint would lower the risk of the complications, and no limitation from the upward or downward migrated disc, central disc, lateral canal stenosis, L5S1 level, etc. Most important is could avoid the unnecessary fusion surgery by this technique. The endospine system is a mobile operating tube, that is a Destendo system. Panoramic view could be obtained with this mobile operating tube. The scar tissue is clearly differentiated from the bony tissue under the endoscopic view in order to protect the neural tissue. Deeper dissection along the bony surfaces from the facet to the base of the pedicle could easily be performed. So operating tube is mobile, illuminate and explore the hidden recesses. It can be mobilized in all directions, like medial, lateral, cranial and caudal with the help of the left hand, the suction tip, and right hand of the instruments or the operating instrument. The magnified view eye is practically inside the spine, so advantage in obese patient also. The positioning of the patient, knee chest position increases the interlaminar space by distraction. Complete relaxation of the abdomen reduces the epidural venous plexus pressure. Head and little bit down, that is about 1.5 to 2 inches, helps to reduce the bleeding. We are putting the patient in the knee chest position on the bolster. We have a special localizing device with 2 bars in the laterally and then 2 knobs on the both side of the spinous process. We are not taking any epi view. We are just taking the lateral view with the help of this special localizing device. 2 bars should be parallel to each other and parallel to this space, and then mark with the marker pen on the dorsal surface. It is a operative technique is a interlaminar window approach, and we have a very few set of instruments. It is a press fit technique between the spinous process and the muscles. There is no special device to fix it, and we have a both the hand are free of the surgeons because of the stability of the instrument. It is very stable instruments. Now come to an example of 62 years lady undergone open laminectomy in the nerve root decompression for the lumbar canal stenosis at L4, L5 and L5S1 in December 2012. In 2014, crippling pain starts due to the recurrence of the herniation disc. Epidural nerve block given in 2015 Jan. There was a temporary relief for 3 months, and consulted many places. There was a mixed opinion for the fixation and the conservative treatment. She landed into my place in 2016 June. We have taken this X-ray. This clearly shows there is a wide laminectomy done from L4, L5 to L5S1. And then we have done the contrast MRI, which shows there is a disc herniation and compressing the nerve root of the right side. And then most recurrent disc herniation of the disc prolapse type. Scarring generally does not generate the nerve compression symptoms. Therefore, the dissections of the scar tissue from the nerve is not difficult, but a small amount of herniated nucleus pulposus could cause the nerve compression. Now see this video, it clearly shows that we are going from the bone to the soft tissue. That is the most important tips, that we have to hit the bone first and gradually differentiate between the bone and the soft tissue, then make a cleavage. Once you got a cleavage, that I think 50% work done. We have a special instrument is called nerve root retractor that retracts medially with the help of this nerve root retractor, that soft tissue, fibrous tissue, nerve and the dura edge to toe, and we are making a cleavage between the bone and the soft tissue and then directly on the disc space. Another patient, 56 years male, low backache with the right severe radiculopathy, was on January 2016. It is extruded disc migrated downward, L4, L5. And then it was the axial view shows that was the compression on the right side. It is micro discectomy done. And after 7.5 months, the patient had severe pain. And this was the situation of the when he presented with the 7 days history to me, when he was not able to stand without support. So this was the MRI we have done with the contrast and confirmed there was a disc at the same level L4, L5 and was compressing of the right side again. We planned for the recurrent disc surgery with the help of a stenting technique. So this is a video shows there is a almost like a never-ending process. We are just trying to remove the disc and it was coming continuously. So the recurrent disc herniation, more aggressive disc removal does not reduce these complications, may be detrimental to the functional segment, but the complete decompression is a must to prevent the relapse. So there is almost like a never-ending process, but it's a huge amount of disc we have removed. The next day morning, this was the before surgery and this is the after surgery next day morning. Patient was very much comfortable. There was no neurological deficit. Now tips to the youngster, those who are beginners, they try careful to do the cleavage between the scar tissue and the remnant of the bone. Whatever the remnant of the bone is left out, maybe lamina, maybe facet, maybe pedicle. You start from the bone, then try to go to the soft tissue and the fibrous tissue. Identify the fibrous tissue, then try to dissection from the pedicle to the nerve root. So here request the patience. Take a small curette and the pen-filled dissector work best. Now maintain this, and this endoscopic surgery, the coexistence of the lateral stenosis does not affect the outcome because the bone decompression is very effective with this technique. At the same time, bone decompression does not lead to the higher fusion rate. Now come to the proper case that we are going to present. This is the 2-level recurrent disc herniation, 20 years boy. Open discectomy done in 2017, L3, L4 and L4, L5 level. Midline approach done. The scar you can see. And then the document is not available because he has lost his house in the flood, developed severe pain and left radiculopathy for 4 months, more in the buttock and thigh, but pain below the knee also bothering a lot, unable to stand more than 5 minutes, walking was painful, and VAS was 8, ODI was 30 out of 45 because he is unmarried. Both bladder and bowel is normal, scoliosis is mild, and SLR is left side 20 and right side 70, jerks was normal, conservative treatment for 3 months fails. So this is his X-ray. So there is a laminectomy done at L3, L4 and L4, L5. And we did the contrast MRI to confirm that the disc herniation, the recurrent disc herniation at L3, L4 and L4, L5. And this is the L3, L4 left side nerve root is compressed. There's a left side disc is in the L4, L5 also. So 3, 4, 4, 5, both there was a pathology. We did the contrast MRI. And this is the old scar. And this is the proposed incision of the endoscopic technique, the stendio technique at L3, L4 and L4, L5 left approach. So this is the cranial and this is the caudal. So we did the marking with the marker, and this is the localizing device with the C-arm, and this was the fibrous tissue. This is the left approach. So cranial, caudal, midline and lateral. This is the cranial, and this is the fibrous tissue, and this is the nerve. This is the nerve root traversing nerve root, and this is the disc. My nerve root retractor retracting the nerve root and giving a little more space in the lateral aspect. And then this is the discectomy, and this is the complete nerve root decompression of the left side up to the foramen. Now, the small video. I'm an arthroscopic surgeon. I'm using my shoulder saver bar and also the RF, radio frequency wave. And then using here the 2 mm Kerrison punch, regular Kerrison punch we are using for the lumbar is 3 mm, but here I'm using 2 mm because of the lot of fibrous tissue, and I was able to negotiate between the fibrous tissue and the bone. Now this is the lateral aspect, that is the medial aspect of the facet, and this white glistening structure is the nerve. So we are directly laid on the nerve and then make a cleavage between the nerve or the soft tissue and the bone. We have to sacrifice a little bit of the medial aspect of the facet, maybe 2 to 3 millimeter. And then we are just decompressing the nerve root after removing the ligamentum flavum, little bit of the bone, inferior lamina, superior lamina, and also the medial aspect of the facet. So this is the nerve root, protecting my nerve root by the nerve root retractor. 11 number blade I'm using to make a nick in the nucleus pulposus. This is 3 millimeter disc forceps again to remove the disc. The disc annulus was a little bit more fibrous, hard, calcified. So it's very difficult to negotiate my instrument to the disc space. There are a lot of disc material coming out. And at the end, when I was not able to negotiate my instrument, I took the Kerrison punch to make it a little bit wider because it was fibrous and hard. Then the real pieces came out. That was the real culprit. And also, this was almost calcified disc. And then irrigation with the normal saline clearly shows the flow was very good, means there was no restriction of flow. So the all free fragments has come out. And then this is L4, L5. Also, we did the same technique and approach from the medial aspect of the facet. And then this is the nerve root, totally decompressed up to the foramen. And this is my nerve retractor protecting the nerve root. Then this is the disc. And we did the discectomy. And this is the nerve root complete decompressed. So I'm not going to the video now. This is the 2 port for the 3, 4 and 4, 5. And this is the midline, this is the old scar. I'm sorry for this. Yes, so this is the next day morning. Patient was able to walk without any neurological deficit or in pain. And on 21st post-op day, that was on 3 days before, that is 16th of September 2020. So this is the old scar and this is the new scar. This is also healed. The patient is able to walk comfortably, even steps walking. Okay, so this was, and then this is the total number of cases we have operated on 22,000. Total number of recurrent discs is 48. Only one was the 2-level disc, recurrent disc. So to conclude, the endospine system is a safe tool for the recurrent disc, superior in recurrences like central disc and upward and downward migrated disc. It could avoid the fusion, cause less trauma compared to the open surgery, however, the steep learning curve. So endospine, the mobile operating tube, a simplified approach in the two-level recurrences also. Thank you very much.
Thank you so much, Dr. Day. That was a wonderful, short and a sweet presentation, but of great vital importance. You demonstrated wonderfully what you can achieve with the Destandus technique, which is so relevant in today's world and is so important a part of the endospine concept. I will now request Dr. Abdul Halim Yusuf to come online and start sharing his screen. So Dr. Abdul Halim Yusuf, if you're there, please start your screen sharing. We are waiting for you, sir. Thank you so much, Dr. Abdul Halim Yusuf. Please enlarge your screen so that we can start. Yeah, thank you so much, sir. Welcome, sir.
Halim, unmute. Dr. Halim, unmute yourself. Yes.
I need to unmute. Okay. Okay, that's sorry. Stop sharing. Screen yet. Okay, good afternoon. I'm Dr. Halim from Malaysia. Thank you very much for inviting me to join this webinar, and I'm really glad to be part of the prestigious expert people here. I'm just sharing a very small experience myself. I'm start doing my endoscopic surgery from 2008 with the help of my teacher, Dr. Rahidas and Dr. Istandau. And my target audience for today is really for junior doctors just starting endoscopic surgery. And I hope that I'm sharing some of my thoughts, helping them in embarking a journey in this surgery. Two parts, the unilateral approach for bilateral lumbar in this decompression is an old surgery, but it's just a new way of doing it through maintaining the complete preservation of posterior tension band system. This is very important to maintain the stability of the patient post-operatively. So this is basically the same old surgery that we done by open, but we do it by just the endoscopic that have been shown by Dr. Day just now. So, but when we do endoscopically, we identify a few areas that need to decompress, and conveniently we divide it into 6 areas. We've divided into center one side, ipsilateral, contralateral, and central lateral foraminal. So this is important to know for us to understand it so that we're able to decompress adequately. Next one is that we are talking 2 important things in surgery, which is safe and effective. And to do a safe surgery, first thing is that we have to understand that we need to prepare it. It's something to do outside OT rather than going inside and then start to figure out. So first thing to know the basic things, vector anatomy, the correlation of imaging, clinical finding, the decision making. These are all important for the safety of operation. It's not safety just inside the OT. So that I like to give a very short coverage of this. So first thing that we must understand in the spondylolytic spine, most of the decompression are at the floor, which is at this level. This is the most compressed area. So you have to concentrate on this area to do the job, other than going wandering or elsewhere. So this is very important. The second one is the understanding of paternal anatomy is very important. This is what we see in our textbooks, the spine textbook, all the coloring pictures, like a very simple picture, but it's very oversimplified. But when we go with endoscopically, this is what we see. So we got confused. So this is important to know the structures, which is very important, which is this one I'd like to emphasize, that to understand the pathoanatomy of ligamentum flavum, this is what structure we are going to face when we do decompression, ligamentum flavum, which is very important to understand it, or the various changes that happen. It can become part, what we call it, part of bony, sometimes cartilaginous of the ligamentum flavum. The third one is the clinical history. This is important, not to decompress everything except those who are symptomatic. Usually this L3, L4 is usually asymptomatic. So we do need to go to all the levels that are shown on MRI. So this is another thing that I like to emphasize here. The last thing that I like to emphasize, that surgeon itself must be confident in interpreting MRI. You don't rely on the radiologist to tell us where is the compressed and what is not. So we have to be very confident. Don't refer for radiologist report to understand the pathology of this patient. Then we come to inside OT. Small things are big issues in the endoscopy. So before we start the skin incision, everything must be ready. Camera system, instrument, high-speed burr, bipolar, everything must be ready before we start the surgery. Don't start incision and then we start searching for instruments. So it's very, very important things. This is what I like. And second one is that from start, I only use the standard endoscope in the spine system since 2008. I never venture the others. I think I'm comfortable. Then I think I don't break anything. I am happy with that. I don't need to find other ways of doing it. A very simple system, small inventories, and I add the high-speed burr in this system. The system is actually look like it's a classic. Have not much changed since first introduced by Dr. Listandau, but it's got a very important features, which is the safety features. You can see the portal here. The portal here, you can see this is important for leverage on instruments. If you are doing open surgery, you use two hands to control your instruments. But when you have endoscopy, you only have a single hand to control it. But with the endospine port here, this is acts as leverage for you to strengthen your cut to control your depth of the burr. This is, I found it very, very important and very helpful for me if compared to the other ways of doing it. This is a way of my keeping safe in my operations. This is what I control my drill. So this is my fingers here, and I control the depth of the drill at the hole here. So by this one, I'm happy that my drill is not going inside, except the depth that I have really decided. The second thing is the level marking. Level marking is not just mark the level, but it got other important roles. First, apart from identify the level, it also tell the point of where is the entry point, canal, spinal level, spinal laminar junction. You have to mark the spinal laminar junction. And the third one is where you want to put your ports. It's not either two medial or two lateral. If you have two medial, then you got near the spinous process, you can break the spinous process. If you are two lateral, you might hit go into the facet, and it's difficult to do decompression when your ports on the facet. And the third one is that you know where's the area to decompress. So this is a line that you can see from outside the skin. This is area to decompress. This is when instrument must be located out of this area. So this is the first floor that you are concentrating your works. So this is what I said, the first floor. This is the one the most thing be compressed here. So you don't wander up or down. This is part. And this is the marks on the skin that you see during your operation. This is what I say, the spinal laminar junction. You have to look for where is the spinal laminar junction, because this is your entrance point. And this is your mark when you do the level marking. This is I mark. The middle one is the midline. This one, the medial facet line, and this is that I look for spinal junction. And my incision of the skin incision is between these 2/3 and 1/3. So this is important. Then what you see initially, what you see the first one, will you see this? You will wonder, where are you now? Where are we now? This is important. And this is what you have to re-orientate ourselves. Are we on the right side or left side? Where is the lamina? So first you have to orientate, then you understand, you have to look where to start. And slowly you will go through until this is what your final works. You see the dura and you see the roots here, your works here. So this is your objective is clear. This is what our objective of the compression. We detach. This is what all the people are doing. Got the plain limbitum fiber and dura. We remove the fiber and protect the dura with pecti and do the bone resection to expose the dura and to see the roots. And we do the cutting of the lamina so that we can see going to the other side. This is what I said, where you should have adequate medial vasectomy and you see the roots clearly decompressed. Same thing if you have sometimes you got the root sometimes vertically situated, very sharp, very vertical offshoot, and this is how you expand to the other side. So that you do this is a high speed burr, this is the spine process and the lamina, and you will expand side laminoplasty from the inside. We call it over the top decompression. And then finally, this is what you see. We can do complete decompression, central decompression. This is an area this is being compressed. So we have a few stages of difficulty that we are facing. First one is the initial step. It's a lot of soft tissue there. You don't see any. And sometimes you lost perspective and the landscape is very distorted where you got the hypertrophy of the bones, hypertrophy of the ligament fiber. And the ligament fiber is not just hypertrophy, it undergo metaplasia and sometimes it changes to cartilage and bones inside the ligament inside. And plus that you have the engorged epidural vessel that make you think difficult. So how you overcome this one? First thing is you have to push a soft tissue. You got a tight gauze and also special retractor and cauterize it. And the second one is get orientation correct. You must understand where are you now. You are on the right side or on the left side. So where is the laminar direction? Where you expect the roots? This is all you have to be oriented. And your preoperative marking, as I said just now, is important to understand where to orientate yourself. And fourthly, you must understand the bone is your friend. You stay with the bone. If you got lost, find the bone. And your bone is your friend. You stay with the bone, you will be safe. And the third one is you have to study the planar graft, especially the interlaminar space. Sometimes interlaminar space is so narrow that it's difficult to enter the canal. So this is why you have to resect some of the facets. The second stage difficulty is a canal entrance. How to enter the canal? First thing is you can't find where is lamino-flavor junction. Or the bone is too thick. You cannot cut with Carrison oranges, too thick. Or the internal space is too narrow that you cannot pass your instruments. And finally, you might tear the dura in case a lot of CSF coming out. This causes more difficulties. And this is part of that you have to. So this is, and the third one is how to get adequate decompression. First thing that you have to focus, where is your work? You must understand your work is at this level, it's story 1. Okay. The second one, you must identify the roots. Where is the root which right or left side? So you have to identify the root. Until you see the root, your work is not complete. And the first one, of course, you have to see the planning and the symptom patient and the planning itself. So this is important tool that for me, I thought. It's a high-speed burr is very important, especially when to cut bones. It's a lot of bones. Peti is very important to protect the dura, so that you don't cut, you don't rupture the dura and got the CSF and make some trouble, terrible. The third one is that you have the rotating revolving Carrison ronger that you can turn, so that it's much easier for you rather than you turn your hand. You turn your ronges, it's revolving Carrison ronges. The fourth one is bioglue is available for me for when there's a dura tear. And then of course, you need a very, very good camera. So I got just a few slides. So for complete decompression, we should achieve, we should understand the pathoanatomy. The second one, area to compress. You must know that what area to decompress. There's no point to compress area which is not important in the compression. The last one, you should know that we are doing decompressive surgery. So you must understand there could be other pains, of course, operatively, especially the facet pain. We have continued pain after surgery, and this is have to explain to the patient. So what are the problem of sacral entrance in achieving adequate decompression? First is you cannot control the bleeding, uncontrolled bleeding. The second one is the dura tear. The third one you lost. You don't know where you are. The fourth one, of course, the long level. And it's especially in the early learning curve. You got long operation time. This is a problem where you got become tired, and then you run into a complication like dura tear, and all this will make you feel you can't do the job properly. So I'm just going to start a bit on the dura tear. This is important to avoid dura tear because dura tear will give you more trouble. It takes more time. You have to put patty in between, and use probe to clear any adhesion between dura and ligament fiber. You create more space. You create bones, reset more bones to have more space, because you need more space to put you want to maneuver your instrument. You need more space, and cut only what you see. You don't cut something that you don't see, and this will cut the dura. And you need a proper handling of the instrument, how you use the instrument, whether you use a 90, 45, Harrison. This is important to use it. So this is what I put a patty in between the dura, and you have to reset bone to get more space. When you got more space, then you see clearly where the objective you want to achieve. So this is what you burn more space. This is the type of dura tear. You got sometimes you got a very I say type 1, which is a very minimal tear, minimal CSF leak, and then tear with a significant CSF leak, and then tear with a prolapse roots, and tear with a dura defect. You got a whole some part of dura defect, and you see all the root coming out. Sometimes the early part of my surgery, I do nothing. I just left alone, and things happen. Things okay. Then I start to do muscle patch. I put a muscle patch from the part of the surgery, take some of muscle and patch to the part one which is tear. Or this is what I'm using now. I put a glue. I put the artificial dura above that and put a glue in that. That is my practice now. So there is a very main advantage of a unilateral approach that there is a feasibility of revision surgery. If you have another surgery because of the whatever problem you have to come again, you have another place to come in, which is another side. This is important about unilateral approaching, where in revision surgery you can come the other side. So, and lastly, I would like to stress that in lumbar spinal stenosis in degenerative condition, the complication will remain complication and will progress into paralysis. We have to tell the patients. And you have condition we call the burnout stenosis, where patient will have no more complaint of pain but walk with simian gaits. And that surgical indication is not absolute in the stenosis, not absolute. And then last one, the benefit of decompression is usually only for 2 to 4 years. And then patient will start again have some similar pain, but it's less intensity. You have to explain to the patient that is the natural evolution of the degenerative lumbar spinal stenosis. So in summary, safety and effective are two important issues in surgery. So important, you have to attentive to detail and meticulous preparation. You need a combination of knowledge and technique. And few tips and tricks are in the situation are helpful in the safe and effective surgery. That's all I think for my presentation. Thank you very much.
Thank you.
Mohinder has joined.
No, Mohinder is not yet joined. Don't know
So
what is
let
wrong.
me start. Let me start. Okay.
Yes, sir. Rohita sir, you start and Mohinder Kaushal sir will join.
Okay.
You start sharing your screen, sir.
Just 1 minute. Yeah.
Just 1 minute. I think Mohinder Kaushal sir has joined.
Then it's okay. Let him finish.
Yeah, that's exactly, sir. That was your desire. So
I'll stop sharing.
just 1 second, sir. Let me just confirm. I'm searching for Kaushal sir. Kaushal sir, can you hear us? Can you see us? I'm not able to see Kaushal sir. Hello. I just got a message that he's joined.
He must be in the attendee.
No, I'm checking that also, sir. I can't see him there. I can't see him at all.
Because he sent a
Okay,
message.
I just upgraded him to panelist just now.
Ah, so then he can see us. Kaushal sir?
Yes.
Yes, sir, we are joined, sir.
Yes, sir. So please start your screen sharing, sir. Your camera is off, sir. Kaushal sir, your camera is off. Please put on your camera. Yes, sir. I think you can see us now. Wonderful.
Allow, sir, allow.
Yes, yes. We can see you. We can see you, sir. Can you please start your screen
Start
sharing?
sharing our screen, sir.
Start your screen sharing, sir.
So screen share. Share screen. Screen. Share. और इसको सिर्फ फुल स्क्रीन करना पड़ेगा इसको। हाँ, इसमें हो जाता है। स्लाइड शो फ्रॉम बिगिनिंग।
Yes, you're on, sir. Great. Welcome.
तो यार ये प्रेस करना गगन इधर चलो इधर आ जाते हैं sorry boss
Welcome, sir. Welcome, sir.
Sorry, Malcolm, my internet was down. Then I am halfway through surgery already. Anesthesia was given, so now net is connected. So I'll quickly go through my presentation. My apologies.
No, welcome.
So,
welcome.
Greetings from City Beautiful Chandigarh. So financial disclosures. Next slide, please. Yeah. So as we all know that in degenerative lumbar canal stenosis, predominantly neurological claudication with or without backache is the issue. Pathophysiology we all know, and in modern scenario in my hands and many of my colleagues, including Malcolm, I think endoscopic MI fusion to address symptomatic instability seems to be a better option in modern times. Next slide. So why do I prefer endoscopic MI fusion? My reason of preferring endoscopic MI fusion is to achieve good neural decompression and to have a advantages of minimal invasiveness also. Next slide. So these are the additional advantages when I switch over to fluid when I am very close to dura. And this is a slide courtesy Dr. Sohn. Next slide. So another advantage of endoscopic PLE for TLF is patients, usually our patients are of advanced age. There is a multi-level disease. There are associated comorbidities, and there is a high morbidity open spine surgery that we all know. So again, my argument is that minimal invasive endoscopic assisted TLF PLF in above scenario is an ideal option. So as far as decompression is concerned, I think the Stendu system can be used. I am a guy who uses single portal endoscopy. So Stendu I have been using since 2002. Now I have my own miniature Stendu 2. You can call it as arthrospine system, which I am using. Next slide, please. So this is a special tube which I have designed through a single portal. When I have to use a cage, then I switch over to this tube. It has a port for the scope, one for the suction, and there is adequate space for a cage to enter into the space after you've done all the preparation work. This is a instrumentation. This is a 30-degree scope which we use in knee arthroscopy. I mean, very conventional instruments and very cost-effective, most cost-effective instrumentation. This is again a endoscopic, this is again a MIS fusion instrumentation designed by JESCO. Next slide. Again, when you're using a fluid medium, you have to bring in the burr and a RF wand, which adds to the cost also. Although there are some special advantages also. Next slide, please. So this is a long list of advantages that why I use orthospine system and the distinct advantages of this system. Next slide. So system can be used in various problems in cervical, thoracic, lumbar disc prolapse, in spinal canal stenosis. Endoscopic MIS fusion can be done, and some other indications are there where this system can be used. Next slide, please. So this is a mobile system, same advantages as we have in Destendu system. So there is a mobility which surgeon can use to his advantages. Next slide, please. So I will be sharing briefly about the operative technique. Next slide. So this is a MR of the patient. You can see significant stenosis at L4-5. Next slide. These are the dynamic views. There is a gross instability at L4-5, and this patient had disabling back pain and a neurological claudication. So patient is kept prone with legs straight, since you have to use AP view also. Needle marking of the level by a 18-inch spinal needle. Next slide, please. And you give a 15 to 20 millimeter stab incision in the skin and lumbar fascia. Next slide. Then further process is by a dilator. You can see on the model how dilator is used to detect the soft tissues from the interlaminar window. And over dilator tube is slit. And this is how, in the last picture, you can see how surgeon performs the procedure while he is watching over the monitor. Next slide. So this is an endoscopic view of dry endoscopy, view of a interlaminar window on a patient and on a model. Now this is a contralateral decompression with a dry endoscopy and a ipsilateral decompression of with a fluid endoscopy. I'm just sharing this thing. Now this is after surgeon has achieved a good circumferential decompression, then he starts a disc preparation work. Next slide, please. So this is, I use this shaver, which is used to prepare the disc and we try to preserve the end plates as much as possible. And this is a final view of the discoscopic view after disc preparation. And this is a red dot phenomena. This is a problem which I usually face when I'm very close to dura. So here I use the advantage of the fluid. I switch over to fluid, and you can see the picture of under the fluid endoscopy. You can see how clearly the disc is visible. And I am using a RF band to control the bleeding. Next slide, please. And this is again, I am preparing a disc with the shaver blade. And then I have, this is an endoscopic view of the disc inside view, and finally position of the cage in the disc. This I have used under fluid. Next slide, please. And these are the intra pictures. And finally, monolateral or a unilateral fixation I usually use in low-grade slips. So post-op protocol is tailored to the individual need. Mobilization out of bed same evening. Posture care and exercise program same evening is started, and return to heavy work after 6 to 8 months. Next slide, please. So these are cases. This is a post-op 9 months post-op patient where you can see settling of the cage in the end plate, but patient is doing pretty well. No back pain, no leg symptoms, and he is very happy with the and good fusion is occurred at the L4-5. And this is another patient. Next slide. So very small series, about 30 patients in last 5 years. So my fusion is only 2 to 3%. I mean, in my all decompressions, and I have been successfully able to achieve all the patients fused and good relief in back pain and leg pain. Next slide. The complications observed were rod migration in 2 patients, cage extrusion 1, and deep wound infection was observed in 1 patient. Next slide, please. So just to share the advantages, it is similar to as other MIS procedures and posterior approach, familiar approach to surgeons. There is excellent exposure of the disc space. There are low chances of fuel injury. And it is, since I use monolateral fixation in low grade slips, so it is more minimally invasive and economical also to the patients. Next slide, please. So it is in 18 years, I mean, almost close to 4,000 endoscopies. I have, in addition to discectomies and canal decompressions, I have extended indications of endoscopy into other areas also. And I have taken spinal biopsy under endoscope. I have drained abscesses also. And I have even tried to utilize advantage of endoscope in spinal fracture reductions. And as per this presentation, you can see very small series of 30. I mean, in close to 4,000 cases, only 30 fusions I have done so far. Next. So just a word about learning curve. I mean, guys who want to learn these techniques must visit a master where these techniques are being regularly done. Then he should attend cadaver workshops, and then finally he should start doing these procedures in his own theater. Next slide. And final thoughts. Great improvements have been achieved in developing endoscopic spine techniques and tools in treatment of spine disorders. Patients seem to benefit, and evidence-based medicine support outcome of these techniques. Thank you very much.
Dr. Kaushal, a wonderful presentation and fantastic application of the Standus in fusion. This is something that the world has watched perhaps for the first time. Unbelievable and brilliant presentation on your part. Like I mentioned, the modification of the tube, the arthrospine system that you have developed by using fluid and air as interfacing is a fantastic application of your genius capabilities. And I'm really in appreciation of that. And I think the rest of us who are watching this presentation will also be of the same opinion. Excellent, sir. Now moving on to Master Srinivas Rohidas, sir.
Thank you, Dr. Malcolm.
Thank you to start, please sharing your screen, sir. Sir, I'll call back on you.
How much time I have?
Panelist. Sir,
How much?
just 1 second, sir, please.
How much time I have?
Just 1 second, sir. Just 1 second.
It's okay.
We are at 3:57 now, and I think we can go on till around 4:30, sir, if you wish to. Around 4:20. Would that be enough for you? About 20 minutes?
No problem. I have just inquired with you. Yeah.
Thank you, because we had some little long presentations.
Yeah.
It's okay, but 20 minutes would be just fine, sir.
Yeah. So, good evening. This is presentation of my journey from 2002 to 2020. So there are so many questions the younger generation have to ask themselves. Whether by all these things, whether we are approaching towards a new gold standard. Everybody is talking about gold standard. I started this thing in 2002. The younger generation has to decide in between whether it is a dry endoscopy or wet endoscopy. There are so many gimmicks. Pure endoscopy or true endoscopy or endoscopic assisted. Everybody is calculating the size of the incision in millimeters. Whether it is a local anesthesia or general anesthesia. Even after general anesthesia, we mobilize patient after 2 hours. The other important thing the younger generation has to decide or think of is the cost of the instruments. When we minimize the incision, the size of the instruments becomes small. The instruments are delicate and there is a recurrent cost of the instruments, which the patient has to suffer, not the surgeon, not the hospital. The basic what we thought, we were taught during our training days that unless you see the pathology, you will not be able to understand what you are doing. So when we minimize our corridor, it is always better that we should have a very good vision, and always with the endoscope, there is always a skepticism that we do not have a 3D vision. In all the meetings, there is a skepticism that with microscope, which is a gold standard, we get a 3D vision, and with the endoscope, we don't get. And the last thing which after the finishing of my presentation, younger generation can take a message that with only one technique, you will be able to create a brand. There is no need to change the technique. I never thought of changing the technique in last 18 years. So this is the Mumbai conference where With distension technique, Dr. John Chu operated 3 cases and all the 3 cases has problem, and that was a very good thing for me. I started the distension technique after a good amount of training with Dr. Distension. This is John Chu's the instrument. This is for the instrument. This is for the endoscope. So in all the things, we have an endoscope and we have an instrument port. Last, I'll show you this slide of the UBE. If we cut this into 2 parts, it is UBE. So the instruments are same. We have to play with the technique. This is in 2002. We did our first workshop in 2004 at Indore. Now the younger generation has to choose. One has to choose your own love. You have to work on the subject which others have not worked on it. You have to focus on it. If you try to change the technique every 5 years, you'll not be able to master in that. You have to do it persistently, then you'll get the mastery. And let others know about it. So your self-auditing is very important. Now the application of keyhole surgery does not require latest technology, but it requires willingness to minimize the collateral damage. Reevaluate your current thinking, whether you want to remove a total disc, you want to preserve the disc, you want to preserve the motion segment, so many things. We have to use the endoscope generously, and it is a concept. Minimal invasive spine surgery is a concept. It is not the size of the incision which matters. So don't compare the size of the incision in millimeters. This is about distension technique. This is the only technique where you can use in all the pathologies. Mohinder has shown in instability. You can use it for lumbar stenosis, multiple stenosis, discectomy, central disc, everything. Anterior cervical, posterior cervical, even the intradural tumors. As compared to the cost, it is the cheapest system, and it is the only system which is available, which can be used with the 3D endoscope. These are the courses which we did in 2006, 7, 9, and 11. This is what we started. This is single chip camera, halogen light. We have to assume so many things. So the crystal clear appreciation of the anatomy is possible with very good image. But this is the first workshop with the single chip camera and a Sony screen. Second workshop, little better image. Third workshop with the ultrasonic bone dissector and HD camera. And this is the fourth workshop. We started our association in this fourth workshop, 2011. 2005, we started with the same technique, the posterior cervical. This is the spinolaminar junction. This is with the HD image. This is the cervical cord, and this is the extruded disc in the axilla. Yeah, this is the extruded disc in the axilla. In 2006, we started with the anterior cervical disc preserving surgery, Joe's technique. This is the uncovertable joint. And this is the forearm anatomy, vertebral arteries here. Same anterior cervical. This is the cord, root is here. Underneath my section is the vertebral artery, and this is the extruded disc. We preserve the rest of the disc. So we preserve the motion segment. When we minimize the approach related trauma, it means we have preserved the stability. We are trying to preserve the stability and the motion segment. This is calcified OPL. This is the cord, and we have decompressed the cord with preservation of the anterior two-thirds of the disc and the vertebral body. In 2007-8, I thought of using the ultrasonic bone dissector. I worked with this company and we developed this ultrasonic bone dissector, which was safe for the anterior cervical near the vertebral artery. Now this is the posterior cervical. I am on the opposite side. This is opposite side lateral edge of the dura, and I am undercutting the opposite lamina. You can see the bone dust here. This is for the surgeon's safety and to prevent complications related with the drill. This is the cool knife. We are cutting the bone to go on the opposite side in case of a lumbar canal stenosis. This is the cord here. Now with the endoscope, you can go inside the disc and confirm that you have done an adequate discectomy. There is no need to assume that you have done an adequate discectomy. You can go inside. This is the normal disc anteriorly, and these are the end plates. So there are no loose pieces. Now this is in the lumbar canal stenosis at 2 levels through the same incision. This is ipsilateral root, contralateral root, lower caudal root, and this is the contralateral root. At the same time, we have preserved the stability. I can retract the opposite traversing root, and this is the disc here. So you can have a nice vision of the contralateral narrow areas also. This is the book which we published in 2016 about this technique and each and every detail of it. So still there was skepticism. So I was always in search of a 3D thing. So the 3D endoscopes which were available were with Vision Sense Machida stores. Initially, I started with this Vision Sense. So insectoid technology. And these are the images. These are the 2D images of 3D. Bilateral canal decompression, flavum, this is ipsilateral root decompression, discectomy, and this is the intradural tumor. In fact, I did with the first surgery which I did with the 3D endoscope was this intradural tumor, so that I can appreciate the depth. This is also ipsilateral, contralateral root, and canal decompression. You can appreciate this video. This is the traversing root. I'm going inside for the disc. If your vision is good, you are more safe near the important structures, near the neural structures. This is canal decompression, ipsilateral root, contralateral root. You are inside the canal. And this was the intradural tumor. This was at L12. Then I started using this 3D converter, which converts 2D into 3D to get the depth appreciation. And this is how you can use it. This was the Mashida, which I used from 2016 to 2017. And then I started using this TipCam 4 mm 3D endoscope by STORS since October 17. You can get 2 images, 2 videos, and you get a very nice appreciation of depth. But you cannot zoom, you cannot wide. The basic important thing of the endoscope is the panoramic vision. Here you cannot get the panoramic vision because it's a tubular vision. But with the help of the distant view technique, you can have a panoramic vision by zooming in and out. So rather than having the zoom in the endoscope, we can use the zooming effect of the distant use technique, inner and outer tube, and you can avoid that problem. This is the 2D video of a 3D endoscope by STORS. You can appreciate the capillaries also. I've done around 332 cases, all the levels. 3 dural punctures, but which never needed any suturing or something like that. Only a tissue dura patch and the fibrin glue helps. These are the advantages of the 3D. One of the best advantage which I appreciated, that I usually call my patient's relative inside the OT to see the surgery. They can understand the anatomy, what I'm doing. They can understand the disease process, and which helps me a lot in the future rehabilitation of the patient. They understand it and they can follow it, so that the recurrence and all other complications, if they are any, they can appreciate it and they can accept it. So at this end, again, how to choose your work? You have to work and do it persistently and focus on it. It is not an Amazon model where you will be able to provide all the things. You have to follow this Gharana model of India. You have to be very good in one thing. You cannot have all the techniques and you will not be able to master in all the techniques. So you have to follow one, persistently do it, and you will be able to master it, and you will be able to create that brand. We always try to blame the technique. Techniques are not bad at all. This is with the 3D endoscope. This is the training model which I have developed. Day 1, it is cadaver. Day 2, they come inside the OT and have a look at it, understand the anatomy step by step. They can appreciate the hand movements, correlate with the endoscopic picture. Third day, again, they try on the cadaver. This is how we can train them, so that the blaming of the technique by the younger generation without understanding it nicely will be less as much as possible. Again, at the end, this is the UBE. Now this is called as a wet technique, 2 ports. If we divide that distant into 2 or the John Chu's apparatus into 2, these are the things which we get. So there is a role of new technology, maybe navigation. Nowadays, navigation is only used for fixing the pedicular screws. But if we can use the navigation to understand how much bone we have removed, whether it is adequate or not, that will help a lot in preventing the unnecessary, inadequate, or more than adequate decompression of the bone. There is always an exploitation of the technique. We should avoid the exploitation of the technique, select our patients nicely. I'll show you, this is the transforaminal approach. This is the neurofibroma. These are rare things. One of my colleagues has done it. But this cannot be a usual thing. With this limited access, as this neurofibroma was only in the foramen as a small one, it is possible. But for routinely, it will not be able to do this. So don't try to exploit the technique so that the younger generation learns to select the patient. Now we are in the post-COVID era. Economical problems will be there in countries like India and others. So we'll have to think of the cost of the treatment, and that will be the crux in the future. If the MISS techniques are compatible with the patient's pocket, they will survive. Otherwise, they will not survive. This is microscope with the endoscope. They are also thinking of the combining microscope with the endoscope so that they can understand and they can use the advantage of the endoscope with the microscope. MISS will continue to be practiced by only elite surgeons if we don't follow the cost effectiveness and the other things. We are always in the search of the gold standard, but our final thing should be 100% success is unreachable, but we should try to have a reachable goal with everyday learning, training, and improvement. So at the least, the younger generation should think of all the things, try to understand the basics, whether it is dry, wet, truly endoscopic assisted, size of the incision. They should understand each and everything and then choose the system which is suitable for their mentality, for their patients. The thing which is very suitable for Korean patients will not be suitable for Indian patients. Surgeon has to understand that, and we are not going to treat or convince the patient by the research papers. We are going to convince the patients by our own patients which were operated in the past. That is our research paper, and the younger generation should understand that. Thank you.
Dr. Rohidas, a fantastic talk by you. Philosophy, science, all melted into one. A beautiful take-home message for all the people who are listening to us and who will be watching this on YouTube and future recordings. You have brought to light that very essence of endoscopy, and that essence is deliverance, relieving the patient of his problem, cost effectiveness, and utilization of all existing technologies, their modifications to the benefit of the patient. So if I were to put it in a nutshell, sir, you have merged history, you have merged science, and you have merged philosophy all together in this lecture. I think it was a wonderful lecture. Dr. Kaushal's talk regarding endoscopic fusion using the modified Destandu sheet was something very innovative and wonderful. Dr. Abdul Halim Yusuf and his experiences with his patients in Indonesia, I believe, excellent. Malaysia, sorry, excellent. Malaysia, excellent. And Dr. Paresh Chandade, you are a remarkable surgeon. You have very beautifully demonstrated the very basics of the Destandu technique, the marking, the skin marking. So I think overall, I'm really in awe and appreciation of endospine. I really have not been very good at it. For me, it was a passing affair. And I jumped to other techniques of endoscopic spine surgery. But today, I do feel like revisiting that. So that was a wonderful session, sir. I thank you very much. I thank the World Federation of Endoscopic Spine Surgery for having participated. And I'm really grateful to you, Rohidas sir, with folded hands. Thank you so much.
Thank you.
I will now want to start with our next session. In case there are any questions from any participants, please let's have them. Otherwise, let us start. I don't see any questions popping up here. So I think we will start with our next session. There is just one question that is was directed to Dr. PC Day, that why did you do a contrast MRI for disc disease? So I replied on my own that it was to help identify inflammatory tissue from actual disc tissue when we are dealing with reherniation. So Dr. Day, would you like to shed some more light on that?
Yes, yes, you are very correct about it. If it is a fibrous tissue, or sometimes we differentiate the inflammatory tissue, fibrous tissue to the disc tissue, and it is only indicated for the recurrences, not the primary.
Perfect, perfect. Really appreciate that, because
But the contrast is really necessary when we are thinking of a recent herniation, and if we want to compare whether it is an infection, recent herniation, or a
correct,
scar.
correct, correct. So it helps to identify all that.
In cases of herniation after 2 years, the contrast is not going to help.
True, sir. True, sir. Fantastic, sir. Really appreciate that. I think we will start with our next session, and I would like to now invite our next panelists, Dr. Tariq Yazir, Dr. Tamar Hassan, Dr. Christopher Hofstetter, Dr. Daniel Hansen, all those who are available, please, I request you to join. Can I request our host, Dr. Sameh, and can I request our host, Dr. John Bennett? Bennett, are you there? Dr. John, are you there?
Okay, I am here. I am
Yeah.
working on, and I upgraded our first speaker, Dr. Tal. You can start with, and I will manage. Thank you.
Who is available with us? Please, let's start with them. So, Dr. Tamer is there, or Dr. Yazir?
Yes, I'm here.
Welcome, sir. Please start with
Thank
your
you.
speech. We would love to hear you.
Do you hear me?
Yes, I can hear you, but I'd like to
Okay,
see you.
thank you.
Please start your screen sharing, sir. Please start your screen sharing. Dr. Tariq Yazir. Yes, you're on, sir. Please start with your screen sharing, sir.
How can I share?
You have to go to the bottom of the screen and there'll be a green arrow, share screen.
Share screen. I couldn't catch. Where is the? Share screen. Yes, I saw. Okay.
Please select your presentation, put it on, and then share your screen, sir. Yes, please select your slide first, enlarge it, and press the play. Yeah. Welcome, Dr. Tariq Yazir.
Thank you.
You are an honored senior member of the spine fraternity. The world of spine owes a lot to you, especially for all neurosurgeons in the Middle East. You are an icon, and it is my honor and pleasure to host you today in this World Congress. Welcome, sir. Please start your talk, sir. We are keen to hear you, sir.
Thank you. Thank you. It's very kind of you to be here. Is really honored. Thank you. It's many thanks. And thank you. And I would like to share a simple case, but it's very from time to time the cases are teachers, and the time is teacher, as all we know. And this is very difficult case for diagnosis, but you be really a big chance for the patients and for the surgeons, in my opinion. These patients' complaints are quite large, so many. Walking is very difficult, getting more difficulty by time, distance and walking time decreasing. He had low back pain, the reflection of his pain on the legs, tingling in all legs, and he need rest when the pain increases. He could walk when the pain was gone. Also, he has coxarthrosis, he has spastic gait, and he was walking a heel off two strike position. His gait was unbalanced. And the patient is 78. He has diabetic polyneuropathy. He has mainly coxarthrosis, right side. He has cervical compression. And in 2099, cervical MRI has severe compression findings. There are myelomalacic cervical changes and stenosis in C4-5. There is also severe radiologic stenosis in L4-5. And one of the electroneuromiographic investigation outcome is diabetic neuropathy. EMG findings do not explain the patient complaints because the patient has spastic gait and bilateral Babinski signs positive. It is recommended to investigate central nervous system lesions. Second, electroneuromiography, a syndrome polyneuropathy, and it is compatible with the chronic part axonal degeneration, right L4-5, left L5-S1, and C6 and C5 segments. And of course, clinical correlation recommended by the neuromyography users. And some coxarthrosis and cervical position and some little details, but L4-5 segment like this, and neurogenic claudication, of course, very obvious. And within this diagnostic masses, we wanted to do UB because all we know, the first rule of the medicine in Latin terms, we mustn't harm the patient. We mustn't do anything wrong for the patient. So UB really is a big chance. UB is not a small surgery. UB is a very clever, very swift solutions. It's full of swift solutions. And the only approach like arthroscopy in knee, but you can do everything with the everything you can do like an open surgery. That's why we didn't want to harm the patient, and we decided to solve the pain, clinical pain relief was our target, and we performed first UB. And here, Dr. Hayati Aygün was in the operating room as a supervisor for me, and I would like to thank him very much. And this is the contralateral decompression of the medial facet osteotomy with medial facet osteotomy, and this is the small bone part of it. And we continued, and post-operatively he has a nice lumbar curvature here, and his gait really was much more better than before. And this is the control MRI, and the decompression was the computerized tomography was perfect. And once upon a time, we used to use this kind of decompression surgeries. Today I feel shame when I look at them, and we have a wonderful technique today, and I would like to thank to founder, innovator of this technique, Dr. Son, and his studies, and the patients are much more luckier than before. And I would like to thank the innovators, and to you, you are trying to share this technique with the world. Many thanks for your kind attention. Thank you.
Dr. Tariq, I don't have words to express my joy and happiness.
Thank you.
Being a senior person like you do and you be, you are an inspiration to all of us. You know, I read a line recently by one of the best movie stars of old Hollywood. That series, Good, Bad, and Ugly. And he, at the age of 89, is producing a movie. So he made a statement, don't let the wolves in. And that statement applies to you, sir. You did not let the wolves in. You did not let age defeat you. You, at your age, have adopted one of the most wonderful techniques known to mankind. And your words and your presentation today is an inspiration to the next generation to come. Amazing, sir. Congratulations and hats off to you. In India, I will with folded hands say salam. Salam.
Thank you. Thank you, sir. Thank you. It's very kind of you. Then I realized you are not only a wonderful surgeon, but also you have a golden made heart.
No, sir. It comes from you.
Thank you.
Thank you, sir.
How
Thank
nice
you.
to be your friend.
Thank you. Thank you so much, Doctor.
Thank you.
Dr. Sameh, can I request you to please invite Dr. Dan Hansen? He is waiting, and there's Dr. Christopher, but I don't know whether Christopher is now available. So can you just check out on that, please?
Okay.
Otherwise, we'll start with Dr. Dan.
Yeah.
Dr. Dan Hansen.
Okay.
So can we invite both of them, whoever is available, to start the next talk, and then Dr. Tamer Hassan, whoever is available, all three of them. Then we go to Dr. Javier and Dr. Adam. We are waiting for Dr. Dan Hansen of USA to join. Dr. Tamer is there waiting in the attendees. Dr. Tamer Hassan is waiting. Can we please? Yes. Yes, please. Thank you so much. Dr. Tamer, can you see us?
Okay,
please?
I have upgraded.
Hello, Dr. Tamer.
Hello, can you hear me?
Yes, we can hear you, sir, and we can see you also. It's wonderful to see you. Welcome.
Hello.
Welcome to the Congress, sir. Please start your screen sharing.
Okay.
You have a lovely smile, sir.
Thank you. Can you see my screen?
It's okay, sir.
Okay, can I start? Hello?
Okay.
Okay, I will talk today about the full endoscopic soft tissue approach to the lumbar disc. I will report my experience in Egypt. You can see that, of course, we know that this is the difference between room light and the headlight, and the microscope and the endoscope provide us more. And this is a 25-degree angle endoscope that we use from the Wolf company. I'm using in my practice. I'm not sure if we can apply those types of questions, but anyway, which intervertebral foramen is the biggest in dimension in the same healthy person? So when we go from up to down, the intervertebral foramen comes narrower, and the reverse for the interlaminar space. So the L5S1 has the biggest dimension, and when we go up, L34 is bigger than L45, and so on. So this is how it looks like, and this is how we should approach, think about our approaches to go from the interlaminar approach or the transforaminal approach. We use this endoscope, and you can see it's 25-degree, and it has this kind of channel, and these instruments I will explain later. And we use the trigger flex device. This is how the transforaminal approach looks like, and I am fascinated with this approach. It has a many useful applications. This is the way we can go to the approach the the foramen. We approach the lower quadrant of the foramen, saving the root up. This is the corridor that we use, and sometimes we can. This is a we can use the pure transforaminal approach, and sometimes we can apply another posterolateral approach. If you use the posterolateral approach, we should use the drill to make the SAP thinner, so we can approach the lumbar spine from a different angle. But anyway, let's talk about the pure transforaminal soft tissue approach. There is no drilling in this approach. This is the corridor that we are using, and this is how the nerve root looks like. Okay, and this is what we have to see. The endoscope has to be in the sleeve, and the sleeve has to be visualizing the ventral part of the spinal epidural canal. The dorsal part, I'm sorry. We bend the patient. We don't use the, we just use the usual curvature of the table to make the patient bend to open the interforaminal space. And first line goes with the posterior facet line, as you can see here. And then we make another line parallel to the disc space. And the junction point between them, we approaches with the needle. And then we put, the needle and then the wire dilator, as it's explained by the company. And finally, we have the sleeve in place at the the ventral epidural space. Once we apply the sleeve, we put the endoscope. This is a 23-year-old male. You can see this kind of disc, as we can see here. Some people may do double level laminectomy and discectomy. Another may do double level fixation. We can use the endoscope, left microscopic hemilaminectomy and partial fistectomy, and we can use the transforaminal discectomy. Many options in such patients. We choose to do the endoscopic approach. I hope the video is working. It's a pure soft tissue approach, so I don't use any drilling. It's useful to rotate while taking the fragment out to make sure that pulsations of the ventral epidural space is very important sign that decompression is full. And we can check also the trigger flex and C-arm that we have decompressed the whole disc level. This is another, the extraforaminal approach. We can approach this safe point and then we go with the SAP up and find the root axilla and then take the fragment out. It's easier to, some other people do it different way. Go inside and then take the endoscope outside. This is the SAP, you can see, and I will show you the root now. Okay, this is the annulus. This is the nerve root. You can see here. This is the after decompression. So another case, a 45-year-old lady, previous 2 lumbar surgeries 5 years ago. And what is the options for treatment? Should we go for microscopic discectomy or fixation with L4-5 discectomy, double level discectomy with fixation, or we use the transforaminal approach? Transforaminal decompression, transforaminal root is always a fresh approach, and this is one big advantage of that route. This video is a little bit long, so I will skip part of it. after taking the fragment out. A lot of adhesions we have, and this is pulsation of the dura, as I told you before, which means that we have did successful decompression. Patient was worried about recurrence, so I did as much as I can, change the angle of the sleeve to take more and more risk material. Despite I am convinced that this cectomy, the more you remove the disc, is not concerned with recurrence. But anyway, I removed as much as I can. This is final after decompression, and you can see this is the ventral epidural space fully decompressed. So pelvis is one limiting factor for this approach, and so I have seen some schools drilling the pelvic, the iliac crest to approach the lumbar spine. I don't think it's a minimally invasive route this way, but you can see here this is the iliac crest, and across this level, across here the pedicle of L4-5. If the iliac crest crosses half of the pedicle, you cannot get the disc below. So I told you that we use this endoscope also in several patients with discitis. Once we get the endoscope inside and wash and do some curettage, inject some ozone, sometimes inject some antibiotics, it has a very good results. A trial before doing curettage of the disc and fixation. This is how it looks like. So of course we know that the advantage of using the endoscopy, and there is another route that we are telling you about, the interlaminar approach. So I summarized my talk today about the transforaminal approach only. Thank you very much.
Dr. Tamer, thank you very much. A very wonderful and informative talk. Really appreciate what you're doing in the transforaminal sector. And this endoscopy basically has been a paradigm shift in spine surgery. Transforaminal endoscopy has its own great set of advantages. And I hope you have not had any bad experiences with root dysesthesias and persistent pain.
Well, in my practice, I think interlaminar approach, microscopic discectomy, has a more application. 30% of the patients were tackled transforaminal, 70% of them were interlaminar or microscopic. And I always tell you that if I didn't succeed to do the approach from the transforaminal route, then we will shift to the interlaminar or we do microscopic surgery. And it's in the same procedure.
It's basically what you're talking of is merging of approaches. And that is exactly what I've also been speaking about, that we need to have a 360-degree mindset, literally. That eventually what is of importance is comfort to the patient, achieving the success that we want to achieve. Transforaminal has been my own passion, and I really appreciated your talk on it. Wonderful planning and execution that you've shown in your videos. Really appreciative of your talk, sir. We will now move on to our next speaker, that is Dr. Daniel Hansen. I think he's waiting, and have we added him? Dr. Daniel Hansen, are you there with us? Dr. Daniel Hansen. I'm not able to see him. Do we have any other speaker? I need 5 minutes. Dr. Christopher Hofstetter was supposed to join us, but unfortunately, because of some major surgical emergency, he is not able to join us. Dr. Javier, are you there with us?
Yeah, I'm here.
Yeah, so Javier, why don't you start with your talk, and we will take Dan's talk after 5 minutes, after you finish. So Javier, can you please come online, please, and start with your presentation?
Yeah, sure, of course.
Yeah. So why not? We will take Dan after you. Okay.
Okay.
So why don't you
Perfect.
start, please?
Perfect. I'm gonna share my screen.
Yeah, please share your screen.
Can you see my screen right now?
Yeah.
Perfect.
Expand it, please expand it.
Perfect.
Larger, complete screen. Yeah, perfect, perfect. No,
Can
we
you
are able
see?
to see your slides, so make it a full screen. Make it a full screen, Javier.
I have
Be down if you're using it.
full screen. This is the full screen, no? Can you
Fine.
see?
Yeah, you can go ahead with this. No issues. Go ahead, please. Go ahead.
Okay. Thank you very much for your kind invitation to this amazing virtual meeting. I know that these are difficult times, and hoping you and your family stay safe. I'm Dr. Javier Quillo Olvera from Mexico. I'm a spinal neurosurgeon, and today I'm going to talk about the scope of the unilateral biportal endoscopic spinal surgery technique in lumbar degenerative pathology. I want to say thank you and blessings to all the participants. There are so many doctors abroad, and there are experts in endoscopic spine surgery. So as introduction, biportal endoscopic spinal surgery, or the so-called UBE technique, is another one of the full endoscopic techniques in which the surgeon works with familiarity through two ports. The technique can be performed in cervical, thoracic, lumbosacral spine for different pathologies. Some pairs regarding UBE are the following. For example, the surgeon can obtain clear visibility of the surgical field because UBE uses continuous saline irrigation, similar to the uniportal technique. Also, UBE is a full endoscopic technique with high accuracy to reach the pathological target or reach the anatomical landmark. So the surgeon feels familiar using common surgical instruments, also used in open or microsurgical procedures. But also another advantage is the surgeon can be feel free in the surgical field. With the UBE, there are minimal motion restriction in the surgical field since the endoscope can follow the instrument moving freely, and an appropriate approach performed ensures that. Also, the endoscopic anatomy is similar to microsurgery, and a relatively short learning curve is needed. But this advantage depends on proper execution of the triangular approach. The biportal technique is performed through two vectors. One vector is the endoscopic channel, and the other vector is the working channel. So the two channels forms a triangle, but the surgeon works with the vertex of this triangle in a space called epiperiosteal space, the sun space. This space is filled with connective tissue or fat tissue. So the surgeon works precisely below the muscles, not through the muscles, not into the muscles. The surgeon works below the muscle, so the muscle damage is minimum, similar to uniportal techniques. But the triangle base should be separate. That ensures that the surgeons not blocking during the surgery with the two instruments. And the surgeons make mistakes of not joining the two vectors, for example, or joining earlier the two vectors, leading in not adequate visualization in the surgical instruments. The endoscope used in UBE is an arthroscope, different to the endoscope with working channel integrated in the uniportal techniques. There are so many brands, but general features include a 4 millimeters outer diameter with 30 and 0 degrees angularity lengths. However, there are more angulations. There are so many surgical instruments, but the surgical instruments are the common surgical instruments used in open surgery. There are also local brands to perform many instruments to make easier the surgery. We use Carrison forceps, pituitary forceps, some dissectors, different RF probes with different tips, drills, 0 degrees endoscope lengths and 30 degrees, and the other instruments, common instruments. The UBE technique has special features also. The technique is performed through a triangular approach, as I told you. Both the endoscopic and working channel join in the epiperiosteal space, the sun space. Then a positive hydrostatic pressure by the saline inflow works as a natural retractor to maintain a space for working. The same saline flow exits through the working channel. This is a circuit that ensures a proper approach. You can see, I'm sorry, in this video, you can see how the inflow of saline passes through the endoscopic channel and exits through the working channel. But another important feature in the UVE technique is that UVE technique is performed through a posterior approaches. One of them is the paramedian approach. In the paramedian approach, you work in a triangle. This space is medial to the multifidus muscle. Here, you can approach the spine with minimal muscle damage. Here is the epiperiosteal space. You have to keep in mind when you perform an endoscopic spinal surgery through this technique. The posterior paramedian approach to the lumbar spine addressed most of the central and lateral pathologies. There are more lateral approaches to reach the foraminal area, or extraforaminal approach called the paraspinal approach. But however, most of the discernation and central subarticular stenosis can be treated by this approach. The paramedian approach here, the surgeon addressed with the vertex angle, with the vertex triangle, the spinolaminar junction. Since there, the surgeons can reach the interlaminar space, the ipsilateral subarticular zone. You can reach the contralateral side. And here, this is a picture that is taken immediately after the initiated the approach, that you can see how the spinous process is, the base of the spinous process and the laminospinous process junction. Also, through the paramedian approach, the contralateral side can be reached. We have two ways to do it. The first one is through the sublaminar approach, and the other one is the translaminar approach. In these pictures, you can observe the progressive steps. How can I get the contralateral side through a sublaminar approach? This is the paramedian approach. And also, the other approach is the paraspinal. The foraminal and extraforaminal pathology can be reached through this. The isthmus, lateral SIP, the proximal part of the superior or inferior transverse process are some of the bone landmarks to guide the approach, the paraspinal approach. Here in the pics, you can see common foraminal approach to transforaminal fusion through this biportal technique. In the intraoperative pictures, you can see the SIP, and after drilling the SIP, you can observe how we can reach more medial aspect of the spine through this paraspinal approach. But we have to define if the UVE really is a true minimal invasive procedure. In Singapore in 2018, a group of experts defined specific points that conforms the true minimal invasive procedure. That points are technology-dependent techniques, less tissue damage, less systemic surgical stress, and return to work activities earlier. When we talk about UVE, we need to know about the problems that could be solved by this technique. Discectomy is one of them, and different articles have reported acceptable outcomes in comparison of UVE versus microdiscectomy. They highlighted points like similar operative time, lesser estimated blood loss, and shorter hospital stays in the UVE patients. However, clinical outcomes are similar, different only in the back postoperative score, which favors UVE. I show you an example of a 32-year-old female here in the superior panel with discernation in L5-S1 lumbar segment. The postoperative MRI at the 12 months shows good clinical results. Here in the video, we summarize the steps to perform the discectomy. We perform a small laminotomy, and then we detach the cranial insertion of the ligamentum flavum. After, finally, we have control of the subarticular zone where the discernation is. And then we perform the discectomy as usually performed in open surgery, microsurgery also. We try to damage minimum the annular ligament to avoid reherniation. And then we have to observe, finally, the neural elements free. We have total control of the neural elements with this technique. Another degenerative condition addressed by the UBE is the lumbar spinal stenosis, but many articles have focused on this topic. Here, the authors found that dural expansion after decompression was similar in the UBE and microsurgical technique, but the only aspect that is different compared with microsurgery also is the back postoperative score. In this slide, I show you the case of a 67-year-old male with two stenosis levels at L3, L4 here and L4, L5. That levels were decompressed successfully with the UBE technique. We used the ULBD UBE technique. We perform bilateral decompression through a unilateral approach. And here in the demonstrative video, we summarize also the process. We perform laminotomy, ipsilateral laminotomy. Then we perform the drilling of the base of the spinal process because it's blocking to pass the contralateral side, and through a sublaminar approach, we can reach the superior aspect of the SIP medially. And then after reach the cranial insertion of the ligamentum flavum, we can start to the flavectomy. We use always the flavum as a protector of the neural elements. You can see in the video how the neural elements get released after decompression. We perform the contralateral side decompression. And then we observe finally both neural elements, both sides decompressed. Recently, different ways to assist the lumbar fusion procedures with endoscopy have been reported in uniportal techniques and then also in biportal techniques. However, through the UBE, through the biportal technique, it is possible not only assist the process of fusion, we can observe all the process and hold the process of fusion during the surgery. The endoscope lets the surgeon decompress the nerves directly, prepare the end plates properly, put the graft and the interbody device properly also. Here, the authors have highlighted, for example, reduced bleeding, complications, postoperative pain, extensive bone decompression, end plate preparation regarding the use of the UBE transforaminal lumbar fusion. In this case, a 52-year-old female with a spondy grade 2 underwent a UBE transforaminal fusion. Direct decompression was reached at the final of the procedure. And if you see the video, you have total control of the anatomical elements. You can see the traversing nerves, and then you can work exactly the Cummings triangle. Here is the exiting nerve, here is the traversing nerve, this is the disc, this is the patella. Then we perform whole discectomy. We use different raspers. Also, we use different curettes to prepare properly the end plates. You can see the end plates correctly prepared. Then the fusion is like open surgery. We use different tips to measure the height of the intervertebral space. We put the graft, we put the cage, always under direct visualization to take care of the neural elements. So many articles have addressed also another point. For example, short learning curve is needed to perform the UBE technique. The changes, the muscles, the multifidus muscles can be, but the changes are reversible. I think other person is talking. I'm sorry. And also, so the UBE, you have rapid recovery after the procedure. As a conclusion, discectomy, neural decompression, and lumbar spine stenosis, and recently endoscopic lumbar fusion are the UBE technique's scope. The related advantages are all of those associated with minimal invasive procedures, in addition to clear visualization and high accuracy. The learning curve for conventional procedures can be short but requires repetition, but the UBE procedure is a technique that is slowly emerging as another option in the full endoscopy portfolio. Thank you very much.
Sorry.
Malcolm,
yeah. Javier, a wonderful presentation by you. Excellently demonstrated. Covered all the basic aspects of UB and also demonstrated a little bit about fusion and plate preparations. So fantastic talk all in all. Really appreciate what you've been doing and really appreciate my master for having taught you so well. So all in all, fantastic. I'm requesting Dr. Dan Hansen to come on and please start sharing his screen. We are waiting for a wonderful talk from him on thoracic and microdiscectomy endoscopic. So Dan, welcome aboard.
Hello, can you hear me?
Yeah, we can hear you. It's early morning in America, so welcome.
All right, thank you everybody for getting together and for giving me the time, and also thank you to Malcolm and everybody who's taught me. So when I approached this particular topic and learning this particular technique, my interest, like many of us, is trying to find a better way to take care of people that have thoracic disc herniations for many reasons. So as I engaged in minimally invasive techniques and endoscopic surgery, this became important for me to learn how to do it. There are several different ways to learn it, but learning from other people's experiences typically is the best way to go. So part of this is going to involve understanding the anatomy that we're going to be approaching, but the technique is actually quite simple as we move along. But it's also important to avoid the risks associated with anything that we do, of course. So in the past, many people have done a variety of different approaches to get into the canal, including a traditional posterior or doing a costotransverse. And then of course you have going anterior through the chest. And each of these have various pitfalls that go along with them. And in my early experience back in the early 2000s, the way that I was taught to take care of a thoracic disc herniation is going through the chest, taking out a rib, and finally doing a fusion after you remove the entire disc space. The problem that I encountered was that you're trading one problem for the other. The patient is now doing better in regards to the neurological status, but you've now created a lot of pain because of having to split the muscle groups and take out a rib and these types of things just to get down there. So I said to myself, there has to be a better way to do this. This is your typical costotransverse approach for getting there. Chest tubes, everything that's involved in doing this. There's a lot of morbidity associated with that. So when we approach the spine from a endoscopic standpoint, what we're dealing with is the rib head coming in and attaching to the transverse process on the side of the vertebral body and trying to get at the disc space as the nerve is sliding out and traveling underneath the rib. So what you'll end up wanting to picture is using your standard transforaminal technique of placing a needle down into the area where the disc space is. And there are some importances about where you're trying to dock your needle, but some of the tools that you're going to want to have available when you're doing this is not only an 18-gauge spinal needle, and a 6-inch 18-gauge spinal needle probably would be adequate, but also different types of stouter needles. We call them Jamshidi needles, but it's like a bone biopsy needle so that you can tap it through the rib head if you need to get to the target of the disc space. So generally, this is the approach. As if you look at the left-sided slide, when you look at the CT scan or the MRI, whichever one you have on the patient, you can calculate out from midline and then take into consideration where the rib head, because you're going to be dorsal or posterior to the rib head and not anterior, obviously, because that's where the lungs and the chest cavity is. And there's no point in going there. But in order to attach the needle and dock it to the disc space, if you also appreciate the fact that the disc isn't kind of a roundish oval type structure like it is in the lumbar spine, it actually has a scooped out anterior portion in the midline of the disc space. So that's one thing. The other thing is that sometimes the cord can be a bit more farther off to the lateral side. So when you dock your needle, you really want to be in the lateral 1/3 of the pedicle as you're looking at your AP views. So that is the quote safe zone to enter this. So after patients undergone conservative treatment, we find different surgical indications. And the people that I've run into that have thoracic disc herniations, they don't always have a radiculopathy. Sometimes they have midline back pain. Sometimes it is associated with radiculopathy. And then you also can get the people that have myelopathic symptoms and things of that sort. So generally speaking, we're going to use our standard endoscopic equipment, C-arm. I like to do this awake so that I know if the patient is having any type of neurologic complication. The fact that they're awake, if they cough while you're placing your needle, then you possibly have entered the chest cavity and you're irritated the pleura. And in that case, you're going to want to make sure they don't have a pneumothorax afterwards. So just like using neuromonitoring with a person awake in the lumbar spine, it's also important to do it that way in the thoracic spine. Some of the different tools I found useful to have, having either a diamond tip drill or a carbide drill is important, but also some type of reamer being available can also make the procedure easier if you get into any of the rib head or what have you. And then otherwise, the standard scope equipment is going to be used. So normally the distance from midline is going to be right around 5 to 6 centimeters. And if the pane in which the red lines are located, you can see that the red line attaching to the disc space is along the lateral aspect of the disc space and posterior to the rib head. That would be an adequate area to get into. The cross section of the anatomy on the far right side, you can see a green arrow and the yellow arrows. The yellow arrows, I recommend trying to stay away from that type of entry point. It seems as though it would make sense to be as close to where the action is, I guess, with a disc herniation or some type of compression. But because we don't know where the cord is, it's safer to start out farther lateral and then work your way medial. So generally speaking, sometimes some drilling has to occur and removal of the rib head or some osteophytes, and also open up the foramen. Those things are all pretty standard in regards to the transforaminal approach, so that we can enter the canal and get down to where the cord is, and then also the space underneath the cord, which is where the disc herniation is. And just like in the lumbar spine, normal pulsatile flow is going to be our goal, not just visualization of seeing that the cord and the neurologic structures are decompressed, but also seeing pulsatile flow and movement. We've got a glitch. I have talked to other people that have done this, and some people like to use neuromonitoring, but again, I don't think that's necessary. Having a person awake is adequate for that. So it depends on people's comfort level, but I don't use neuromonitoring for mine. My typical postoperative care is to make sure they don't have a pneumothorax, and you can generally rule that out if they don't have any shortness of breath and their oxygenation and pulse ox has normal values of greater than 90. But if it's less than that, or they have any issues, then get an x-ray. They may need a chest tube, possibly not. But my general course of events is just like in a lumbar spine. The patient gets up, they're discharged to home. They may or may not need narcotic medications. And of course, you want to restrict your lifting and rotation for 6 weeks, because if it was a disc herniation, you don't want to have a recurrent disc herniation occur. And then just as far as avoiding complications, it's easier to do, I think, if a person is awake when they're having the surgery done and not a general anesthetic. And one of the problems I've had with thoracic spine is that some people do have a very well developed 12th rib. And so therefore, it's very easy to count up from the 12th rib, but it is possible to have an interventional radiologist place a small bead of tantalum or something like that in the level where you want to go, so you can identify and have a defined starting point to do the surgery, so you're at the correct level. I haven't had to do that yet, but that is always an option. Otherwise, other than endoscopic complication with the pneumothorax, there's not many other ways to have a really bad pitfall with this particular procedure. And the benefits definitely outweigh the negatives when it comes to all these other types of approaches that are out there and the morbidity associated with that type of procedure. Multiple studies have been done looking at the different types of outcomes in regards to pain relief, good versus excellent types of outcomes. And generally, there are always greater than 50% excellent outcomes in these studies. And the good to excellent results usually equal 80 to 90% of the patients having the surgery done. Thank you. Any questions?
Dan, a wonderful presentation by you. Two things I will really agree about you. One was the green corridor, which you pointed out, rather than the yellow corridor. I thoroughly agree with you. Going very close to the dura is not of prima facie importance when dealing with a thoracic disc. First get in and then work closer and closer to the thoracic cord. That is a perfect way of understanding the thoracic disc. And overall, excellent presentation. No other comments to make. Kavi, would you like to speak something on this?
Yes, Dan, I agree with you that in case of thoracic herniations, messing up with the exact level is one of the surgeon-oriented problems, which I think one can overcome by doing a discogram. You can just inject a dye and then you can count the levels, so that can also make your life easy. Otherwise, it was a wonderful presentation and great. Congratulations.
I think we are waiting for Dr. Adam. Is he there with us?
Yes, thank you, sir.
Dr. Adam, welcome. Welcome from Indonesia.
Yes, thank you, Dr. Malcolm Pestondi, sir. Thank you, everyone. My name is Adam. Yes. Please, I'm going to share screen, sir. Can you see my screen?
Yes, wonderful.
Yes.
Please make it large.
Okay, sir. PLT, transforaminal result of first 50 cases. This is endoscopic fellowship experience in Mahatma Gandhi Mission Hospital in Navi, Mumbai. It's just last year. I am a young spine surgeon. I am beginner here. I started just 50 cases for the PLT transforaminal. So for a beginner here, it is okay to start a surgery on endoscopic spine. I think most of the beginner, if we see the presentation from the master, we feel like a small guys, but it is okay that we can start from beginning. This is my teacher and my I have a spine consultant in Universitas Indonesia and from Gajah Mada University. I have spine fellowship at the SNUH South Korea 2006-17 and endoscopic spine fellowship. And this is all my assistant, Dr. Francisco Kani, Dr. Skore, Dr. Makom, Dr. Kang Taek Lim, Dr. Lutfi Katam, Dr. Harmantia, and Dr. Icap. And also this is my Dr. Saifal and Dr. Nilesh. Okay. Sorry. Just glitch here. So this is a low back pain. Sorry. There's a problem in my computer.
Take your time, be gentle. We are not in a hurry.
Okay. There is a low back pain. I cannot go in a screen because there is error. So I go with this mode.
No problem.
So what is low back pain? We have a 80% normal population experience low back pain during their lifetime. Pain may persist for 6 weeks and major impact to socioeconomic condition. I'm going to tell this to my fellow here that not all the cases we have a bulging disc or herniated disc should undergo for endoscopic surgery. We have to select all the patient. And the lumbar disc herniation, it is a basic sciences that we have to treat the patient from the non-interventional or conservative phase first. So if I already operated approximately 50 cases, it means that it is only 10%. So I already treated more than 500 patients. Which one is getting better with bed rest and SIT and muscle relaxation. But if the 10% is not getting well, we can do interventional. For interventional, there are types presented before. We have a laminectomy, discectomy, and also yes system, thesis system, interlaminar approach, foraminoscopic approach, and it is stated by Kim et al. At 2011 and Testandu at 2002, and then now we are facing a PELD, and from Kondo et al. It is the laminectomy and partial fascectomy will lead to post-operative instability, will need fusion, and transdural approach has an invasive and lengthy operation. It is cause more complication. So we are moving toward the new technology called PLD, which from the literature it is getting spread and more studies from the 2016. There are 3 types of PLD. There are operative, interlaminar, transforaminal, and posterolateral. This is the study that inspired me to do the report. This is by Kandila Mahesa. This is the result of first 100 cases. I am a half of it. I just do the 50 cases. From the study, we can learn that the age of the problem of the prolapse intervertebral disc is approximately age of 40 years old, with range of 15 to 84, a male more than female, and most of them at the level like 50 L45 and L5S1. And operative duration, it is 3 hours to 15 minutes. In my experience, I start with 3 hours also, and getting shorter when I did more cases. And I didn't believe at time that I believe that transforaminal can do all the kind of cases, but until my 50 cases, I have to convert also to interlaminar and also combination. So there is no one technique that's superior to all approach. We have to master all of the approach of the endoscopic, and duration of hospitalization is 1.6 days and recurrence of 2 patients. The fast score is reducing from 8 to 1, and we can see the McNabb criteria is also good. The second journal that inspired us is simultaneous L45 transforaminal and L5S1 interlaminar percutaneous endoscopic lumbar discectomy. So even we in the hand of one as expert, sometimes we have to convert and do the other approach to tackle the problem. my teacher, Dr. Malcolm Pestonji, has always told me that do not make the patient in harm and risk the patient with your ego to do the kind of one approach, and you will end up with injured the patient. Primum non nocere, first do no harm to the patient. It is okay that we can say to the patient, sorry, because of my lack of experience, I cannot tackle you. I endanger your nerve, so I have to convert to open. So it is my cases, my experience also. From this journal, we can see that they use both transforaminal and interlaminar. And the third, there is a study also, comparison of percutaneous endoscopic lumbar discectomy and open lumbar surgery for adjacent segment degeneration. This study is telling us that in group A who underwent PLD and open lumbar surgery, we can see the operating time become 3 times higher and the blood loss is more. So the admission day is more. So actually the minimal invasive surgery, I think it is a must for young surgeon actually who have more time to learn. So it is not late to start. If you are from Indonesia or anyone else, I am okay to share my knowledge with you all. And this is the microendoscopic discectomy versus PELD from this study. It is stated that PLD more fluoroscopy time and more time, but the hemorrhage here, you can see the hemorrhage is less, and the post-operative bed stay is less, and also the total hospital stay. I mean, it is okay to master MED, but if you willing to study PELD, we can shorten the post-operative bed stay and also hemorrhage of the patients. And the significant pitfall of percutaneous endoscopic lumbar discectomy for last central lumbar disc herniation. Why I take this journal? Because when you start doing transforaminal, there will be problem in tackling large central lumbar disc herniation. I will show you my cases that I did problem in transforaminal in a large central lumbar disc. So I have to add interlaminar approach also. And this is a percutaneous endoscopic lumbar discectomy for lumbar disc herniation SD surgery, a short-term clinical result of 235 consecutive cases. This is from China. As in this study, you can see the PELD, which is group A and group D, is almost same. I mean, this study is whether you need to make the patient as inpatient or the one-day surgery. So there is no significant difference. So for new beginner in doing transforaminal, it is okay to admit the patient a day in a surgery. We do not need to make the patient inpatient before a day before the surgery. Effect time of first ambulation on recurrence of PLD. The journal is from China. This is a good journal. As we see, the group E, M, and L. E is means early, M middle, and L is late. I mean, E early is 3 to 24 hours after surgery mobilization, and middle is we have a 1-day bed rest and 2-3-day bed rest, and the group late is 3-day to 7-day bed rest before mobilization. And the result is when the leg pain is almost the same, but the back pain it is increases in the early group. So it is better to make the patient has a bed rest for approximately 24 hours to prevent back pain due to early mobilization. And this is the journal. So we should make the patient little patient to do for ambulation. In my cases, this is my logbook of the fellowship endoscopic and Mahatma Gandhi mission. Thanks to Dr. Malcolm Pestonji sir and Dr. Satish Chandra Kure for teaching me. This is the case. This is all treated by PELD. This is just 43 here, but it is combined with operation in my hospital also. We have more 7 cases, but I not included here. This is the sample, the case, the female 39 years old with chronic back pain and sleep disturbances. In a traditional treatment, we just treat this patient with this condition. This is a chronic non-healing annular tear with a conservative treatment. But if we put the scope inside here and we take a view with the scope, we can see that there is an annular tear here and the trap fragment from the disc that irritate the dural. So it caused the patient to be radiculopathy. And if we treat the patient, if we do or treat the patient with open surgery, maybe we can treat this, but the collateral damage caused by our approach is getting more. So maybe we can reduce the leg pain, but the back pain become even more. This is the procedure of discogram before I'm doing transforaminal. I always do this kind of procedure in my patient, and I treat also with sometimes I give a intradiscal steroid injection. And this is the second case, male 53 years old, radicular pain to the right leg, unresponsive to conservative treatment for 6 months. This is the fragment in the central, but it is not large, it is grade 1 because it is not more than the facet joint. So I usually draw in the MRI of the patient with my spidol or my pen, and I draw the centimeter because I am afraid of getting penetrate the peritoneum, or sometimes in the high level L2 or L3 I will penetrate the kidney. So I always draw this to measure. I never use 8 centimeters, 9 centimeters, 10 centimeters to the every level. I always measure every single patient. This is the central prolapse of the L45, and you can see here I always draw this to see that my needle should land posterior to the vertebral body. It is okay. I will not penetrate the dura because there is a protrusion of the disc. So if I put here posterior to the vertebral body, I still touch the disc. And this is the procedure. You can see my working channel here. I am putting here, it is outside in technique. I put here and I try to drill the facet to make foraminoplasty, to make access, so I can pick the disc herniation. And this I use drill. I use intramedular drill for ortho. I am still an ortho surgeon, so I still do trauma case. So I do intramedullary reamer, and I drill here to the foramen to the patient. You can see in my hospital, this is rural hospital, so no complete equipment here, so we have to try to use other instrument. And as you can see here, this is the final picture of the clearance. I can clear everything here, and this is half in, half out. I can clear the dura, epidural here. Under there is no fragment here, and the annulus. My teacher always told me that I should not clear all the annulus, so I can let the annulus to heal, not to take everything. I just do this surgery and local anesthesia and ask for the clinical sign or the complaint of the patient. If the patient said, doctor, my radicular pain is gone, so I stop the surgery. Sometimes I left some annulus here, not to cut everything, because I let the annulus to heal, and I will not make more instability here. And as you can see here, my CRISPR can open and bite everything here. This is after TELD transforaminal approach, and this is the final pictures. See, okay. Sorry, my record video is broken in my hospital, so I have to record with my my phone. And this is the patient, the third patient, this 26 patient with chronic back pain, radicular pain during walking. You can see the straight leg raising of the left. He tried to inhibit it because of pain. And you can see this is before surgery. He cannot walk without painkiller. So even I give tramadol and ketorolac, he still felt pain. And so he saw him the radiating pain. And this is the X-ray. You can see a postural scoliosis due to pain. And this is a large central prolapse disc. And this is the slightly left side. This is the prolapse disc. And this is the position we make in our hospital here. And this is a line marking. I do this line marking by in the YouTube how to draw it. There is a first line, second line, and third line, and fourth line. And I always did. I always do a discogram for this, and then I put the disc and try to land 25% in the posterior. And then this is the picture. I put also methylene, but make sure not to push to insert the dura because it will cause a paraplegia. And this is the process that I grasp everything out, but and this is the clearance. I take the fragment here, and you can see here. I clear the disc, and this is the final pictures. After I can see the nerve is can pulsate like this, I stop the surgery, and the patient said that, doctor, I have no pain, no radiculopathy. My radicular pain is gone. I stop the surgery. I'm going to show you this bleeding. This is the only bleeding. So the bleeding of this procedure is very minimum. And this is the 1 day after the surgery. The SLR of the left and the right side, no inhibition. The patient can walk freely and happy. And this is the MRI pre-op PLD. I will compare to you that this is pre-op. My teacher said always do MRI post-op to evaluate whether how is your technique, it is improved or not. We cannot deny or state to the patient that we already operate you and we are success, but we have to evaluate ourselves. As you can see here, I successfully take the large disc here and here, and as you can see, there is still some fragment here, but since the patient it's okay, I do not clear everything here because I'm afraid it will create instability. As you can see also here, the L45 disc is already black disc. So if I take more disc here, it will create more instability to this kind of patient, since this patient is only 26 years old. Is this the last case, the fourth case? Sorry, sir, I ask for more injury time, sir. This is the prolapse IV disc, lumbar 4-5, and I did a transforaminal approach here. Here I was afraid that I injured this. I thought this is a tracing root. Maybe it is a root injury, but there is no tingling or radiating pain after the procedure. So I'm going to show you that even a good surgeon, our master may make a mistake. But in this patient, I think this is only a vessel because not nerve. So sometimes we do something that can injure to the patient. So this is the last picture I will show you. This I will always clear like this. I will not clear all the disc inside here, so because I think I will injure and cause more instability. As long as the patient has a pain-free and the patient is satisfied, I stop the surgery. Okay, this is the procedure. This is the procedure that I'm doing also interlaminar PSLD because I feel that I cannot clear the disc. So I proceed, I convert to the PSLD also. Here I do interlaminar. Interlaminar procedure is almost same. We open the flavum and then we clear everything until we can see the pulsating dura. And see, as you can see here, I do combine transforaminal and interlaminar. It is in the 40 for this case of my transforaminal, I have to combine both of them. And this is the result of pre-PLD and post-PLD. As you can see, the pre-PLD, you can see the prolapse disc in the central and the foraminal here. And 3 months post-PLD, the fragment is gone. You can see it. And here. So this patient has a pain relief at all condition. I mean, there is no complaint at all. So this is the pre and post 3 month post PSLD, PELD, I'm sorry. Okay, and this is my study. We still collecting the case. My operative duration, I'm going to tell you the truth that I'm still doing in 2 hours because I'm still new beginner, and most of them I do transforaminal, and I just did 1 case of combination of transforaminal and interlaminar. Take home message for beginner: endoscopic surgery have a steep learning curve. There is no one do it all method. I mean, transforaminal, interlaminar, and combination. Learn from the endoscopic surgeon mentor will flatten the curve and keep on learning and improving yourself. Do not be discouraged from criticism and failure. Admit your failure. Never try to prove to anyone. You only need to prove it to yourself that you are competent. And this is my teacher who teach me a lot about endoscopic spine. When before I meet this guy, I even cannot put a scope. And now I can do 50 surgery. Thank you so much.
Adam, that was quite a long talk, but thank you so much. I think you're an encouragement to all newcomers. Your positivity, your attitude has always been very encouraging, and it has been my privilege to have been your teacher.
Yes, sir. Thank you so much, sir.
Someday I hope to learn from you. That is the way it should be. Now, I think we have ended today's session. We had a wonderful session with Javier, Dan, Tamer, Tariq, Sir, and Adam. Unfortunately, we missed out on Dr. Christoph Hofstetter because he had to attend another surgery. We will try and adjust him tomorrow. If any of you have any questions, please do ask them. Dr. Kavi, I would like your closing comments. And I would like to then say goodbye for today, and we meet tomorrow again at 11 o'clock India time to start our day 2. So Dr. Kavi, your closing statements, please.
Yeah, before we end up, I have one
Sorry.
small question for Dan.
We have Dr. Christopher with us now.
Yeah, has he joined us now? Then we would love to listen to him.
Yes.
It'll be an honor. Dr. Christopher,
Yes, I will upgrade him.
Dr. Christoph, are you there with us?
I will upgrade him. Give me 1 second.
Please do, please do. It'll be a pleasure to conclude with all our speakers.
Yeah, in the meantime, Dan, I wanted to ask you, what is the size of the endoscope you use for your thoracic disc surgery? The central channel.
Well, that's a good one. I've used 4.1 millimeter working channels, and I've also used some older scopes that have smaller than a 4 millimeter channel. Currently, my favorite scope has a 4.3 millimeter working channel. So I've found that the working channel is smaller than 4. It's difficult to get a drill down there. It's difficult to clear the bony fragments as you're working if this channel is too small. So I've migrated away from the 4.1 up to 4.3. If I could get a bigger one, like the 4.7, I'd probably go for it. But 4.3 is primarily what I use now.
And one more question. What is the highest level of thoracic disc you have removed?
Probably T6-7.
With the same scope?
Yeah.
That's fantastic. That's good. Because I've gone up till T5. I've not ventured beyond that. I had the privilege of seeing one of our colleagues from South America. He had done a T3 level. That was amazing. But then I think he used a cervical scope because at T3 it would not be possible to use a lumbar scope.
Yes.
Yeah.
Yeah.
Well, that's a good one. I've used 4.1 millimeter working channels, and I've also used some older scopes that have smaller than a 4 millimeter channel. Currently, my favorite scope has a 4.3 millimeter working channel. So I've found that the working channel is smaller than 4. It's difficult to get a drill down there. It's difficult to clear the bony fragments as you're working if this channel is too small. So I've migrated away from the 4.1 up to 4.3. If I could get a bigger one, like the 4.7, I'd probably go for it. But 4.3 is primarily what I use now.
Yes.
So I think T5, T6, fair enough. We can go with our lumbar scopes. This is definitely a message to all of our spine endoscopy enthusiasts that a regular scope, a regular transforaminal scope can be used up till the T3, T5, T6 levels. The foramens are quite large and the approach is a little steep. Again, I will reiterate what Dan had shown and marked as the green corridor. Please go back, check the recording on YouTube. That is the safest way to enter, definitely. Enter, manipulate, mobilize, reach the cord, but do it very slowly, gently. Do it under local anesthesia. You don't need neuromonitoring. And there's always the pleasure of getting a large thoracic disc out. So that was a wonderful part about it.
I think Dr. Christopher is here with us, so let's proceed
start
with
with
his
his talk.
Yeah.
Do you mind if can everybody hear me?
Yeah, we can hear you, but we'd like to see your screen share, sir.
Perfect. So the screen is coming here. And again, I apologize. I actually logged in when I was I listened to a couple of talks, really excellent talks that I would like to talking about the challenges and the new frontiers we see in full endoscopic spine surgery here. And again, thanks for including me, and sorry for the late disclosures. For this relevant, I do a lot of teaching for Troimax, and I also do a lot of teaching for the AO spine, which is not associated with Troimax. But that's my relevant. I'm sure this has been addressed earlier, but the big question is always, when you have new trainees why should you at all do this? I mean, new equipment, new technique. And I always find it astonishing that, the answers really with the traditional open surgeons here with Dr. Chapman, who is just an amazing, brilliant opens that what determines complications. And they looked at cardiac, pulmonary, GI, neurological, hematological, urological cost of laundry list.
We've lost your link, Dr. Hofstetter.
Am I back up?
Yes.
Can you guys see my screen now? Can
yes,
you see
but,
my screen?
but
Yeah, we can see you now.
Hello?
yes.
Yeah.
But sound is crackling.
I don't know what this is. Sound is not good. Yeah, I'm sorry. It's just
now it's good.
I have a very poor connection here. I apologize. This is not
Okay.
Not Let me just okay, so I think again, this is one of the main issues that I think needs to be addressed. And then the other thing is I think that is important is we wrote a paper last year, as we call it, the benefit zone of endoscopic spine surgery, where we look at what is the sweet spot of this technology. And certainly discectomy is a relatively low complexity procedure, and accordingly the additional benefit of lower complications of endoscopic spine surgery is there, but it's not it's not tremendously big. So, but it's like complication rates, as we know, all the outcomes should be very similar. But the complication rate goes roughly down by 3% if you look at all the randomized prospective controlled trials. And that changes quite dramatically when we look at now something that is more, complex. And there were a couple of talks. There were a couple of talks today on the agenda. When we look at, for example, an over-the-top decompression surgery, where with traditional surgery, we have 30% complications. Endoscopic, we have 9% complications. So there's going to be certain procedures where there's a tremendous potential. And I would almost say that, for example, a thoracic discectomy is right in the beef of this, right in the middle area. Because that's where you have the biggest bang for your buck. And so, but on the other hand, you also see that those, curves cross again. So there's going to be areas where we try to push the limit and really we don't give the patient any additional benefit. And the same has been true in MIS, where certain procedures have been done that really push it too far and there's no more benefit to the patient. But it's up to us to define that area where endoscopic spine surgery has clear benefits. And that gets me to the next sort of talk. What's really important to push the limits and to move along is having cutting edge technology. And I'll just show a couple of examples there. So as we talked about endoscopes, we talked about working channels right now, for the interlaminar approach. I totally agree. I think more than, less than 4 millimeters is too small. It's really difficult to do any meaningful work. For the transforaminal, 3.7 millimeters is on the smaller side, but you can accomplish a lot. And you can see I even have an example of a partial corpectomy that I would like to share afterwards. Drills are really important in that for bone removal, and there's different technologies and different companies making this. But learning how to do that and efficiently remove bone is a skill that everybody in this audience probably has mastered. And again, for the interlaminar technique, when I teach the residents and fellows, is really to follow that yellow ligament attachment that actually we made, the principal anatomical landmark for a reason. Is as long as you follow this attachment, you see it up here, you really don't get lost. The second you don't drill along that attachment, it's very difficult to be efficient. Navigation is another new thing that is coming out, and people have used different navigation systems. Now there's one, Germex has brought out a navigation system that is designed only for endoscopic stuff. And I think there's a tremendous role for that, in that, it's going, these systems are going to help us surgeons to remove, some of that radiation exposure that we all have. And as you know, there's papers floating around that the rate of cancer in spine surgeons is, almost, 10 to 15% higher than that of other surgeons. So I think that's even, though that's at the very beginning and it works, but it's something that all of us should be interested in to get ourselves out of the radiation, which we are constantly exposed. And I think once we have that more broadly implemented, I think it's going to help us to flatten the curve, the teaching curve, the learning curve. There have been some talks before talking about, how difficult it is to learn that and how long it takes. And I think having navigation and knowing exactly where you are all the time flattens that curve, and especially the radiation exposure. And again, everybody doing these procedures, I think we all have to kind of think about how we can improve that, because that's going to be not sustainable. It's really useful for posterior cervical foraminotomies, especially at the lower levels where it's very difficult to determine the level. For transforaminal approaches, and especially for the fusions, where you can then also use the navigation to put in pedicle screws. That is another frontier that is coming. I think the next big thing is going to be endoscopic fusions. And the issue with endoscopic fusions, it really needs a highly orchestrated array of instruments and devices. So you're going to need navigation. You need to do a very nice foraminotomy, foraminoplasty, the discectomy, and then innovative graft design. And there's some new challenges and new sort of developments there, especially the 3-dimensional expandable cages that look very promising. Also the two portal systems I think are very interesting. So I think there's some technology coming there that I have no doubt that in 5 to 10 years, we'll be able to compare those favorably with MIS TLIFs. It's right now just at the breaking point. So I do maybe like 20 a year when there's really no other, when I can't do an MIS TLIF, but it's certainly technically possible, as you can see there. And then those little things, I have to, we did this little, in the Joymax set, we have designed this little plastic holder. It's blue, and it looks very silly. But this thing helps you to get your hand out of the C-arm. You know, you can hold all the dilators and nobody knows what it's for. So this is the lowest low-tech thing in the world. You could probably print it yourself in your shop or make it out of a piece of a stick. It can hold the dilators during the whole procedure, but it helps you to get your hand out of the beam. And nobody knows what it is for. So that's why I put it on there. It's really low tech, cheap, and it helps. And again, it's a really very little brilliant sort of little thing. Then obviously you want to have a tower and the different systems, that have complete systems. And again, I work with different systems. I work with Wolf and with Joymax. They have really sort of pushed it forward. But again, enough of different company stuff. One other thing that we have worked on is the nomenclature of surgical procedures, and I would like to invite you to really utilize that. I've had the great honor to work with the best experts worldwide, and you can see the author list there. And we designed, and some of them I think I saw on the list here too. So thanks everyone who contributed. During a year of back and forward, we designed an AOS, as an AO, we call it the AO spine, a consensus paper on nomenclature. We looked at the approach, the instrument, the location, and the procedure, and designed this nomenclature system. And you can see here the whole list that is throughout. The nice thing is, as long as we reference to this, is that you can now find your work, because as you see, if you're looking for a paper on, for example, transforaminal discectomy, you're not going to find it. People call it TELD, people call it whatever they call it. And I called it differently too. I mean, a lot of people say that, I used to call it like this. Well, I have papers too that I called it differently, but I think at some point we have to agree on one way to call it. And I would everybody encourage to use this new nomenclature system, because then people can find your work. If you do good papers and publish them and you don't use a nomenclature system that we agree upon, nobody's going to reference and honor your work. So again, 28 experts worldwide, and this is what we came out. So again, thanks everyone for helping with this. I think this is going to really put our field on much stronger legs. And then two, I don't want to take too much of your time. Then I have two examples I think that sort of really show the new frontiers and where endoscopic spine surgery is really hitting the biggest area of this benefit zone. One of this is what we call the endoscopic, cervical endoscopic unilateral laminotomy for decompression. And again, we have I've published a book on that, and during that work, really that principle of target area and principal anatomical landmark came very clear at the end of working on this for a year. A target area is a bone area, like a structure on the bone that you can see on the X-ray, that you can palpate with your needle or with your trocar, and that you can visualize. That is nothing that has anything to do with if anybody sort of pushing down the throat, any procedures or anything else. But as you can see, next time you do your procedure, you will have a target area that you can see in the X-ray, that you can feel, and that you can visualize. And then the principal anatomical landmark, for example, for this procedure is the L ligament attachment, because it guides you safely towards the neural structures. Everybody uses that. It's just, for me, there was a revelation to kind of use this now for teaching. And you can see when you're standing behind a fellow and they're kind of totally lost, you're like, what are you doing in the middle of the spinous process space? That's typically where you get lost into lamina. And then, so that's typically how you can get them back. Quick here, we've sure seen that. So that's kind of the target area for our approaches, is the edges of the lamina and the cervical work. Because you can see it easily, you can see it on X-ray. Then we do the bone work along the attachment of the L ligament, as you can see there. Here's the lamina, and the L ligament attachment is right there. Hemilaminotomy. One thing in the cervical spine, when you do complete decompressions, there is not in the lumbar spine, you can get away with taking not as much from the base of the spinal process. In the cervical spine, you do have to be very generous undercutting the spinal process. In particular, in very severe stenosis cases, you cannot expose any pressure onto the spinal cord. You will have monitoring changes very quickly. And then you do the contralateral decompression. So that's a thing. And where is this useful? Well, here's an 84-year-old male, sick as an 84-year-old with lung cancer, other comorbidities, and he complained about unsteadiness and loss of dexterity. So maybe he couldn't use his hands anymore. And you can see what you can see on the X-rays there. I mean, this guy obviously has a thoracic kyphosis that he then corrects with hyperlordosis in his neck. So he has to lift up his neck in order to see something, and that causes then buckling of the ligament. In a patient like that, obviously you would be insane to think about a deformity correction. He would have a peg and he would have complications. And that for me is the ideal patient where you make a gigantic difference for that. I just saw yesterday a patient like that too, that I'm not fixing her lumbar spine. She's also 80 plus. And these patients are not super happy, but because, the neck pain and the discomfort is still there, but the myelopathy disappears. And so here's a postoperative image. And one thing that really surprised me, how much space you generate. So we did a C2, C3, and C3, C4 decompression. You can see in the right lower panel here how much CSF you have around the spinal cord. And so the space that you create with this is tremendous anyhow. But I just want to point out one more time, you really can only use this when you have pathology from the back. So if somebody's straight or kyphotic and the main pathology is in the front, this is not going to help you, obviously. But a great procedure, and what a great way to help patients that really need help. And again, we had a talk right now before the thoracic discectomy, so I don't want to hammer that home. Again, same thing here, thoracic discectomy. We'll use the caudal SAP as a target area. Again, this is where we land with our Jamshini needle. The pedicle helps us to be oriented and avoids to do a lot of unnecessary X-rays. And you can see here the pedicle that you see during the procedure. And so here's the pedicle, here's the dura, here's the disc. And typically, again, I call it the Turi shot because in the US we have a lot of medical legal litigation. So every transforaminal case for me, I put up the kerosene onto the pedicle, onto the caudal pedicle. What it does is it orients you in all three dimensions, because there's no way you can be off it. Once you have seen a pedicle, you know where ventral is, dorsal, medial, lateral. It really is a solid anchor. It can do the discectomy. And then this is a case I wanted to present to you, last case, and I'm almost done here. Again, thank you for being so flexible. So here, this is the cases that, nobody wants to see because they're complex and they are, that's not something you want to see in your private practice. But I have the university, that's what I see. So 45-year-old, morbidly obese, BMI of 60, ankylosing spondylitis. Here you can see her standing in my office, the sweetest, nicest lady ever. And you can see on a t-shirt, she's dripping CSF out of her back. She has had a T11L1 arthrodesis, an open decompression at the outside hospital. Patient developed a non-union chronic CSF leak. And had multiple revisions. She had like 4 or 5 revisions by plastic surgeons trying to kind of take care of this wound that was leaping CSF. No success with that. She had low extremity pain at 8 out of 10, was severely disabled with an ODI of 50. As you can see, a kyphotic posture, only able to stand with assistance. So she's holding on there. I think she needs a walker to ambulate. However, her strength at that point was intact, and she had a sensory level at that level. And so you can see on the imaging, so she has totally she has basically a Charcot joint there, large osteophytes, the pedicles are gigantic, and there's very, very little space for the spinal cord given those severe degenerative changes. And so in her, so we did a transforaminal discectomy, right partial T12 corpectomy. So we really removed a large part of the T12 pedicle. And again, I agree that doing this via 3.7 millimeters is obviously challenging and takes time. But here's some of the bone removal that I just wanted to show. And one thing that you can see here is here's the ventral osteophyte here. The spinal cord starts here. Interestingly, and not unexpectedly, there was a large dural defect that kept the leak open. We found the leaflet of the dura, and you can see that. So that's all open. Here's the dural sleeve. And all this, the dura is gone. So you're looking at spinal cord itself here right now. And so we are removing part of the T12 vertebral body for the corpectomy. And you can see, so this is really almost like intradural sort of work here. So again, spinal cord is there. The dura stops here. Again, from this Charcot joint, it's just totally eroded. And you can see here nerve roots and everything. And so we close it typically with a piece of Duragen, and you can see here, so putting a piece of Duragen in there, but people use different stuff, so I don't want to, there's different ways to, secure that, so you put that in there. This is a little technique that I like to do, is you guys see the needle coming in on the side. I like to use the irrigation channel as my second hand for these closures. And I take a K-wire and you go through the irrigation channel, and then you can stabilize something, and basically it allows you to do manual work. And typically when you have to do something like that, I use, again, here's in the irrigation channel, we have a K-wire coming through, and you can stabilize the piece of foam, Duragen, hold it there in place with that, and now we come down there and we secure it with some glue. So now we come back in here and put some glue in there, and secure that repair. This is the imaging afterwards. So you see preoperative, you can see all the osteophytes and that were resected there on the CT scan. You can see it nicely there. And then you can see that we resected the pedicle there and the part of the vertebral body. So we did extensive bone work, combined it with an endoscopic T-lift. So we put a graft in there endoscopically. That was not without complications. So this patient developed a pneumothorax, which I never had with a thoracic disc. So that's maybe something for everybody who's doing thoracic cases. I don't know, it was because of the Charcot joint and everything was communicating, but she developed a pneumothorax, so she needed a chest tube. She did have some issues with her strength, so she has like a 3 out of 5, but she's now able to stand and ambulate again. Her CSF leak subsided, and she was able to successfully go home, and we combined it obviously with posterolateral instrumentation. Again, a very difficult case with no perfect outcome, but I think the endoscopic technique really helps with these very, very complicated patients to offer them treatment. And that brings me to the conclusions. I think the technology for full endoscopic spine surgery is rapidly evolving, as we've seen in other talks too. There's a lot of good people and brilliant surgeon, working in this field and making it better. I hope that the common nomenclature system that we worked for over a year on is going to be used and helps us to put this field on a stronger foundation. Again, it's going to be resulting in more literature and better science and a faster development if we can all talk the same language. And again, it's same for me. I've 10, 15 papers that I didn't use that same nomenclature system, but I think we have to move along and sort of make those updates. The procedural protocols that we developed, the AO, I think they help us to standardize surgical techniques, and full endoscopic approaches now with those modern tools allow for safe and efficient decompression surgeries of the entire spine. And I think future advances of tools is going to be navigation or any other technology that helps us to get the CM out of the OR. The fusion surgeries, I think, which will be the next big frontier. And that gets me to the last slide. Thank you so much for inviting me. I really, again, apologize for the time confusion, even though you provided this brilliant sheet of time zones. Somehow I got it wrong. And then here's, a lot of these things we were able to write up in a textbook that I think is very helpful to teach residents and fellows. So they typically bring it to their OR and it helps. So any suggestions also how to make this book better for us is very welcome. And here, if there's any questions, then I'm happy to answer them. Thank you so much.
Dr. Hofstetter, first of all, welcome. Wonderful lecture by you. I think two major take-homes from your lecture for all of us is the introduction of navigation in endoscopic spine surgery. So I think that definitely is going to help decrease the radiation exposure that an endoscopic spine surgeon goes through. And I think that's a wonderful innovation that we all should look forward to. The second major thing that is a take-home message for all of us is the common nomenclature that AO Spine is working upon introducing. It should help clear up a lot of air and definitely make research and publications much more organized. So you being part of that effort, thank you very much. We had a wonderful presentation by you. We really appreciated your presentation on the thoracic spine with the CSF leak. That was a very wonderful presentation by you. I think all in all, we've had a very good day with all the panelists. I wish to thank all the panelists who have been present with us. Dr. Sameh, thank you so much. You have been the tiger force, the person who has pushed me consistently in doing this job. And Dr. Anand, and I'd like to thank Dr. John Bennett also, Neurosurgical TV. I would like to end today's session and hope to see you all again tomorrow morning at 11 o'clock Indian Standard Time. We have some very, very beautiful presentations tomorrow. And I hope we have a good day tomorrow again. Dr. Hofstetter, pleasure having you with us once again. Thank you so much for being with us.
Yeah, no, thank you. What a great audience. Looking forward. I think everything is going to be online too, all the talks, right?
Dr. Anand Kavi, would you like to make some ending comments, please?
Yes, Dr. Hofstetter, wonderful presentation. I learned a very new thing of using the K-wire for stabilizing your duragen in that dural tear. It was a very genuine idea and I really liked that. Yes, it was
I'm sure you never need that.
Yeah, but you can always come across somebody else's case where you can use this technique to repair the dura without maximally invasive surgery. So today's day was wonderful. We had a great array of different types of endoscopic presentations in lumbar, cervical, as well as thoracic spine. And the big take-home message is, I would like to repeat what Adam said in his talk, that there is no single technique which is the foolproof and which can be used for all problems in spine. So one has to keep on learning all the techniques and use the technique which is ideal for that indication and which is best in your own hands. I would also like to thank all the participants to bear with us for last so many hours, right from 11 in the morning to 6 in the evening. So once again, it was a wonderful day. I thank all the panelists, all the presenters, all the participants, Dr. Sameh, Neurosurgical Society, Neurosurgical TV, Dr. Pestanji, and all of you, and wish you all a very happy and healthy life forward. Take care. Corona is still out there, and see you tomorrow morning. Thank you. Thank you.
Thank you so much, sir.
Dr. Sameh, one last few words from you.